with CN being more potent than CS, but CS having a potential problem for delayed onset pulmonary edema if there's been a sufficient exposure. This paper, actually, if you want to pull that, the British Medical Journal from 2009 is a review of a number of these different agents and talks about the time to onset and the duration of persistence or usual. Sometimes that can be a little bit longer, especially if it's in a closed space. So again, the name, right, chlorobenzylidine malonitrile. Well, that just rolls off the tongue, but chloro, right? So it's got chlorine in it. That's the important part. At the other end of the word is nitrile, and we didn't really talk about this, but nitrile products that's cyanide, that's CN. But this is not a source of cyanide exposure, right? It is a cyanide molecule in this compound, but it doesn't cause the harm. But you can see that if you just look at the name, people can carry away the wrong message. But when you say, what are people experiencing, then you're going to say, well, they're complaining about their eyes and they can't irritate. It's tear gas. After all, they're all irritated there. They can't see. In their nose and their throat, they're coughing. Maybe if they've got asthma, they're going to end up with more problems because now you've got a reactive airways condition that you've precipitated an exacerbation of. And there are people who are more at risk for some of these effects, as noted here. Contact lenses, that's an important one to remember. If people have contacts, those need to be taken out, and then the eyes irrigated to prevent any more long-term effects. So the environment, the nature of the exposure is also important in addition to the dose. And management, is pretty much, if it's been a gas that they're exposed to, they probably don't need much decontamination other than, actually no decontamination at all. If it's a vapor, they need to have their clothes removed, the external clothing at least, so that you don't have any trapped in the folds and whatnot that now contribute to secondary contamination. Wet decon is going to be needed for exposed surfaces like the eye, but may not be needed for the whole patient. And supportive care is important. Oh, and I guess we've just finished with this. So you already mentioned that the vesicants can cause pulmonary injury as well as skin and eye. And the best predictor, from my understanding, and we've been contracted to do a little bit of work to try and identify the risk of chronic effects following an acute exposure from a number of these agents, is the degree of symptomatic exposure to the eye and the extent of skin vesicles and blisters if they develop. But that can be so much moderated by the amount of clothing and protective gear that people are wearing. The eyes have become maybe the better predictor. But pulmonary and eye injury, delayed and progressive, especially eye injury, is related basically to what Ziad already mentioned in terms of the damage. So you're initiating damage immediately. But why is it that 15, 20 years later, people are developing significant keratopathy and corneal ulceration and things like that? And some of the reason for that is that some of that initial damage that's occurring is taking out stem cells. And if stem cells are not there to replenish, you're retiring and apoptotic cells as ongoing injury occurs over life, you're going to end up down the road with a less reserve, less ability to manage the daily issues. And those become now long-term effects of the acute exposure. And I think I'll end it with that. Right.
Thank you.
Thank you.
Any questions or comments from the participants before we break for lunch? Dr. Aaron. No, I think it happens with the chemical irritation that happens in the inflammation. You get the pneumothorax, and he had bilateral pneumothoraces and pneumodiastinum, and he had chest tubes and on the damage, I think, from the chemical damage to the tissues.
Okay, thanks.
Other questions? Masad?
Thank you. Because recently, as everybody knows that...
Can you please speak up?
Yeah. Recently, as we know that there's a lot of demonstrations in some of the countries, and there's a massive use of smoke grenades. So regarding the... tox, the tear gas, regarding the toxicology side of these smoke grenades. Anything as a physician, as a first responders need to be aware about, especially the smoke grenades?
Yeah, so most of those riot control agents delivered by, an explosive or under pressure release, then you end up with, ideally, these were developed and marketed not because they cause permanent injury or death, but because they cause an acute onset. And the table, CARRON paper from British Medical Journal is a good resource to go to compare them and contrast them. But within seconds onset, but within half an hour offset, right? So short-term irritant effects because they're very water-soluble compounds. But if you now deploy those across a population that includes, and a lot of the demonstrations you described, young children, mothers, the idea that if people go in mass to protest, nobody would hurt them, but maybe that isn't true. But now you're exposing populations that are not young military recruits, that the idea was that's where it's going to be deployed. So you can end up with people who have asthma. Well, they're going to potentially have persistent effects. Or people who just try and run away and hide or go off in a corner and stay in, if they especially drop down into an enclosed space, you're going to have a persistent exposure. And persistent exposure to an irritant can cause injury. So I think it's more that, not that the compounds themselves are inherently super toxic, they're not, but you can expose susceptible groups and the circumstances of exposure.
And Dr. Othong, who's actually now in snake inflammation, he taught me one lesson. In his hospital, was very close to the Prime Minister's location in Bangkok when there were demonstrations protesting his, presence in that office. They would come quickly to the emergency department. And before complete hydrolysis, so this is not a gas, it's powder, and it hydrolyzes rapidly. So if you get the victim quickly, or the responder is there quickly with the victim, there may be still ongoing hydrolysis and release of the irritant.
So there's secondary exposure, and we've seen that even with pepper spray. Is, people will come in, and if they come in quickly enough, and enough of them, you get a little irritated in the room. Right?
So
pepper sprays are way down here compared to CS and CN.
You have to do wet and dry. So the idea is you have to do dry decontamination is not enough potentially. You have to do wet decontamination, which is lacking in some places.
So while you're doing the wet decon, though, right, they may complain of more symptoms, but that doesn't mean stop. It means you need to do more. Like just if it's kind of like we're often asked on chemicals. Well, aren't there some chemicals you should not, wash with water? And it's like, well, technically yes, right. You should not take phosphorus, or you shouldn't take sodium and lithium as a metal and dab some water on it. But turning a fire hose onto somebody with a little bit of that on it is fine. But if you've been exposed to pounds of this stuff, maybe water shouldn't be used. So it's all a relative thing. Persistence in a given area versus removal of it rapidly.
Yeah.
Dr. Hamoudi.
Yeah, thanks a lot. In my country, many people exposed to this tear agent, many protests. And so many people ask me, my friends, are there any rule for the Pepsi can or baking soda to ameliorate the burning pain sensation? Scientifically speaking, I didn't find...
I don't think so.
So for inhalation of chlorine, sodium bicarbonate added into the nebulizer, if you've got people with persistent airway symptoms for that, there's case report data that suggests it works, and there's no reason to think it would harm people, so that's probably reasonable. Decontamination, if you're talking about things you can mix in with water or add or substitute, the problem there from my perspective is that anything you do that delays application of the water is going to increase the time of exposure. And so even though it might be that some things, like CN, for example, will hydrolyze better if its pH is up, 9 or so. But if you have to go hunt around for stuff and then get a basin from somewhere and then pour the water in and mix it, and it takes 10 minutes to do that, it would have been better just to put a lot of water on them 10 minutes ago. So that's how I'd answer that.
People who were exposed to tear gas in the last events in Iraq, they experienced Pepsi was very effective.
Which one?
And that may be
Pepsi?
So
Yeah.
that may be readily available.
That was a standard.
Were they drinking it?
Everybody had a bottle of Pepsi in his pocket. So it was effective, and they immediately washed their faces with
In
it.
Lebanon, they're using basal, onions.
Well, that's just to get the substance P up there.
And charcoal. Some people have been bringing charcoal to the demonstrations.
Everybody in the United States carries a bottle of water because we're all in imminent danger of dehydration all the time.
Bottle of water is okay, but
But if
now
you have
they
Pepsi-
found out that Pepsi was effective.
I think we're all in imminent danger of hypoglycemia and dehydration right now after a long morning. Thank you for our speakers and participants. Let's have lunch. Come back here to start at 1:15.
Dr. Wax. But just in case we merge seamlessly, I'll introduce him now. So Paul Wax is the executive director of the American College of Medical Toxicology, and he's a medical toxicologist out in Phoenix, and also with UT Southwestern, running the toxicology clinic and practicing there when he's there practically, it seems, every other month. So this is going to focus now on the cluster of neurologic symptoms, and again we'll try and keep that same format of a broad differential and some of the importance of not only the chemical compounds itself, but some of the other issues that can come up in the differential diagnosis, and then how to sort all those out. So if I could have the slide set.
Chuck, and it's been, again, a great meeting, and I thank Dr. Kazi for all the speaking opportunities that he's provided me as well. Hopefully you're not too tired of hearing me speak at this meeting. It's been a great meeting. I've learned a tremendous amount from everyone here, and the faculty is really to be commended. So we're going to shift gears from inhalational and pulmonary to neurologic, and what we decided to do is Dr. McKay was gracious enough to put together part of this opening talk. So I'll just go over the goals and objectives and turn it over to Chuck for a few of the first slides. But there's a large differential diagnosis when it comes to clusters with neurological complaints. I mean, the brain is so essential to our own being, and many, many things can affect the brain. So we're going to recognize that there are many components to someone that might present with some sort of nervous system perturbation. We're going to divide it into these toxic syndromes, as you'll see, and discuss sedation and convulsions and hallucinations, and go into that in some detail. But before we do that, we're going to discuss briefly radiation syndromes that may affect the brain, and also, very importantly, infectious disease processes that may affect the brain. So with that in mind, why don't we turn to the next slide, and Chuck, you can go over the next few slides if you'd like.
Sure. All right, so somewhat similar to the respiratory issues, although people would necessarily have a lot of concern about a radiation exposure, and people presenting from it because of their concerns about secondary contamination, or just the issues of dealing with a patient who's been exposed to radiation. It is very, very unlikely that anybody who's had a radiation exposure is going to come in with predominant CNS symptoms. And if you think about that, it sort of makes sense the way we think of radiation as interacting with our cells, is that cells that are very, very rapidly dividing, cells that are very active in terms of metabolic processes, are the cells that are more likely to be impacted by radiation. Now, I would hope that most of our brains are active, some of the time anyways, but the sensitivity of the CNS to radiation is not the same as, say, the GI tract or the bone marrow. I know Zia didn't really mention, but the most early measurement for a radiation effect in terms of some of the common tests we might be able to do, do you guys know what that would be? What blood test do we depend on for early evidence of a whole body radiation exposure? So lymphocyte, right? So you're looking for a depletion of the lymphocyte count. And if you think about lymphocytes, they are not an active, I mean, they do divide, but they're not the most actively dividing cell. They actually have a long residence time and circulatory time. But you think also of what the lymphocyte looks like, right? It's a cell that has 90+% of its volume taken up by the nucleus. So it is, with a radiation hit, it is much more likely that that cell is going to be impacted in its nuclear content and therefore have an impairment in its function than a cell where the DNA is all tightly wrapped together within the nucleus, and you're more likely to just hit water or something else within a cell. So the lymphocyte is a very early marker. The CNS is a very uncommon organ to be involved. And this table is just a part of the presentation that's up on the Radiation Emergency Medical Management site, like Ziad showed you with the Chemical Hazards Emergency Medical Management. This is something that's housed at the National Library of Medicine, has a slew of information in it, but it's best to go looking for that before you need it, because it's hard to navigate if you're in a stress circumstance. But they have a lot of charts and a lot of graphics, and one of the things that I just will emphasize here is that that the likelihood of a CNS component, so this neurologic issues showing up with radiation exposure does not till you're up in the 10 gray or even a little bit likelihood in the 8 gray range, which is a radiation, whole body radiation exposure range that is lethal, uniformly lethal. So if people show up with CNS symptoms, it's because they've had a lethal exposure, and they will be manifesting other evidence of radiation exposure by that point. It was significantly the drop in the lymphocyte count. So it is not something we need to spend a lot of time with. Having said that, people who have had a potential radiation exposure are going to be very upset, nervous, and also they may have all of the sympathomimetic or other kind of features going on that might make them look like they're stimulated or otherwise impaired, because of the issues. So they may have vomiting either because of radiation exposure or because they're very nervous. But vomiting and emotional status doesn't affect your lymphocyte count. So, you still have that to go back to. On the infectious side, of course, it's a lot more complicated. Altered mental status is a hallmark of bad systemic infections, and it doesn't have to be a CNS infection. So, sepsis is going to induce altered mental status. So it's always something to keep in the differential diagnosis, and whenever we're called on people who have altered mental status and some elevated temperature, it's always a consideration, but oftentimes, we were thinking of it when we have patients with, say, serotonin syndrome or neuroleptic malignant syndrome from exposure to some antipsychotic. But again, if you're talking about a cluster, it would be unusual for multiple people to show up with, a simultaneous serotonin syndrome or something like that. So keep it in mind, usually you're going to have a fever and some prodromal symptoms like I was talking about with the respiratory issues, but keep it in mind, it can sometimes be an issue. And one of the ways to rule it out if you're talking about a larger group of people is just comparing, the time, the epidemic curve, as it were, right? A chemical exposure generally causes a lot of symptoms in a large group of people within minutes to hours, and then it tails off over time, with very rare exceptions like Ziad already mentioned earlier this morning, like dioxin or methylmercury, where you have a delayed onset symptom. But for the biologic agents where you have an infectious process, you need to have the latency time for organisms to grow and reproduce, produce their own toxins and cause effects. And so that's going to be days to weeks. And if it's a transmissible illness, that's where you're going to see a weeks-long epidemic curve, not just an hours-long kind of curve. So keep that in mind, and that'll help sort that out. Oh, it really likes that one. So the chemicals, you know, the things to remember here is that, you know, if we say, well, it could be a chemical exposure, that could be true, but how are you going to keep track of, you know, hundreds of thousands of chemicals? And the answer is you can't. But when you're thinking about chemicals that have now exposures that cause CNS issues, and it's a cluster, this becomes a lot more manageable. We hope that it is more manageable, because if, again, you're not likely to have a large number of people exposed to a chemical all at the same time. So that's a medication, unless there's been adulteration of the food supply. And in that setting, the most important thing is to kind of keep it in mind. And if somebody comes in saying, I think I may have been poisoned by something I ate, drank, a medication I took, you have to consider the likelihood, but how likely is that? And one of the mechanisms or processes we use to think about that is the what's called the production distribution bow tie, you know, in terms of looking like two triangles brought up together, evaluation. And if something were affecting, say, a food contamination at the production side, where you have a few ingredients that are put together and then distributed to a large group of people, then you would expect a large number of individuals to be affected. If it's tampering with a product after it's already been placed into the store, for example, then you would expect a small number of people involved and in a very localized area. Whereas if it's something at production side, it's been distributed to many, many areas, and then you'd expect multiple sites and multiple people. So those kind of things, just kind of bringing it into the realm of what am I going to do and still take some action, helps with that. So if you think about this just in terms of you know, what might happen when you're next on duty, you know, if 5 people are unresponsive at home and paramedics are responding, or they're being brought to the emergency department for evaluation, you know, think, you know, which one of these things is more likely. You know, they all have serotonin syndrome because they're all on antidepressants and then, you know, took some dextromethorphan. Well, sure, I guess maybe it could be, but probably not. Actually, almost for sure not. Fentanyl analogs, well, that could be, right? If they were all using at a, you know, at say a drug house, and they all became overcome. That's how we actually recognize a new fentanyl analog being introduced into the heroin supply, because many people are affected all at once. So that's a possibility. But again, if you find out that it's 5 people that are all related to each other and they're multiple generations, and it's a nice home, not a, you know, a drug-using house, well, then that's less likely. So circumstances, remember, it's not only the toxin, it's also the circumstances and the nature of the patient, the host, those 3 things together. So carbon monoxide, you know, that actually would fit really well. You've got 5 people overcome in a house because of some problem with the exhaust of the heating system, or you know, the oil or gas burner, that kind of thing. And we've had this happen repetitively, enough so that it's a real concern, public health concern, in terms of keeping people safe by putting carbon monoxide detectors in their house. And the thing to remember is that if you have many people involved like this, is that if you're responding as a paramedic, you do not want to be in that environment for very long. And we've had, unfortunately, people who have tried to resuscitate, you know, responsive parties in a home and get overcome themselves because they were in that environment. So just a way of looking at it, and again, the reason to do it is because it allows proper care and protection of staff as well. Well, I think
Yep.
take over now.
Yep. Okay. Yeah. Okay. Can you hear me? I think yes. Good. Great. Okay. Yeah. Thanks, Chuck. So as described, the CNS is immensely complex. You know, billions of neurons, and many things can affect the brain. And we'd like to kind of clump them together to better understand how it affects the brain, and also how we will, you know, proceed with the management of a patient or a cluster of patients who have been affected. So one way to look at this is look at the excitation and the inhibitory influences. There's a variety of neurotransmitters. Some of them are more excitatory, others are more inhibitory, and there's a balance between these two. So GABA, for instance, is inhibitory, but glutamate is excitatory. And you take away GABA, you take away glutamate, you add GABA, you add glutamate, and depending on the cocktail, will either lead to more excitation or more inhibition. So there are also other neurotransmitters that may not cause excitation or inhibition, but in some other ways affect the sensorium and modulate the thought processes. And neurotransmitters such as serotonin or acetylcholine are major players in this sort of sense. And in this case, you may get neither inhibition nor excitation, but some disorganization or frank hallucinations. And we'll talk more about that in a couple minutes. So too much inhibition can lead to sedation and coma. Too much stimulation can lead to convulsions. And altered modulation of thoughts may manifest it as hallucination. So those are kind of the three main subtoxidromes under the CNS alteration that we'll discuss with some clinical examples. And we'll start off talking about sedation and chemicals and drugs to sedate. Now, a prototypical chemical, which may not affect a cluster unless multiple people are drinking, which is not uncommon, is ethanol. And the important thing about ethanol is just to reiterate the idea of dose response. Ethanol is a toxin that it really requires a large amount to cause some sort of alteration. I think I may have briefly mentioned this the other day, but we measure ethanol in grams, and one beverage, one bottle of beer or a glass of wine is approximately 12 grams or 14 grams of ethanol, depending on how you measure it, which is 12 or 14,000 milligrams of ethanol. So it's a lot of ethanol to cause perhaps a little bit of intoxication with one drink. As you drink more, particularly if you drink it all at once, you'll be much more intoxicated, and then to a point of incoordination. And finally, with a large amount, you may have coma and respiratory arrest ultimately. And that usually requires a very large amount of ethanol. But depending on someone's tolerance as well, someone who's not a drinker may succumb to much less ethanol than someone who's a tolerant drinker, and it may require quite a bit more to cause the same effect. So the first example, and I mentioned this earlier this week, I think it was mainly some of the students that I was discussing this with, but what happened in Moscow in October 2002, and I think most of you probably recall this or have learned about this at one point in terms of the effect of some sort of gas on this whole theater. So as you may recall, the Chechen terrorists took over this Moscow theater, and the Russian military wanted to put down this terrorist event, and they attempted, for them was a novel approach, which included the installation of this gas into this theater. And unfortunately, although they were successful in putting down the revolt and killing the terrorists, many of the theater goers were also killed as well, which was not what they were hoping for. And there was much secrecy about what sort of gas this was. Initially, people thought it might be some nerve agent, but nerve agents cause seizures. They generally don't initially manifest themselves as coma, but these people fell asleep and had CNS sedation, and many of them had respiratory depression, and those that died from hypoventilation and respiratory arrest. And as it turns out, it wasn't a nerve agent, it wasn't a benzodiazepine, it was an opioid, but this opioid wasn't given through a needle parenterally or through a pill, it was given as a gas, and that's what kind of surprised everyone, because there wasn't a lot of attention to the fact of using an opioid through a gaseous route of administration. And the gas that it was hidden in much secrecy. It seemed to be some sort of opioid. Folks suggested it was fentanyl, because fentanyl is very potent, but in this case, it actually was one of the fentanyl analogs, which was carfentanil. And carfentanil is an opioid that works just like morphine, but it is much more strong at an equivalent dose. And as you can see in this table that I put together some years ago, one aliquot of morphine is 1/10,000th the potency of carfentanil, which with the same amount is so much more potent. And that's why these people in the U.S. and elsewhere have been dying from fentanyl and fentanyl analogs, because these drugs are just so potent. Now, as it turns out, the carfentanil was initially developed to be used as a veterinary agent, and it was used to sedate very large animals, like elephants, for instance, or bison. And that's how potent it was, because when you're dealing with a 3-ton elephant, you need something that will knock them down without expending a tremendous amount of volume. And that was what was called wild nil, appropriately named the trade name for this carfentanil. So if one came upon a scene and there were a bunch of casualties, people with hypoventilation, with CNS depression, one should think, could this be an opioid? Important to certainly recognize that, because opioids do have a specific antidote, and regardless of the potency of the opioid, if you give the antidote soon enough, and if you give at the dose that might be required to block the receptor, you can reverse the intoxication with the opioid. So using naloxone, which is quick on and relatively quick off, is the approach. What happened in the Moscow theater is that the healthcare providers and the first responders weren't informed that the Russian military was using the carfentanil. So these people came out of the theater, they weren't equipped with the naloxone, they didn't know what they were dealing with, and that's what led to many of these casualties. So how else might we recognize an opioid intoxication? The 3 cardinal features or CNS depression at high doses, respiratory depression, and then particularly the meiosis that might occur with the eyes. It doesn't occur with all opioids. Some opioids, like meperidine, for instance, there may actually be some mydriasis, but classically with the majority of opioids, you'll see meiosis. Now, you also see meiosis with a nerve agent, part of the cholinergic response from a nerve agent is meiosis. So it's not pathognomonic for an opioid, but someone who has been exposed to some sort of cholinergic agent is going to act very differently than someone who's exposed to an opioid. That's why the initial reports in the Moscow theater that it could have been a nerve agent, because they had small pupils, but didn't make any sense. Okay, so that's briefly sedation. Many things cause sedation. We'll use a couple other examples as well, but there is increase in the inhibition, and the naloxone helps to reverse that effect. Other things that are important along with the naloxone for the opioids is supportive care. And if it's a non-opioid where there's no specific reversal agent, then supportive care is the primary management. And supportive care includes respiratory support, and then in cases with hypoventilation, ventilation, and it's critically important and may make a very big difference. Historically, it's of interest that years ago, with a lot of stimulant poisoning, with a lot of barbiturate poisoning, which is a sedative, the thought was the treatment should be to use a stimulant to reverse the effects of the barbiturate overdoses. And the morbidity and mortality from barbiturate overdoses did not decrease despite the use of stimulants. And that was in part because these patients were then developing stimulant poisoning and developing seizures and convulsions and dying from the treatment, while they should have just been given supportive care and ventilation. And one of the major breakthroughs in the history of the treatment of poisoning was the so-called, what they called the Scandinavian method, which was to abandon the use of the stimulants to treat the sedative patient, and just to support them with airway and ventilation. Okay, so turning our attention then to convulsions or and differentiate between convulsions and seizures. So inhibition of inhibition, if you take away the inhibition, you may then have a seizure. And this occurs pharmacologically in many examples. And there's a whole list of chemicals and drugs, pharmaceuticals that can cause seizures. And this is an example of a case of mass poisoning through this rodenticide, which was used to poison and many people developed seizures. And initially, these first few cases that occurred in the U.S., in fact, one wasn't sure what exactly they were dealing with. But as it turns out, they were dealing with a chemical with the abbreviation of tetramine. And this is a very seizurogenic sort of chemical. And there was this fellow in China that was using this to kill some of his competitors and led to killing over 38 people in this one event. So tetramine is a very strong poison. It was used as a rodenticide, but banned years ago. But it was still available, and this caused this mass poisoning. This is another case of 61 students felled by this rat poison. One thing I should mention about rat poison particularly is there are lots of different types of rat poison. So rat poison is not one specific chemical or one specific drug. Many of the rat poisons used historically were extremely toxic, like the tetramine, but they included chemicals like arsenic and thallium. And typically nowadays, the rodenticides are somewhat safer. We heard, I think earlier this week, perhaps about the brodifacoum that was used to contaminate the synthetic marijuana in Chicago and elsewhere in the United States. And that's one of the safer rat poisons, but it's a very potent anticoagulant, and if you take enough of it, again, dose response, it can anticoagulate a person as well and lead to significant bleeding. But this is an older rodenticide and causes seizures. So this is a list of some other chemicals that cause seizures, back to the stimulants again, and some of the agents used for nerve agents, which are organophosphates, the nerve agents or the pesticides, and we've heard a lot about that this week, organophosphates and carbamates. At low dose, depending on the chemical, seizures may not be evident, but as the dose increases or if it's a more potent organophosphate, seizures certainly could occur. Same thing with nicotine. Now, of course, nicotine is ubiquitous as a chemical within tobacco. People that use tobacco tend not to seize, but if they use too much nicotine, certainly this can cause seizures, and people have gotten into nicotine. Young children can get into nicotine, or even adults. Nicotine has been used as a pesticide in the past, and if someone deliberately ingests some of the nicotine, that can cause seizures. Hydrazines are also chemicals that cause seizures. Hydrazines we find actually in some types of mushrooms, and also we find hydrazines in rocket fuel, and if someone was exposed to the hydrazines, they can cause seizures. Camphor is an old-fashioned mothball that it tends not to be used anymore, in part because of its toxicity, but is also very seizurogenic, as well as organochlorines and strychnine. Now, strychnine is interesting because from a mechanistic standpoint, strychnine doesn't cause electrical seizures in the brain, but because of its effect on neurotransmission peripherally, patients become very stiff. They seem like they're having seizures, but they're really not seizures per se, but clinically they manifest as similar to someone who was having a seizure. Okay, so what is the management of someone with convulsions? Is to sedate. So before we talk about sedation, the management is not to stimulate, it's to support them, it's to use an antidote if it's an opioid such as naloxone. But with seizures, we don't just support them, we have to control the stimulation, and so sedation is quite important. I think one of the major advances over the last 30 years is the recognition that this is really of critical importance, that one needs to sedate the patient. You can't just put them into physical restraints, but you need to chemically sedate them if they're agitated, or certainly if they're having seizures. So a good first-line approach is the benzodiazepines. It doesn't always work. It works much of the time, but not always. There are other drugs that can be used, such as barbiturates or propofol, which is used in anesthesia. But these chemicals are important to consider, particularly if the benzodiazepines are not initially working, because of the emergent need of controlling the seizures. Again, you can't have someone seize for too long, otherwise they develop complications, mainly hyperthermia and rhabdomyolysis from all the muscle agitation and acute renal failure. So a lot of significant complications if someone's not emergently treated. There are certain circumstances where pyridoxine might be useful. Certain drugs such as isoniazid, which is used in the treatment of tuberculosis, an overdose of isoniazid doesn't immediately respond to benzodiazepines without providing the critical cofactor, which is pyridoxine. Okay, and then finally moving on to drugs that, or chemicals that neither sedate nor cause stimulation, but may manifest it as hallucinations or some sort of alteration, such as that. And as mentioned at the outset, there are a lot of different neurotransmitters that come into play here: serotonergic, sympathomimetic, anticholinergic, and even anesthetic. So not one common pathway, but they manifest it as an altered mental status, neither sedated nor stimulated, but more having hallucinations. And some of the drugs that have been abused in the past and even today at present, including drugs that affect serotonin, like LSD, for instance, or the tryptamines, this can cause significant hallucinations where the patient is just not there and is not interacting normally. The military actually used LSD in some experiments back in the 1950s. They thought it might be useful to use in the battle and put down their opponent. A lot of that research was done in secret, and as far as we know, wasn't continued after the 50s and 60s. But if there was a number of people who were suddenly hallucinating, one needs to think about something like LSD or similar chemical. And these chemicals are extremely potent. It takes a very, very small amount to cause the hallucinations. We'll just move on to the anticholinergic hallucinations. Now, this is through a different mechanism. We've talked about the effects cholinergically and what happens with a nerve agent poisoning or organophosphate poisoning. Well, if you block the receptor, if you block them, in this case, particularly the muscarinic receptor, you'll develop what is described as an anticholinergic toxidrome. And one of the features of that anticholinergic toxidrome is what would be described as a delirium. These people are often awake, and they just don't interact normally. They talk very funny. It's kind of gibberish. They're making no sense at all. And they can also get somewhat agitated, but they don't even need to be agitated to be very symptomatic, and it can be quite dramatic. We see most of this with pharmaceuticals that have anticholinergic properties, particularly diphenhydramine, but it also occurs in certain plants, Jimson weed, and if there was a mass, if there was a picnic or something and someone inadvertently contaminated the flour with something that contained scopolamine or one of these belladonna alkaloids, there might be a mass outbreak of what would look like anticholinergic poisoning. And this is the mnemonic that we often use to remember the clinical effects of clinical effects of anticholinergic poisoning. Not only are they delirious, but they tend to be very dry and hot, and they may be unable to void. So there are a number of features of anticholinergic poisoning, but the more severe manifestations are usually the CNS alteration. So this was hundreds of years ago in Jamestown, Virginia, in the U.S., but there was a picnic of some sort, and they accidentally contaminated the salad with the Jimson weed, and all these people develop what we would consider now to be anticholinergic poisoning. And this has not only been used historically, but in the Balkans War in the late 90s, these same agents were potentially used. And BZ, which is an abbreviation for a long chemical name, which is not a benzodiazepine, is actually an agent that was developed for military use, and its effect is to cause an anticholinergic syndrome, not necessarily to kill, but to cause this delirium. And you can see the dose of BZ, which is effective, is a very, very small dose. So theoretically, if you had a mass casualty event where there are a number of people acting delirious, one might want to consider BZ. And that was another agent that was considered with the Moscow theater event, but the patients, the theater goers were not acting. They were not acting with any sort of delirium. They were all sedated. So it didn't make any sense that it was BZ. So treatment strategy for hallucinations is kind of dependent on the exact agent. If they're agitated at all, one would want to calm them down. Benzodiazepines would be a good first-line approach. If one knew that they were dealing with an anticholinergic agent, antimuscarinic, if you use something that will overcome the receptor blockade, that may resolve the delirium very quickly and efficiently. And we often will use physostigmine. So physostigmine is a carbamate, so it's related to the pesticides. It's related to the carbamate pesticides, and in fact, it is a carbamate. And by blocking this acetylcholinesterase, it leads to an accumulation of acetylcholine, and the acetylcholine accumulation then can help with overcoming the muscarinic blockade. So if the patient is truly anticholinergic, and you have to be careful about this, because if they're not anticholinergic, then you'll make them cholinergic, which is not what you want to do. But if they're truly anticholinergic, a small dose, 1 to 2 milligrams of physostigmine, may totally reverse the toxicity, while Benadryl, it's not working. Okay. So again, the dose for physostigmine is approximately 1 to 2 milligrams. We reserve it when we're fairly sure that it's an anticholinergic poisoning. And if it is an anticholinergic poisoning, and if they are agitated and hallucinating, the judicial use of physostigmine may very rapidly, within 3 to 4 minutes, reverse the delirium. So concluding thoughts here, that the CNS is a unique target organ. There's a lot of different presentations as just described, and the management generally is symptomatic. There's a selective use of certain antidotes, particularly naloxone, if it's an opioid poisoning, and perhaps physostigmine if it's an anticholinergic poisoning. I think I'll end on that note and open it up for questions. Thank you. Any questions?
Let me go ahead and introduce the next section. Pierre has put together a group of speakers for what he's called the special topics area. Just some issues that for a cluster of illnesses presenting over time, other things that may not fit ideally within some of our organ system approach that we've used up until this point today. And so first we'll have Dr. Bruno Megavain come to the podium, and he will be talking about ricin. I think we have Dr. Megavain's presentation coming to us from Paris, France, and I think both of these are. Okay. And who's going to talk on ricin?
Ricin, yes. So good morning, everybody. I'm very pleased to be here with you, and we'll talk about ricin in a few minutes. So the story started in 1978, and you know that the first person to have been poisoned with ricin, or supposed to have been poisoned with ricin, is Markov, a BBC journalist, but from Bulgarian origin, and he was stabbed in the thigh with an umbrella while waiting for the bus at Waterloo Bridge in London. And he died a few days later from multisystemic organ failure. And on his autopsy, it was found a metallic pellet of platinum iridium, and it was presumed to contain ricin. Then, a few years later, in Iraq, the old regime, the previous regime of Saddam Hussein was accused to have prepared liters of concentrated weapons-grade aerosolized ricin made in Iraq, ready to be used. I don't know if they really existed or not, I don't know, but it was supposed to be. And of course, there was many incidents involving ricin, and if you go to Wikipedia, you see that there was at least 26 different events during the history where ricin was supposed to have been involved. And the most recent episode in Europe was in Germany in 2018, where an Islamic terrorist bought 1,000 grains of ricin and used instructions he received from the extremist Islamic State group and was preparing a bomb, but hopefully he was stopped before using this bomb. So ricin is a bioterrorism agent. It's, of course, a biological toxins, and you see that bioterrorism has include not only bacterial, but also viral and biological toxins, like botulinum toxins and ricin. Ricin is classified by CDC in the B category. That means that it is moderately easy to spread. It is responsible for moderate illnesses with a relatively low death risk. But when you look at the dangerousness of the different biological toxicants based on their median lethal dose in mice, you see that ricin is well positioned. Probably the most toxic toxin is botulism toxin A, and more recently botulism toxin G, which is much more toxic too. Ricin is toxic mainly if it is inhaled or injected, while if it is taken by oral route, it is less dangerous than cyanide. So it is still dangerous, but less than cyanide. What is ricin? Ricin is a component of the seed from Ricinus communis, and it is found in the castor oil, which comes from this plant. It is produced in the world with 1.3 million tons per year to produce lubricants, cosmetics, and even pharmaceuticals. It has been, for instance, experimented to treat pain and prevent graft versus host disease, and also as cancer chemotherapeutic agent. So it is easy to find. Its toxic properties were identified in the last part of the 19th century by this German scientist Stillmark. And now, of course, its mechanism of action is more known, and you see that ricin is a lectin with two glycopeptides bound with a sulfide bridge. And one part, the subunit A, allows the ricin to link to the membrane, while the second subunit can go through the cell till the endothelium, the reticulum, sorry, and then it will inhibit in the cytosol the ribosome activity. So it is glucosidase, and it inactivates the ribosome subunit, by modifying an adenosine, by removing an adenosine in the RNA ribosomal 28S. And then the protein production will stop and the cell will die. So that is the mechanism of action. So there are three routes of exposure to ricin. The first one, which is not so rare, it is the ingestion of castor beans, generally for a suicidal attempt. So symptoms occurs about within 4 to 6 hours after the ingestion, up to 24 hours. Normally, the seeds are relatively bitter, but to have toxicity, you have to masticate. So it is not so easy to masticate the seed. And it is estimated if you masticate the seed, then 3 seeds are enough to kill a child and 8 to 20 to kill an adult. So the toxicity has 2 phases. In the first phase, you will have irritation of the oropharyngeal mucosa, rarely more severe corrosive lesions, and then colicky pain in the abdomen with vomiting and important diarrhea. In the second phase, you will develop fluid losses, dehydration, hypotension, electrolyte imbalances that may lead you to hypovolemic shock and multi-organ failure, mainly acute renal failure. There may be also a risk of hemolysis, seizures, cardiac arrhythmias, and in case of fatality, patients will present diffuse intestinal hemorrhage. But this is relatively rare. In case of injection, which is more rare, but still possible, then you will have more severe features, initially non-specific, like fever, headaches, abdominal pain, and then rapidly hypotension, with intravascular hemolysis, acute tubular necrosis, and of course multi-organ failure leading to death. You may have also local tissue damage, and death is relatively rapid within 2 days, like it occurs with the Bulgarian journalist. And finally, exposure after airborne, intoxication after airborne exposure. So this is a very rare situation. There is no case report with airborne exposure, but it is supposed to be the way by which ricin could be used as weapon, as bioterrorism weapon. So symptoms will occur rapidly within 4 to 6 hours, and it started by cough, dyspnea, arthralgia, fever, then rapidly respiratory distress, multi-organ failure, and death. The patients will develop profuse sweating, and then he will have pulmonary edema, necrosis, bleeding, tracheobronchitis, and of course interstitial pneumonia leading to the death. It has been estimated that possibly a few people were contaminated by ricin by this route in Soviet Union, in a factory that was supposed to produce ricin in the 50s, but there's no case report. So all the data coming from this route of exposure are only in rodents, and by extension, it is supposed to be like that in humans. So when you look at the review of all ricin poisoning reported in the literature, and this is an interesting study, so it is like 1 century of cases. You see a total number of cases of about 875 cases. Most of them are accidental and by oral route, but there are some intended cases and some cases by injection. And you see that in the majority, the accidental oral cases are benign without death, while almost all the fatalities occur if the patient inject the ricin, and mainly in a voluntary situation to suicide. Diagnosis is difficult because, as you understood, there is no specific manifestations. Generally, the patient will come with cardiovascular failure and hypovolemic shock, or multi-organ failure. So it's difficult to diagnose. If the history is not clear, it is difficult to diagnose ricin poisoning. But if you suspect the diagnosis, then you have several methods of diagnosis. The immunological methods, they are very sensitive. They are relatively rapid. They could be used as multiplexing methods. They are fast and they allow fast and on-site detection. There are spectrometric identification that are with more limited sensitivity. They are relatively rapid in 8 hours. Also could be multiplexing, but they are much more specific. And finally, you have the functional methods. That means that you have to assess the ability of ricin to depurinate ribosomes. So it's a real-time cytotoxicity assay. It's sensitive and specific, and it is mandatory to determine the biological threat level of a sample. So normally, you have to combine an immunologic or spectrometric test with a functional method. Because as you understood, ricin could be present everywhere. So you need absolutely to show that you have a functional positive method. But all these methods are not available routinely and only in very specific laboratories. For instance, in France, only in 2 or 3 laboratories in the whole France. So you can use surrogate methods. And this is the case of ricinin. It is not ricin, ricinin, which is another compound of, that is present in the seeds. It is an alkaloid found exclusively in these seeds, but it is by itself not toxic, of course. So it can be present in different castor oils, cosmetics, and medical products. So if you use this test, you may have some false positive. And of course, you can also find some false negative if the toxicant was synthetic ricin and not castor seeds. So its use is still questionable, of course, but it is easier to use and it is available in more laboratories, possibly in MENA region, I don't know. So what are the management of these patients? First, of course, in case of severity, the patient should be admitted to the ICU. And this is the case following an exposure by ingestion or inhalation in the presence of severe diarrhea, cardiovascular shock, respiratory distress, hypoxemia, massive hemolysis, and of course, organ failure. The patient have to be transferred to the ICU. Treatment is based on decontamination, and of course, if the patient ingested the seeds, you have to use activated charcoal, as usually recommended. There's no specific recommendations here, and you understood that normally by oral route it is not dangerous. No role for cathartics and whole bowel irrigation. Then, of course, in case of symptoms, you have to provide supportive care based on fluid resuscitation, vasopressor supports, oxygenation, mechanical ventilation in case of pulmonary edema, and of course, hemodialysis in case of acute renal failure. Are there specific therapies? To date, there is no available antidote for ricin toxicity. However, some treatments have been suggested to be active on ricin. Sorry. No, it has this one. Okay. So, N-acetylcysteine and liposome encapsulated N-acetylcysteine showed promising results in rodent models. Milk, lactose, and galactose seems also to inhibit ricin B subunit to bind to the cell. So these are experimental in vitro studies. Dexamethasone and vitamin E seems also to have shown some extensive survival in experimental studies. But of course, none of these therapy is systematically recommended in humans. Are there specific therapies that could be more effective? Possibly. There are, of course, antibodies. These have been used in animal studies and have demonstrated the possibility of protection against inhalation and parenteral administration of ricin. There are several methodologies of administration. Passive immunization, and these methods show a protection before exposure to ricin using humanized animal-derived FIB and recombinant antidotes. And of course, much more interesting, active immunization by inducing adequate levels of ricin neutralizing protective antibodies. This could be useful as a vaccine therapy in people like military at risk of ricin exposure. There are also non-antibody small molecules that could be effective to inhibit protein-mediated effects of ricin. But to date, all these therapies exist only in mice and rats, nothing in humans, of course. What to do in humans? Of course, rapidly, you have to use the adequate personal protective equipment on the scene. Normally, you should use level A, especially if there is a risk of contamination by respiratory route. So you have to protect your skin, your respiration, and you have to use a breathing system. You have also rapidly to decontaminate the environment and to decontaminate the dermal surfaces of any patient by removing the contaminated clothing and by washing the skin with soap, with water, and of course putting the clothes in a double bag that is labeled as contaminated. And you have to clean all the surfaces and clothing with a solution of sodium hypochlorite for at least 30 minutes. That will inactivate ricin. So in conclusion of this presentation, you understood that there are development in biotechnology that allows to date probably the obtention of ricin easily from the seeds, but also by synthetic production in a laboratory by a possible terrorist state or organization. So this creates very aggressive bioweapons. And to date, some states or terrorist groups are accused to try to obtain such biological weapons, despite prohibition. Ricin is active in the absence of any producing organism. It is highly toxic at extremely limited doses, and it represents a challenge for clinical diagnosis and detection. Immediate identification is recommended to contain any further dissemination. And of course, as you see, the treatments are still difficult. That's why WHO is urging all the countries to strengthen preparedness plans to prevent such contaminations. Thank you. I don't know if there are any questions about ricin. Of course, all our experiences are limited in the field, but recently in Europe, following the production of a possible bomb in Germany, ricin become on the top of the issues, and the states and the governments try to reactivate all the specific diagnostic means, laboratories, possible therapies to fight against this possible risk. But to my opinion, it remains limited risk.
Bruno, you'd mentioned the difference between the castor beans themselves and then the ricin isolated from that as a water-soluble product. Most of what we've had in the U.S. has been people who have obtained castor beans and then ground them up, or sometimes ingested them whole, which often they're asymptomatic. But we've had events in Las Vegas and a few scattered events elsewhere where people individually have done preparations either in their home or in hotel rooms. And it has raised a question about the level of response, often after the fact, because sometimes people aren't told immediately what's happened, and then after the fact, somebody goes in to try and clean up the site. Do you have any comments on that other than the general recommendations as far as if people have disrupted the shell in terms of responding to those events?
My experience is limited, of course, but normally you see you need a big amount of seeds to extract the ricin from them. Then it is not so easy to produce an aerosolized bomb. Possibly, and that was the case in the US, they put it in envelopes, or they put it on doors or on the shoes of people that they want to be assassinated. But so they suppose that the person will contaminate himself because it doesn't cross the skin, so by oral contamination, thinking that the ricin is sufficiently concentrated to allow this. Because if you swallow a seed without mastication, you have no toxicity. So I don't know really if these means are effective to allow a fatality, because it's more frightening, I think. And in many such situations, such people use this ricin to frighten the people. I'm not sure that this really results in a fatality. The only way is to inject or to inhale. And as explained, if you use the seed to have the ricin, then the ricinin is present, and you can use ricinin as a diagnostic tool. But if you use synthetic ricin, but this is only performed by a state, not by a private person, then ricinin is not useful tool. So you have to measure the ricin directly. And you need, in both cases, an analytical or immunological test and a functional test. Because, as you understood, if you use only an analytical or immunological test, they may be false positive, because ricin or ricinin could be found in different situations in a market. So there is a study that tested for ricinin, and about 2% were falsely positive. So you need a functional test also.
Thank you. Any other questions?
Okay, thank you very much.
Good afternoon. I'd like to thank again the Scientific Committee for inviting me here. My name is Robert Hoffman. I'm a pediatric emergency physician and medical toxicologist. I'm the medical director of the Cutter Poison Center. I'm going to discuss a topic that there's a high chance if you're a toxicologist or an emergency physician, you might have seen some of this information previously. Some of these slides are actually slides that I just presented here at this conference. So if you attended the previous lecture, you'll see some similarity. I don't have any conflicts of interest to disclose. I will disclose that some of these slides are actually from a World Health Organization template that I've used before and that's widely used to discuss this same topic. So some of these slides are not my original slides. They're actually WHO slides that are freely available for people to use and I've used in training previously. But basically, I'm going to discuss some unique aspects of anatomy, physiology, and development, as well as behavior that poses some specific issues with regards to children in RIMIC situations. And then a few specific details of exposures that are unique, and then discuss how this relates to pediatric cluster illnesses, or how it would impact our management in pediatric cluster illnesses. So this is these are just some older paintings, and the reason it's included in these slides is if you look at the older one from the 1300s, you see that the child is actually just a miniature adult, and the exact purpose of this discussion is to explain why that's actually not the case. So kids are not just you know, miniature versions of us. There's significant differences. So so some of the differences relate to exposures. So there are different pathways of exposure. So some pathways of exposure are actually, you know, antenatal. So antenatal or postnatal. So transplacental as well as breastfeeding. More likely to occur on a larger scale is our children's behaviors. So exploratory behaviors, hand-to-mouth behavior, putting things in their mouth that aren't food items or, you know, aren't made to be ingested. Their location, their physical location, meaning you know, being on the ground, so either crawling on the ground or just being closer to the ground, even if standing. Higher surface area, so relative to us, surface area to volume ratio. And then kids are preambulatory, and most kids who are going to be exposed to something, including in the US, if they're not pre-verbal, they're poorly verbal. So if you think of, you know, kids who are 4 years old or less, they have very limited ability to speak or give their own history. And then if it has to do with adolescence, high-risk behaviors or kind of behaviors that might result in exposure or dangerous exposure that could have been avoidable. So I have a few slides about breathing, because this is one of the key things that differentiates younger children from adults. So I won't go through all of them in detail, just try to give you the specific point, which is minute ventilation. So children's uptake of toxins is faster, and that's kind of specifically related to their position close to the ground and minute ventilation. So this is actually from a pretty cool study that was exposure to chlorpyrifos, so chlorpyrifos sprayed on carpeted floors and toys, and the uptake by children, and you kind of see the peak the peak is kind of right there in the center, as opposed to, you know, older children or 10 to 25-year-old patients had very little uptake of chlorpyrifos. This slide is a size and surface area slide, so relates to what I just mentioned. So smaller children, especially a baby, has a very different volume to surface area ratio than adults. This is more significant when it comes to dermal exposures, but it is one of the key things that we consider when we consider pediatric exposures in poisonings or mass casualty situations. So one thing about children has to do with behavioral differences. So younger children either, you know, can't recognize danger, or maybe older children, like an adolescent, recognizes but ignores something as dangerous. And I won't read through all of these, but younger children can't specifically remove themselves from a dangerous situation, and actually won't necessarily know that a situation is dangerous. And like I said, adolescents have risk-taking behavior. So, so xenobiotics are handled differently by younger kids as opposed to older. And again, I won't read through the slide, but just there are some significant differences when it comes to both uptake, metabolism of poisons, and then excretion of poisons. So minute ventilation, which I mentioned before, is significantly different. So the younger the patient, so the closer to infancy, the much higher the minute ventilation. And an analogy to this would be, you've heard the term canary in a coal mine. So you know, an infant literally is like a canary in a coal mine if you were thinking about something like CO or a toxin that's going to be taken up specifically by the respiratory route. Some other considerations have to do with in-hospital care, staffing, and resources. So lack of pediatric EM specialists is pretty universal throughout the world. It's not common that a child would reach an emergency center in most countries and actually encounter a specifically pediatric EM physician. They're typically going to be seen by a pediatrician, general practitioner, or maybe an EM physician. And there's a little bit of a difference in each of them. There's maybe some advantage and some disadvantage to each, but there's some distinct differences in what they're capable of providing for the child. The other kind of specific issue faced is when children do get to a hospital, it's not really, there's no guarantee that hospital actually has specialized services that are able to care for critically ill children. Meaning it's very possible that the hospital doesn't have a dedicated PICU or neonatal ICU. And besides being able to manage those as inpatients, it might not have other things that are necessary, which might be people able to do ECMO for children, or respiratory services able to keep children ventilated. This is from my talk yesterday. Even some simple things like just supplies. So the reason I show that blue top tube, it's not specific to a RIMIC situation, but it's that blue top tube is, you'll recognize that's an adult vacutainer tube used to check coagulation profile. So to fill that, and it's necessary to fill that tube to a specific volume to ensure the anticoagulant inside is exactly the right amount. Now, the difficulty with these tubes comes in, it's very possible if you have a young child, an infant or neonate, you won't be able to get enough blood to fill that tube, and resulting in a lab error. So there are a lot of simple things that you would think are simple, but actually can become problematic when we're managing children in these situations. Another consideration has to do with developmental or cognitive capability of the child. So typically, children have to remain with the caregiver. So if you're talking about considering a mass casualty event, you actually have to consider, so are children going to be transported without an adult? And then if decontamination is needed, who's actually going to take a child who's alone through their wash, through the decon? And then, you know, further considerations would be, well, if there's an adult there who wasn't exposed, but they could go with the child, does the adult go through the decon and potentially get contaminated? So there are really a lot of kind of developmental or cognitive questions that come up when managing kids. Once the patient's inside the hospital, we face the same thing. Who's actually going to stay with the patient? It's not really feasible to have a one-to-one nurse for every unaccompanied child. And then other issues of consent, capability of consenting to procedures, consent to a hospital to a level that provides higher care. Specifically, it's issues come up with regard to antidotes. And it's mostly not availability of antidotes, more familiarity or unfamiliarity with antidotes. So for any given poisoning, it's likely that an ICU relative to a PICU probably has more experience applying that antidote. So anyway, this is the second of the pictures that I just showed you, and this is a more realistic picture of a child, which is, you know, a child is kind of like an adult, but a distinctly different entity. That's actually the last slide I have. Happy to take questions. Thank you.
Hello, everyone. I hope you are still awake. So I've been asked to give a talk about paralytic syndromes related basically to toxins exposure in general. And so I'm going to talk in brief, basically. I'm not going to burden you with all of the information related to all of this, but we are going to speak a little bit about Guillain-Barré syndrome, the barium toxicity, botulism, and we had quite extensive talk about botulism in the last workshop. Tetanus toxin, tick paralysis, saxitoxin, and then tetrodotoxin, because we had an outbreak of tetrodotoxin. I would like to share that with you, and then cons if we have time. So Guillain-Barré syndrome is basically the most common cause of an acute generalized paralysis that we see in the emergency department. It's usually commonly missed diagnosis because most of the time we don't know what is going on with the patient initially, and it is associated with significant morbidity. And it's basically happened due to inflammatory peripheral neuropathy, which could be related to virus-induced, bacterial-induced, or toxins. There are four main phases for this disease. They usually start with the interval of an infectious prodrome that happens initially, and patients usually does not know that they are going to develop, or there are no signs of symptoms that they are going to develop this kind of paralysis. But then eventually they progress into weakness, which manifests as symmetrical limb weakness, diminished or absent tendon reflexes, and then, but they have a minimal loss of sensation despite the paresthesia. So that's one of the things that you might put in your mind when you are looking at the differential diagnosis. And these symptoms usually last for about 4 weeks or so. And then they have the plateau phase, and then after that, the recovery phase. The main challenge in this is the clinical diagnosis. So if you have a high suspicion of Guillain-Barré syndrome, you will be able to pick this as early as they come in the initial presentation. But they might have also abnormal nerve conduction study in the assessment. And when you do a CSF analysis, you will find a high protein analysis and a low WBC. And the treatment most of the time is supportive. You can use immunoglobulin, and that's with a high efficacy, especially if it's administered within the first 2 weeks of starting the symptoms. And there have been trials of using plasma exchange as well in such cases. Barium toxicity. So barium basically used as a pesticide or insecticide. The feature of the barium makes it a little bit you know, it looks like a powder, a white powder, like a flower. And then most of the time, people might miss this with the usual flower, and that ends up by an unintentional poisoning. The barium by itself, it can cause competitive blockade of the potassium rectifier channels. So it will decrease the potassium efflux out of the cell. So most of the time, the potassium will be built inside the cell, and there is a decrease in the level extracellularly. And this will cause an increase in the vascular resistance, leading initially to hypertension, and reduce the blood flow, leading to metabolic acidosis. It also indirectly affects the potassium by increase the membrane permeability to the sodium, and so increase the sodium-potassium bond activity, leading to the further influx of the potassium inside the cell, and so decreasing the potassium level extracellularly. And usually, the hallmark of diagnosing barium toxicity is the hypokalemia associated with it, which will lead into overall result, cellular depolarization and paralysis. And that's the main reason behind the paralysis, is because of the hypokalemia rather than the direct effect of the toxin. The clinical presentation, it can cause fixed proximal weakness, also abdominal pain, nausea and vomiting. The hypokalemia can lead into ventricular dysrhythmias, and then death may be related to it, associated with hypotension. And the main thing is that they develop a flaccid muscle weakness and respiratory failure as well, which can also lead to the death in such cases. Diagnosis is clinical, and also there are some centers that they can do the blood level or urine level of barium. The treatment is mainly supportive with aggressive correction of the hypokalemia and mechanical ventilation for the respiratory failure. There are evidence that enhanced elimination like hemodialysis and CFFH might help in such cases. Botulism toxin, again, we spoke about this earlier. Botulism is quite a nasty toxin that if happened, it can cause great fatality. It's the most lethal toxin known. You need only a small dose of this, like a human oral lethal dose will be 1 microgram per kg, which is quite, scary. The mechanism of toxicity, probably you know this, it's usually, we need acetylcholine in the neuromuscular receptor agents. So what will happen is that you have at the nerve or at the neuromuscular junction vesicles that contain the acetylcholine, and then you have proteins. I don't know if this will show, but you have proteins at the end here. That protein here. Neurotransmitter. What will happen is with the botulism, they are going to affect the protein there. Okay, so that will end up by having the vesicles flowing up there without reaching, the acetylcholine will not be released. And that will end up basically by decreased level of acetylcholine and causing paralysis. So clinically, they will have a decreased symmetric paralysis, descending symmetrical paralysis. They will have normal sensation, and that might be a clue to diagnose botulism. Normal reflexes compared to the previous two, and they might have early cranial nerve palsy or cranial nerve involvement. And eventually, the cause of death is basically because of the respiratory compromise and respiratory failure. Diagnosis, we talk about this, but toxins are detected in the serum, stool, and the food. And also you can grow the bacteria by itself in the stool or in the stool culture. And the treatment is mainly supportive. You can use botulism antitoxin if you have it, and that will shorten the duration of the illness and the morbidity as well. Or you can use also IV botulism immunoglobulin. Tetanus is another cause for paralysis. Tetanus by itself, it's an extremely potent neurotoxin that produced by the Clostridium tetani in an anaerobic conditions. And usually it presents with an acute onset of hypertonia, painful muscular contractions. So you can see that, the classic posture of such patients, and it can cause generalized muscle spasm and increase reflexes. The diagnosis is mainly clinical, and the treatment is supportive. Using the tetanus immunoglobulin might, shorten the duration of the illness as well. And of course, the main thing is the prevention with vaccination. Tick paralysis, again, it's basically peripheral nerve effect due to the one kind of ticks called Dimacentor tick species, and these are basically cause ascending symmetrical paralysis, ptosis, again normal sensation, and respiratory failure leading to death. Mainly the diagnosis is by identifying that these symptoms related to the tick. You need to look for it and try to remove it. And of course, there are certain techniques that you need to apply in order to remove this tick. And usually the other investigations are within normal, including the CSF. The treatment is by tick removal and supportive care until the effect is completely resolved. Saxitoxin is a paralytic shellfish poisoning, and is basically formed by the dinoflagellates in the shellfish. It can cause ascending symmetrical paralysis. So you can see is almost all of them, they can give you a similar clinical picture, which might, a highly suspicion of certain diagnosis will give you the clue about what is the exact cause for these symptoms. For this patient specifically, they will have burning and tingling sensation, around the mouth and the lips, and maybe in the foot at the beginning of the illness, and this can be used to differential between it and the other types. It can cause altered mental status and respiratory failure. So in this way, you can see it's different compared to the botulism and the tetanus, basically. Diagnosis is, again, is clinical suspicion. The toxin can be detected in the food, water, environmental samples. There are certain centers that can send and test even the urine sample for saxitoxin, and the main treatment for it is mainly supportive care until complete recovery. Tetrodotoxin, this is basically, I mean, we had an outbreak of 6 cases last year of tetrodotoxin related to fish ingestion. They didn't know that it was a buffer fish. And so tetrodotoxin by itself depresses the action potential generation by the fast type sodium channels in the neurons and the skeletal muscles, leading to that kind of paralysis. So usually the patients will have, the initial presentation in our cases was initially GI symptoms, nausea and vomiting, little bit of dizziness, and perioral tingling sensation. And then after some time, they started to feel this ascending paralysis. And that happened within 30 minutes after the ingestion. You usually expect the paralysis to start within 1 hour to 3 hours from the time of the ingestion. And we feel that this presentation was quite quick, maybe because they ingested quite a good amount of the toxin. So they develop ascending symmetrical paralysis with cranial nerve involvement. And then eventually they started to have respiratory failure, and then they lost their consciousness. And this is one thing that you might also consider in the differential diagnosis, that these cases, they will develop eventually altered mental status and coma. Again, the diagnosis was clinical. We had to say that this was tetrodotoxin based on the history and the examination, but we were able to send the urine samples to be tested, and it came positive for tetrodotoxin. If you have the facility, that's okay. Otherwise, it's mainly clinical diagnosis. And the treatment was mainly supportive treatment. We did a trial of using newstigmine to overcome the effect of the tetrodotoxin on the neurojunction and neuromuscular junction also. And we also considered dialysis, but we were not sure whether this intervention was the cause for the quick recovery. Most of them recovered within 48 hours. The last one is Konzo, and Konzo basically is a highly dietary, caused by highly dietary cyanogenic cyanogens substances in what is called cassava roots. Okay, so these patients whom they ingest cassava without being processed in a certain way to degrade this toxin, they will end up by developing symptoms, which is basically upper motor neuron symptoms. So they will have abrupt, irreversible, non-progressive, and symmetrical spastic tetraparesis, increase in the reflexes, and then tropical ataxic neuropathy. So that's very classical for Konzo. Again, the diagnosis is mainly clinical. You can detect the cyanogens through the food sample if you have that facility. And the treatment is mainly supportive with higher education on prevention of, higher education basically on the way to prevent the development of this disease, and maybe the control the way how this kind of fruit being prepared. So I guess that's the end of my presentation. Any questions? Sorry. No? No questions?
So
Dr. Nelson is going to be coming up, and I don't know that all of you have heard him over the last couple of days, but he's going to be presenting from Sandia Labs and little systemic issues regarding an emergency response.
All right, I realize it is the last series of talks at the end of the conference, so we need to wake up a little bit. All right, everyone has a pad of paper and a pencil. So I'd like you each to take a pad of paper and a pencil, and everybody stand up. All of you, stand up. We're gonna do some artwork here, right? The art of medicine now. So take your paper, put it over your head. All right, and draw the biggest circle you can with your pencil. All right, congratulations, you just drew your face. So now, as physicians, I'd like you to draw your eyes, your mouth, and some hair in that circle. All right, let's take a look. Very nice. Okay, that has no meaning in life whatsoever, just to wake us up. So, as many of you saw on the first talk on Wednesday, I'm a scientist. I represent Sandia National Laboratories, and this is science. Well, kind of art. I don't know, a little of both. But I'm here to talk about security principles. And I acknowledge that as physicians, most of what I'm talking about today, you won't ever actually probably do on your own, but know that there are resources out there to help you if you ever see a security problem in your own hospitals. So we at Sandia teach a comprehensive risk assessment approach. We typically offer courses that are about anywhere from 3 to 5 days long on all of these topics, primarily, again, with scientists, but I think there's a lot that we could offer to physicians and hospital settings, which I'll talk about now. So we usually teach 5 questions. What do we have? Meaning, what dangerous substances, be them biological, chemical, radiological, do we have in our hospitals or our patient clinics? What can they be used for? Again, it's kind of a heavy topic, but what could someone use these for to hurt someone else with? What could bad guys use them for? How badly does somebody want it? Why would someone want to come steal it from you? And how can we protect against these bad actors? So again, in the patient setting, we find chemical substances. This could include fentanyl, chloroform, a lot of the dangerous substances we talked about today. Biological agents, of course, you have patients coming in that are exposed to Ebola, hopefully not Ebola, but various dangerous viruses. And then radiological, many hospitals have cesium-137 in the blood irradiators. You might also find Tech-99 and various other radiological substances. So question for you. If I told you I wanted to work with a flammable liquid, an extremely flammable liquid, or a combustible liquid, which of these 3 do you think is worse? Which is the most dangerous of these 3? None of the above? So as a chemist, I think of the difference between flammable and combustible. And these words have slightly different meanings. And then the word extremely. Well, the challenge with this is that depending on where you look, which reference you look at internationally, you get a different response. And there are some chemicals that if you look at US-based regulations would classify as flammable, and then even other US-based regulations would call it combustible. A perfect example of this is acetic acid, or commonly referred to as vinegar. Now let's take it to poisons. What if I wanted to work with a poisonous liquid, an extremely toxic liquid, very toxic liquid, packing group 1, or hazard category 4 liquid? Which of these is worse? Yeah, I have no idea, right? And that's the point here, is that it depends on where in the world you are. So some chemicals could classify as all of these. So if you have a very poisonous chemical, it could be classified, depending on where you are in the world, as extremely toxic or packing group 1. So because of this, this is why we, the international community came together to develop the global harmonized system. Because within certain countries, the US is a great example, and then between countries, so if I were to ship a package from the US to Turkey, we had different laws, different regulations. So in the US, we would label a toxic chemical differently than here in Turkey. So this system was developed by a lot of input from around the world, along with the United Nations, to try to minimize some of those problems. So this has now been implemented in many countries, but the Middle East still has a long ways to go with this. And many countries are starting to implement, such as Egypt is in the process of implementing GHS, but they haven't fully integrated it into their processes. So one of the really cool things about this global harmonized system is that it standardized what we call a safety data sheet. How many of you have worked with a safety data sheet before? Conversely, how many have never seen a safety data sheet before? So I met a couple of your colleagues here this week that had never heard of a safety data sheet before. So what this is for any material, it has known hazards. And what the global harmonized system did is it standardized these hazards. So it makes it easier for people around the world to identify the same concerns. Now, under all safety data sheets, on the second line, you find hazards. And this will include toxic hazards, chemical hazards. And so they've come up with a very systematic approach where anything, if you see the word H300, or the letters in the code H300, means fatal if swallowed. So that would have an LD50 of less than 5 milligrams per kilogram. Fatal if in contact with skin, it's code H310, and then H330, fatal if inhaled. So these values are all available online, and they allow us to quickly attribute toxicities to various chemicals. The way that this is determined is by a lot of mechanistic, deterministic toxicology, which is really the field that I come from, where there's a systematic approach where you do an animal study or various other studies, you find the toxicity of a chemical, and then if you find that it has an oral toxicity of less than 5 milligrams per kilogram, you call it a category 1 toxic, and so on and so forth. So what this means for you is it makes your life easier. Now there are pictograms, or these pictures, that are associated with all of the hazards that we need to be most concerned about. For instance, if something is acutely toxic, you'll have the skull and crossbones. So that means it has very high toxicity. So this helps you in your labs. You can go around, or your clinics, or wherever you may be. You can walk around, and if you see that picture, you immediately know this is a safety concern. It also could be a security concern. The issue with security risk assessment and security management is that some chemicals may not present as acutely toxic originally, but they're very easy to convert in simple chemistry to extremely hazardous chemicals. Case in point is mustard, which we heard about earlier today. In one step, you can convert a very simple chemical, dimethylamine, into mustard gas. So dimethylamine is not particularly dangerous, but if you convert it into mustard, of course, we saw today, it is quite dangerous. So there are many resources out there to help us identify these chemicals that are known to be precursors. For example, the Organization for the Prohibition of Chemical Weapons has lists that they have published that help us identify these chemicals. Turkey is a member of OPCW, as are most countries in the Middle East. The only country who is not a member is Egypt. Switching gears a little bit to biological hazards. For something to become a hazard, it's going to depend on, one, its transmissibility, its lethality, treatability, latency, a lot of these different factors, which it's kind of outside the scope of what I want to talk about today. But the reason I bring it up is the security we have around it is the principles are all the same. Radiologically, the hazard associated with a radiological material is going to depend on its half-life. How long is it present? So if you have a compound like fluorine, radioactive fluorines for FDG imaging for cancers, the half-life of that is in the order of about an hour. So if someone were to steal a large source of fluorine, they'd have to have a very well-orchestrated plan to actually do anything wrong with it, because by the time they got to their intended target, it would be gone. Similarly, with a compound like, with a radioactive isotope like uranium-238, is a half-life in the order of billions of years. So in order to be a radiological hazard, you would have to have huge quantities of it, at which point the metal toxicity outweighs the radiological hazard. So the half-life is important in determining this. It just so happens that cesium-137 is one of those radiological materials that is a security concern. The physical form of it is important. If it's a gas and it just disappears like krypton, you're not so concerned about it, or radioactive argon, not so concerned because it disperses very quickly. And then activity level. Of course, if you have a very small concentration or activity, it's not going to hurt someone. We're less concerned about it as opposed to these high activity. Again, this leads us back towards cesium-137 for blood irradiators in hospitals, which here's a picture of those. So next question we would ask is, how badly does someone want to take this from us? And there's unfortunately a lot of different types of bad people out there with a lot of different motivations. Some are opportunistic, some are very motivated. We have individuals all the way up to state governments that could have very localized, all the way up to very widespread impacts. We've heard about a lot of these today. This is World War I, chlorine gas exposures, with Syrian exposures, and then with organized groups such as ISIS that we heard about earlier today. So a lot of this makes sense to us, but what it means for us in the clinical setting or in our own laboratories or wherever we may be is understanding why us. So that leads us to a discussion about why us in the patient setting. And really in hospitals, you're relatively vulnerable in the sense that your mission is to serve patients. You have to be open to the public. Your mission is to take care of people, so you always have people coming in. Whereas in my institution, I can shut the door and keep people out, so I have much fewer people coming in and out. We know that you have toxic chemicals in hospitals. Certainly the quantities are smaller than you'd find at like a chemical industry. We know you have radiological materials as well as infectious agents, though, again, most of the infectious agents, you don't have a lot of control over what comes into your clinic. So that's a little bit harder to predict from a threat perspective. And of course, equipment is always important. So if we wanted to reduce the vulnerabilities in the medical setting, we have a number of different tools to do that. Physical security, so this is adding more doors, more locks, more gates. Transportation security, so this could include protocols on how you package materials to ship them. Inventory management, which I talked about on Wednesday. Personnel management, this could include wearing things like badges. How do you ensure that the people that are coming into your hospital are entitled to be there? And then lastly, information security. Just random question. How many of you have changed the passwords to your email in the last year? Last 6 months? 3 months? 1 month? Last week? Okay, so that's impressive. A lot of places we go, people have never changed their password before. I guarantee you that your password is out there on the dark web. And actually, there are now tools. A lot of banking applications will search your credit history and tell you whether your passwords have been hacked or not. And that actually just happened to me a couple weeks ago, so I quickly changed my password. So anyway, there's really 4 principles that we need to think about when we're trying to improve our security. The first is balanced, second is layered, third is graded, and fourth is hierarchy-based. And I'll go through each of these briefly. So by balanced, we mean you don't want to make your facility into a nuclear security facility. It wouldn't work for your needs. So you need to balance the mission of your institution. Again, you need patients to come in and out. And also, the other aspect of balance is that we need to think about our facility in 360 degrees. For example, there was a famous case in Brazil where there was a large bank that had built extensive security around their vault. But the problem is they built their vault in the basement, the very bottom of the building. So some criminals bought a house within about a kilometer. They set up a landscaping company and then started digging out dirt over about a period of a year. And they were slowly digging a tunnel a kilometer underground and came out underneath the vault. Now, it turns out the vault had no security looking downward. So you have to think about the vulnerabilities all around your facility. You don't want to put all your efforts on the front door if you've got an open back door. With layers, this is the onion principle. I don't know if you've ever received a package, like a gift from a friend, and it's a box, and you open it up, inside's another box, and you get really frustrated, and then you get another box, and eventually you get down to like a piece of trash or something. You know? But the point is, it takes forever to get to that present in the middle because there are more and more layers. So the more layers you have, the more difficult it is to access something that's higher risk. And layers is not necessarily doors or gates or locks. It could be a number of things, such as having security guards that walk around or having badge systems. So we're making things more and more complex. So just to look at a clinic setting here, this is looking at a blood bank. Down in this bottom corner here, we have a blood irradiator. And if we wanted to really look at the security of this, we'd want to think about how many layers do we have. So if we break this down, we see that there's 3 layers of physical security in some regards, but we'd really want to know what's down here. How easy is it? Is there a window right here? Maybe there is. And if there's a window right there, we really only have 1 layer of security. So we've got to think about these layers in 360 degrees. And then we need to think about this idea of graded or risk-based protection. These are just a few examples of chemicals. Certainly there are other things out there, but and this will depend on the situation in your own country, your own region. I recently went to a laboratory in Kenya, and they had chloroform in the laboratory for many years, but then there was a trend where people were stealing chloroform from laboratories around the country so that they could then kidnap people. So they made the decision that this was too high a risk and they got rid of it. But that could be, in that setting, obviously a high-risk chemical, whereas saline, it's not high risk. So you don't want to protect saline unless, of course, there's a theft situation for it, but that would be a different discussion. And then the last major concept is hierarchy-based. So this really comes from the field of industrial hygiene or occupational hygiene. I'm sure in most of your countries you have access to occupational hygienists, so if this concept is of interest, please do reach out to them. Similarly, I'm happy to discuss with you further. But really it's this idea, I like the STOP principle, the stop sign. This comes from the Germans. Substitution, technology, organizational measures, and personal measures. And I'll show you an example of what I mean by this. So if we're looking at radiological hazards, the most effective thing you can do is to substitute the radiological hazard. So if you have a blood irradiator that's based on cesium-137, that is a pretty high-risk material to be taken. But there are alternatives, right? You could use an X-ray-based system that doesn't require radioactive material. So you've immediately reduced your risk. You could also put in administrative controls or badge access controls. That would help lower your risk. And then lastly, you could protect the actual individual blood irradiator. Similar with chemicals, you could choose different types of chemicals that are known to give similar medical effects. Substitute the higher hazard chemical for a lower hazard. You could also, eventually, the last thing you want to start doing is putting in personal protective equipment like goggles. I'm not saying they aren't important, but they are the last barrier. So you want to think higher if you can. And then biologically, if, say, this is more for a research setting, but if you're studying typhoid fever, you could use a surrogate, a different lower hazard bacteria like typhi, Salmonella typhi instead, and so on. So the idea is to really think about getting rid of the hazard if possible, substituting it, and then thinking about administrative controls engineering controls, and then lastly, PPE, personal protective equipment. So again, there's really 5 questions we ask with security. It's what do we have? What can it be used for? What harm could come from it? How badly does someone want it? Why us? So this is a really important question. Think about what weaknesses you have in your facility. And then lastly, how can you reduce them? And particularly when it comes to this last question, how can we reduce our vulnerabilities? I wouldn't suggest that you start designing your own systems for that. But certainly these first 4 questions, you're very capable of doing. All of us are capable of asking these questions. And then reaching out for help. Reach out to your security personnel. Reach out to Sandia. Reach out to Ziad. He can put you in contact with other people as well. So the main point is it's like you're in the clinic and you can see these problems arising. So speak up about it, ask for help. There's plenty of resources out there to help make your work environment a safer place. So any questions you have, please feel free to email me, write to me, WhatsApp me as needed. Yes, Ziad.
Have you talked about, sorry, I was outside finishing up some administrative stuff, but have you talked about
the... You missed our artwork.
Did I miss?
You missed the artwork session.
Oh, okay, what about the video? Do you play the video? No.
Oh, I did not play the video.
But have you talked about the role of emergency physicians and the role of emergency responders in detecting chemical or biological or radiological incident breaches?
Not exactly. No,
can we
be a great
bring
time
that up?
to bring it up? Yeah.
Can you bring that up a little bit?
No, yeah, but it'd be a great time to bring it up. Sure.
Okay, so we have a role as healthcare providers in this area. Can someone tell me why we have a role? Why do you think that we have a role in detecting a chemical incident breach or a biological or radiological?
Because we are the first responder. Nobody will know if we don't recognize it. It comes to us as a first, guys. And if we don't raise the issue, maybe it will be missed.
Very good. That's the one point. So detecting the actual illness. Tim, are you trying to answer? Go ahead.
It takes a long time for a hazmat team to set up and do entry. They got to do vitals, get in level A suits, get downrange, get back, sample, that kind of stuff. And typically, I'll tell my guys to call the hospital and ask what the syndrome looks like before they go downrange. Because typically, the medical people have an idea long before the hazmat team makes entry on what they're dealing with.
And what about our role in detecting something suspicious? Can you imagine a scenario where we actually enter the scene and see something, not we, the first responders enter the scene and find something suspicious on the scene? And many times the paramedics are there before the criminal has concealed the evidence. So if a criminal is doing something, they don't have time to conceal it when they get injured and the paramedics arrive there. In the emergency department, we also should be suspicious about, presentations that are odd, something that doesn't fit, an explosion at a home. Why was there an explosion? A chemical burn that is from a weird chemical, or a chemical that's not supposed to be as a household chemical. A group of people exposed to a chemical together, and if they're working on something. So all of these are reasons why we can potentially play a role in this chemical security or biological security or radiological security ring.
And I want to expand on that point that with most terrorist attacks, they're more predictable than you might think, in that they don't just happen overnight. There's always a planning phase, a testing phase. So if you think about the process, first, someone has to acquire, let's just choose a chemical example, for instance. First, they have to acquire some knowledge about what chemical they're going to use. Then they have to actually acquire the chemical. And then they have to develop some sort of a delivery system. So in this process, there are many opportunities for them to be exposed themselves. So there's always the possibility that they might splash some chemical on them. And if they come into your emergency room and they have some weird chemical burn that doesn't make sense, especially in line with their occupation, that's a red flag. We'd call that a red flag in the US at least. But that's a suspicious warning sign. Then, most of the time, during these attack cycles, they also test it. a small-scale test. Again, another opportunity to see people coming in that have some sort of a strange exposure. And this always happens before the larger planned event. So there are many opportunities that you as physicians are uniquely situated for to actually identify big attacks before they happen.
Thank you for expanding on that. And also, the other thing that we need to know about is who to report it to. We did a survey of emergency responders in Atlanta about these topics, and it's being published in a journal issue that Andy is editing, I believe.
It's actually available online right now.
It's already available, correct. And you can look it up. And you can use that survey if you like in your own community. That'd be nice to do that. So a couple of things came out of that survey. The first thing is that people were, responders did not know who to contact. We were surprised to see that. Mm-hmm. Do you know who to call if there's something suspicious? You know, if you see something suspicious other than the police, you know, who do you call? No, what if you did know and you suspected something? Our responders didn't know who to report this to. The other thing that we noticed in the study is our responders felt a little bit ethically undecided. Is it ethical for a responder that goes to save someone's life or take care of somebody in their home to report on them, even if they suspect a criminal activity? If you see something, say something motto, is that ethical for a paramedic to do this who's already awarded the faith, the faith and the you know, confidence of the community? Are they violating that faith? That was the second thing that was, I thought was interesting.
That's a really tough problem too, because you could also look at it the other way. By not acting, you're potentially harming
other people.
So it's and no one can make that decision for you.
No, for example, in the U.S. we have some joint we call them like joint hubs of law enforcement and fusion centers. We call them fusion centers. But people are not trained in this, you know, responders, and we asked them, you know, they're trained in hazmat maybe, they can recognize toxidromes, or they train in toxidrome recognition, but they don't train in chemical security. So chemical security training is lacking for responders and physicians, certainly, and nurses.
I have the video with us, so we can watch it after the break.
Yeah, maybe we'll watch it during the discussion. Sure. And don't worry about being a little bit behind. This is part of the discussion that we're going to have. So let's go ahead and take a break right now for 15 minutes. And come back at 3:30, or 20 minutes. Come back at 3:30 for the final PPE session. We have Dr. Anwar Al-Wadhi, who's one of our disaster medicine experts from Kuwait. He's going to talk a little bit about chemical hospital preparedness. Dr. Abdilhal Attas from Saudi Arabia is going to talk about biological hospital preparedness and biological transportation of biologically infected patients, such as Ebola. And then at the end, we'll just kind of do an open forum together and maybe show the video.
Yeah, perfect.
We'll try to get you out of here at 5:30, if not 5:15, hopefully. Thank you. Koenig and Dr. Schultz. He is now in Kuwait. He actually went back to Kuwait right away after he graduated to contribute to his country. And he currently is the advisor for the Emergency Medical Services and HIMSS for the Ministry of Health of Kuwait. And is actually in Department of Emergency Medicine at Mubarak General Hospital. He is going to share with us the perspective on the hospital response or hospital reception of chemical emergency victims. And then he may show us some videos, I believe. Yeah, so thank you, Dr. Anwar.
Thank you. Thank you, everybody, and welcome. I know it's the end of the conference, and you guys are tired. It's the afternoon. I promise I'll make it short. So basically, you know, the talk is about hospital management of chemical incidents and the reception of, you know, the victims of either industrial or warfare or, you know, might be like terroristic attack. This is, you know, I want you to imagine if you have a facility and you get called in today that something happened at the facility and you are actually, you know, either the medical director or the actual disaster manager thing. This happened at one of the oil field refinery just 2 days ago, which is on February 20th. We'll watch like really short videos. So this is actually the CCTV camera of one of the sites. This is actually 2 days ago. And this oil refinery is due to, next video. So this oil refinery actually is due to, this is all taken by individuals. I'm sorry. No. Yeah, so this is all taken by individuals. Actually, some of the videos might be uploaded already on the internet. Regardless, the good thing is this facility is not functional yet, so it's not up and running. So there wasn't a leak. It was all major, structural damage, and thankfully nobody got injured. You can go third video. I'm not sure why it's not projecting, but anyway, that's fine. That's it. You get the idea. That's fine. We can go back to PowerPoint slide. Something with a projection. Okay. So yeah, so imagine yourself, this is actually another refinery. This is in Philadelphia many years ago. But anyway, so the actual thing when you start is actually you get a notification. The regular channel for this, so for example, Dr. Ziad just mentioned if you're at a chemical incident, just before the break, what would you do? Our people are aware how to manage these type of incidents. Are they trained to a specific role in a specific agency? So the idea is if you get something like this, you obviously, you call the emergency line. Usually all companies run their own thing unless it goes out of resources, which is by definition is a disaster event when you have requirement and resources. And you make a call to 112, which is the dispatch for many countries, or 911 in the United States. And by the way, 112 is actually international. So if you call apparently 112 in the United States, it goes to 911. And you report the incident, and the 112, whether it's the emergency dispatch, it contacts your EOC, Emergency Operations Center, at the EMS department. And the EMS department asks you questions. They're trained. They know how to scale up and down, and then they activate hospital or multiple hospitals under HICS, Hospital Incident Command System. And if they think the event is actually really large, they activate the ICS, the Incident Command System, which is a multi-agency approach to certain incidents. Now, you can always activate it, and if the incident is really small, there are no people are being harmed, it's only fire or it's only building collapse, then you can, downscale it. But if you do not, and something gets leaked, like, gas or oil or chemical or fire, so to speak, it's very hard, to catch up with the event itself. So the main thing, actually, once you activate all of the system, is patient safety and your staff safety. If you miss on these two, it's actually, you're multiplying the effect. So let's say we go back to our incident, you have to establish your zones. So hot zones, warm zone, and cold zone, you can mobilize or demobilize as much as you want. If you don't do that, something might happen to what similar happened in sarin gas attack in Tokyo. Remember? The average was 200 at the event in 1995, but by the time they reached the hospital, there wasn't a proper, people are not used to that kind of scale. The average number was 5,000, including staff and patient and relatives also. Some of them actually taxi drivers who transported those people. So staff and safety security response to the objective. What kind of incident? This one is hazmat, hazard material. And then you activate the incident management, and then once you manage the role, let's say it's only fire, then you transfer of command to the fire department. And then obviously incident recovery, which is you learn, lesson learned, incident action plan, and everything that goes after it. So we go back. So HICS activation, Hospital Incident Command System. You need as much as intelligence, you need to know as much as information, because actually you can manage more in the field while en route, and you actually can, reduce the effect of all of this to your hospital. So one of the things, if you think this is like really, something that could contaminate your hospital, you can go and activate hospital lockdown policy. Now, hospital lockdown policy has many objectives. It has for active shooter, threats, leak of, let's say, radiological material from your nuclear department, many reasons. But in this scenario that we're going to talk about specifically, we're not talking about biological or radiological, we're talking about chemical incidents. So you can activate lockdown policy. The other thing is you always, if you need, ask for help. Remember, we go back to the incident command. If you think the scale is large, then you can ask for fire department, National Guard, whoever does hazmat too. So you can have a field zones and decontamination at the site if your decontamination units at the hospital will be overwhelmed or people will flood your hospital being affected. So once you activate the decontamination unit to the hospital, whether it's in the field or mobile units, you also want to know more about the agents. Is it liquid? Is it vapor? Has it been, what type of contamination? Was it inhaled, ingested? Was it contact? Was this a spill? All of these, obviously, make a difference in the management. But you go back to the basic thing, which is ensuring patient safety and staff safety and security. So PPE, personal protective equipment, and you scale it up and down. So if you think it's really, one of those that needs level 1, then you go level 1. Our colleagues will probably demonstrate, the type of suits and the scubas and how you use it. The basic for hospital staff, if you don't know, you can go to level D, the basic, which is, goggles and face mask and apron and gloves and all of that, right? Now, luckily enough, now you have to detect, let's say, chlorine or other, leaked gases. You have many companies that provide chemical kits for that, that's good enough. However, there are many chemicals that's out there, and the majority, they don't have the antidotes. The majority of the management for these things are actually conservative, which is supportive care basically. But one thing stands. So if you're let's say you're in your PPE and you activated your decontamination unit at the hospital, but many patient comes in, so you actually go to, this is MCI, like mass casualty incident, which is more of a disaster event. You go to reverse triage. So you want to go through green, yellow, red, and black. So for example, if a patient comes in at the hospital and you have resources and you're not overwhelmed, so priority resuscitation goes to the top priority before you look at, you decontaminate him totally. I mean, you can do both at the same time. In the decontamination unit, you expose the patient, but if the patient is cardiac arrest, you absolutely jump to resuscitation. Make sure resuscitation comes first, as long as you are having your basic protective equipment. Now, there are actually some of the lists out there, like Kim Intelligence Syndrome list, which goes actually through the major thing when you ask the paramedic in the field, or if the patient arrived in the hospital. So you ask for vital sign, mental status, pupil, mucous membrane, lungs, and skin. Those are major parameters, and if you link them, you will find a way of, okay, I'm dealing with, opioid toxidrome, or I'm dealing with anticholinergic. So the Kim list helps you to do that. So what are the major lists that we are looking at? I'm sure like all of your colleagues have gone through all of these, and I'm not going to repeat them, but we'll mention them briefly. Knockdown syndrome. Classic in an industrial site. People walk in, a guy, drops, the other guy wants to help him, he drops him. Before you know it, you have a lot of people, dropped at the site, and you cannot help them because people don't know what kind of agent. The other agent, like pesticides, people work on farm, but also naval agent when it comes to warfare, and specifically now, a fourth generation, which is odorless and you cannot detect it. Then solvents and anesthetic and sedative. The anesthetic and sedative is commonly what we use in the department, like halothane, and propofol, and benzodiazepine. Then you have irritant gases. Irritant gases commonly now, it's actually in riots. You have people going riots in many countries, unfortunately, and then you define them between upper and middle and lower airway according to their volatilities. Then opioid syndrome, we all deal with this in our facilities every day. The unfortunate part is, unfortunately some terrorist attack might use some of the opioids for terroristic reason, like carfentanil, right, which is probably like more than 250 times more than opioid, and they can vaporize it, and presumably it happened in one of the terrorist attacks in Russia. The anticholinergic syndrome also, and then convulsant syndrome. So now we go with the initial assessment. So you want to make sure that resuscitation is your priority. So airway, breathing, circulation. But D is actually not disability when it comes to ABS. It's actually decontamination. And the drugs, you need to know, do I have the antidote for this, or this is conservative management? If I have the antidote and I'm receiving many patients, I probably need to ask for to stockpile those agents. Now, you can go through the asbestos mnemonic. Now, agent is what type and what's the, the LD50, and what's the status? Is it liquid, vapor? What's the type of contamination to the body? How severe is it? The time of course, is it delay or is it acute onset? All of these actual parameters, and obviously synergistic and combined effect or delayed contamination, right? People were not, exposed properly, they can have delayed contamination for that. Then you can go through poison, which is, what type of it? Is it outside? Is it internal? What's the, sequence of event for that? Do we have other differential diagnoses, right? And the net effect for both the patient and actually for cross interaction between chemicals. Like, for example, this facility, if it had multiple towers, one is chlorine, the other one is H2S or something, or ammonia, you will have probably a mixed range of victims. So we go back, and now we're going to go through them really quick because I'm sure my colleagues have covered all these syndromes. But knockdown syndromes is, as we mentioned, it's usually in the industrial site. People walks in, they drop down. The actual mechanism behind that is usually, for hydrogen cyanide and hydrogen sulfide. The major mechanism is actually toxicity to mitochondria, so they cannot utilize, the use of oxygen. So it could be simple as cellular asphyxiant or hemolysis that goes into hemoglobinopathies or anemias. Now, the other one is pesticide, or what's known as cholinergic or nerve syndrome. I mean, most of you have dealt with this, especially if people work in rural areas and people still use pesticide, for farming. And the only thing that we all know that you need quite, large amount of atropine. And if you're lucky enough that you have 2-PAM, pyridoxine also. And then obviously for muscle spasm, people have spasm for a long time. So think about rhabdomyolysis, think about renal failure if you need dialysis. And obviously, you can work on that. The other is, aggressive supportive measures like circulatory and respiratory measures. And obviously decontamination when indicated, which is probably most of the time it's the case. The other one is organic solvent, aesthetic and sedative. So industrial will be like, the gasoline, the toluene, the carbon tetrachloride, and freon, like used in freezers. And the medical will be nitric oxide, in anesthesia department, halothane, isoflurane, the stuff that we use every day, like etomidate, barbiturate, and benzodiazepine. So there are specific drugs like benzos, you have flumazenil, but all the others, most likely you will end up doing supportive measures like aggressive ventilation, oxygenation and circulation measures. Irritant gases, the major categories will go probably upper, middle, and lower airway. So ammonia, chlorine, and phosgene, and it's all divided according to their volatility. So if somebody inhaled, was it only inhalation, or is it actually skin contact? We go back to when we were doing differentiation for that, right? And some of it actually industrial, and other, unfortunately, could be used in riots or actually just household leak, like chlorine, for example. Now, ammonia, if you have, it's actually erosive, so we know that, especially with mucosal membrane. So irrigation, people could inhale it. Specifically, they end up with massive laryngospasm and actually respiratory arrest. The treatment, again, is like decontamination when needed, hydration, and obviously supportive measures. Chlorine, on the other hand, might have a yellow to green color to it. It's non-combustible with a very specific odor. Yet again, it mainly affects the middle airway, and it can cause respiratory spasm, which is acute, and the respiratory failure. The treatment, again, for it is actually supportive and aggressive measurement, but there is no specific antidote. The other irritant, which is has low volatility, is actually phosgene, which settles in the lower alveoli. It's colorless, it's non-flammable, and it can also lead to suffocation. Now again, you need to decontaminate when needed, but aggressive supportive measures. So this covers basically the pulmonary irritants. We go back to tools for identifying these agents. Use them if you have them. If your facility has, obviously the funds to get them, that would be great. If not, just use your basic parameters that we discussed in the field, that you look at the vital sign and the names to identify which one of those 7 or 6 toxicodrome that we talked about. Now, opioid is another one. You guys are very familiar with this. If you have a, we have antidote for that, which is naloxone. However, if you experience a patient coming with ramifentanil or just fentanyl, now, unfortunately now fentanyl is being sold everywhere over the internet, or carfentanil, which is much worse, then you probably won't, revert that person with few naloxone antidote. You have to watch, you have to ask, you have to get collateral histories, but it can be challenging, even with the availability of the antidote. And obviously, you guys are the expert when it comes to opioid toxicodrome. Anticholinergic, obviously, it's the sympathomimetic without having a wet skin. It's rather dry. But basically, what really bothers the patient is actually the altered mental status and hallucination. And what you need for that is actually aggressive, hydration. You need benzodiazepine, and if people go into rhabdomyolysis, they probably need dialysis for that. So, but the major mainstay of treatment for the anticholinergic is conservative management. Convulsant, on the other hand, now it affects the central nervous system. So you have glycine and GABA antagonism, which is they desensitize the nervous system. But if you have something against that, then it's excitatory effect. And the opposite, the same. Glutamate is excitatory, because if you have antagonism to that, then you have depression of the central nervous system. So it's actually, the toxicodrome for that is the opposite of what's the available physiology for these things. So where are they found? They're actually found in the industrial chemicals, and they can be in chemical warfare or terrorism attack. And what happens actually, again, aggressive measurement, hydration, supportive measure, and respiratory support. And remember, for people, because they go into excitatory phase, they might end up with status epilepticus with unknown cause. But what you need is conservative management, benzo, barbiturate, and if you suspect something like INH toxicity, you probably add pyridoxine to that. So in summary, you have to have, when you receive a call for these type of incidents, you need to have a high index of suspicion. Gather as much as information as possible, because the only way that you can actually manage these events is you can scale it. So let's say you're at that facility, that hospital, and they called you about the incident that we saw a few minutes ago. You can actually make a call to the EOC, say, even though I'm the closest to the facility, I need the support of the Incident Command Center, and divert the cases like green or yellow triage to other facilities, right? And even if you know the chemicals and you have stockpile, you can share it through your incident command system with other facility, especially if they're receiving the lower acuity one. Now, request for support is very important. If your fire department, or if your National Guard, or if your civil defense use hazmat team, use them, because that means probably the lower cases, that are not severe, they can be treated at the field by going through the hot zone, warm zone, and cold zone. Identification of the patient. If you go through the parameters that we discussed about those 7 toxicodrome, then you probably have a good chance of managing these events. If you don't have the tools like kits to test them, that'll be fine. You just have to do the basic conservative management, fluid, aggressive hydration, and circulatory management. And manage per incident. So if this incident that we saw just now was a fire, and then you activate incident command system, you can deactivate it. But if it's a fire that led to structural collapse, and you have victims, trauma from structure, and then you have victims from toxic inhalation, obviously you're going to run the full incident command scale for that. The evaluation of the incident is extremely important. A lot of people mention this is like lesson learned, but it's more than the scientific word. It's experiences gained through incident action plan. So when you demobilize, you sit down and you look at things and how did we do, and this is probably one of the most important things to learn, and how to manage that type of large scale and complex event. And I would like to leave the last few minutes for questions. It's a little bit of a complex topic, but thank you for your time. It's the end of the afternoon. Thank you. There is.
Let's have Dr. Ibtihal do her lecture, and then we can have the discussion. Maybe that will stimulate more. So Dr. Anwar will stick around with us until we do this. It's my pleasure to welcome Dr. Ibtihal Attas. Dr. Ibtihal Attas is currently at King Abdulaziz University in Jeddah, and she is Deputy Director of EMS at that hospital. Ibtihal completed a residency in emergency medicine at Emory University, followed by a fellowship in emergency medical services at Emory, and then moved back a couple of years ago, and is here with her lovely family, her husband, Dr. Sultan Wajih, and her daughter, Asil. So, Ibtihal is going to talk about the biological side of things a little bit. Yes.
All right. Good afternoon, everybody. We're just going to switch gears, and we will concentrate on the biological incident. So the biological incidents, we have many, either it's man-made or actually was done by the nature. We have the incidents in '84 where like a couple of salad bar restaurant in Dallas was infected with salmonella because of like some political group. Then we had since 2001 the anthrax. After that we have the SARS, the outbreak of coronavirus, and lastly recently the other coronavirus, the novel one. Yes, the viruses actually. So when we want to think about the biological attack, it's really similar to the infectious disease outbreak. The only different is like the scaling of the surveillance and how you're gonna act with the public health authority will be just more skilled. So how you gonna identify the incidents if it's biological? We have like mainly two sources of the to identify that. Usually the 911 centers or any call center in the country they have their like geographical mapping of where is the call is coming from. So usually the program that they have or the mapping will show them if multiple people have like presented with the same symptom, and this will alert them that, okay, there is a possibility of like an outbreak here or a biological incident. And usually if you have a call for one patient, it's a regular day. 2 patients, it's a little bit suspicious. If you have 3 patients, like on 1 hour or 2 hours, this is usually activate the hazmat or like hazmat response or something like that. So the authority will be just at least notified of it. The second place, it's the ER actually, and that's why we're saying that the emergency physician are the first line. They are the most important people to identify if there is incident, because you can have increased scale the number of patients presented to you. And all the infection control in the hospital, they will notice that, okay, from the surveillance of the disease, we have this month a couple of people presented, or in this week, we have a lot of like respiratory symptom or gastroenteritis more than what we usually suspect in this time of the year. So for for the biological wise in the community, what is the sign that make you suspicious that it could be an attack? If you have a bombing that didn't make a major destruction for the place, you can think that, okay, maybe it's a dirty bomb. If there is in the neighborhood unscheduled spraying for insecticides, it's like a different, like a weird time, weird place that they usually do not do the spraying, then people have to be suspicious. If there is if they found anything like thrown in the floor, like a discarded PPE, any biohazards bag, this is also suspicious because it shouldn't be in the community. It has its own way to be discarded. And if there is also like multiple insects in the same place that it shouldn't be, like if you have like a lot of whatever fly, whatever, it's like in a place without plants, then could be suspicious. If there is a lot of dead animal from different species, so if you have like a lot of like birds that getting sick or dying in the area, you need to take this in consideration. And lastly, the outbreak of the respiratory symptom, if it's in the winter, could be normal. But if it's in the summer, then it has to be suspicious. For the epidemiological part, the clue usually that if you have a disease in multiple people are dying, sorry, I'm a little bit small. And if you have a single case of uncommon disease, like if you have one patient with anthrax, one patient of smallpox, this will activate the incident. And then lastly, if you have a zoonotic disease that shouldn't infect the human, but it's now in the human, this might be a biological attack. For the CPR&E, the scene management, as the doctor before me mentioned, you usually isolate the area, control your access, establish your communication, and this is how you kind of go in the scene. You start communication and you have your risk assessment, but then you implement your treatment, doing your triage, and try to do the victim evacuation. And this is how you kind of controlling this is how you set your control zone, where you have your hot zone, warm zone, and cold zone. Unfortunately, for the biological incidents, all of this is like not gonna happen. It's most likely for chemical, or if there is a bombing or something else, because most of the infectious disease have an incubation period. So the patient will actually come to the ER with the symptom, and they already exposed, like anybody exposed to them, and you don't really have to do all of this stuff. So how you're gonna think of the bio stuff in your response plan? You have to put a plan, how you're gonna recognize if there is an attack. So you have to have a plan for this. Like you put a syndromic syndromes specifically, you educate your staff about that. How you're gonna get your prophylaxis? If you want antibiotic, if you want a huge amount of antitoxin, how you gonna get that? If there is a large number of dead people from infection, what you gonna do with them? And how you gonna deal with the public? How you gonna control the area of the attack? Like these days, what they are doing in China, and how they like isolated most of the areas, and how you limit the access to the area of the attack. And you have to have a plan how you're gonna quarantine the possible exposed patient, like the possible exposed people actually, because not everybody gonna listen to the quarantine order. It's not isolation because they didn't show the symptom yet. So you need to have a plan for that. And most importantly, the safety of your worker. Adding to all of that, for the bio incidents, you need to add for yourself more stuff. So it will be how you're gonna transport these patients, and if you transport them, you need to prepare your vehicle, and what special equipment you might need to do, how you're gonna disinfect your equipment, what you're gonna do with the waste management, and lastly, post-mission surveillance, which you need everybody who transported a patient, you need to put him under surveillance for a possible appearance of the symptom after that. And it's really, basically, it's the infection control if you think of it. It's very simple. If you are doing your hand hygiene, you have your precaution appropriate and your PPE, and you have your prophylaxis and the vaccine, then things gonna be easier. Just a little quick about the mode of transmission and precaution. We have, as we know, the droplet and the airborne, and in the droplet, you actually have like more than 5 millimeter of the droplet itself, and it's enough for it to do a face shield, a mask, and a regular gown. But when it's airborne, you actually need to have like N95, HEPA filter, and all of that. For your standard contact stuff, you need your gown, gloves, your face shield again, and your regular mask. Hand hygiene, it's the most important, and don't forget that. So if you detect an outbreak, after that, what is the appropriate response? So you have to notify the authority. They're gonna start their epidemiological investigation. They're gonna look for how many patient is affected, what is the sign and symptom of the syndrome that they are developing, what is the exposure route that they have, and they will do a rapid lab identification. Then they're gonna release for you what is the treatment, what is the antibiotic or the antitoxin you need to use. If they suspect that this area is contaminated, authority have to map this area, and they need to answer many questions. It's usually the answer they get the answer after they have like multiple sampling from the place. Is the incidence was spread by liquid or powder, or it's any change in the physical or biological thing of the bacteria or the virus, make it more virulent or make it resistant to treatment. They have to answer this. After you have this answer, then as a medical provider, you will issue your correct PPE, you start your first aid and treatment for the patient, implement the decontamination. And remember, the decontamination here is different because you have to include the building from inside and outside, especially if there is a gas or air stuff, and for your vehicle. So, like really in conclusion, if we think about decontamination, it's really needed if there is a chemical exposure or a nerve gas agent or whatever, and we don't need it if this chemical is gas or if it's biological incidents, and we can actually delay it if we have radiation incidents after we treat the patient and save the patient. And there is multiple methods that you guys know, the dry and wet, but for biological, we're gonna add like the normal sterilization stuff that we do in the hospital and the autoclaving. So I'm gonna talk now about the Grady experience. Actually, Grady EMS, they are the hospital care provider, the pre-hospital provider for Atlanta City in Georgia, USA. So they developed this team, what's called biosafety team. It's mainly made after the attack of September 11, and they actually, initially it was like a SWAT support team, but after the SARS attack in Canada, they start thinking, okay, what if we had to deal with a SARS patient and we have to transport an infected patient? What we're gonna do? We need to protect our staff and ourselves, and we need to help the patient at the same time. So they developed this unit, and the leader for the unit is Dr. Alex Isakov. So actually what they do, they train their paramedics, a couple of them, and they teach them the nature of the disease. They're going through courses, and they teach others also in the area. Their experience with the Ebola patient, basically, in 2015, they transported the two Ebola patients to Emory University Hospital. So what they did, actually, they have 5 steps in their plan. How they're gonna prepare their ambulance, what is their PPE, and what is the role of each one in the team, and how they're gonna prepare the patient inside the ambulance. And here are some pictures of their publication. This is actually the inside, the ambulance from inside. So what they did is, they are using the regular ambulances that for the daily operation. They didn't buy like an expensive unit or like wasting a lot of money. So what they did is the ambulance, and they have like a plastic, very thick plastic draping, and they actually wrap the ambulance all over from inside as a capsule. They remove everything out, the suction, the oxygen, anything the patient might need it, and they wrap it up in plastic so they can use it. And this is the ambulance from inside. And actually, if you notice from the top, this layer also can, like when we close the door, it covers the door completely. So there will be no contamination for the ambulance whatsoever. Because even if you didn't do that, the ambulance have a lot of small spaces, and the infection will get somehow, it will get contaminated, and it will be very difficult to disinfect. Okay. After that, how they prepare the patient. So they suggest 2 things. If the patient can walk, he can actually wear the Tyvek suit, because for the Ebola patient, some of them, they're having vomiting and diarrhea, and some of them, one of them was very weak to walk, and the other one was fine. So if the patient can walk, they can wear like the suit, which will be easier to transport the patient on, and it will make the transmission less. If the patient cannot, they actually grab up the patient with a cover, and they're covering him completely, as you can see in the picture. Also, for the mask, kind. If the patient have no vomiting, they actually can put a surgical mask. If the patient is vomiting, they are actually giving them like a very thick bag so they can vomit in it and they're not contaminating everywhere in the ambulance. So they're trying to keep the ambulance inside clean. The PPE that they use, actually the Ebola was, as you guys know, it was a contact mainly. So they used the Tyvek suits, double gloves, the hoodie. It was actually felt that the goggles and the mask, the N95, were more than enough, but they choose to use the paper. The only reason they use that because it's environmental thing, because Atlanta is very hot. So if you think about it, when you are putting the goggles in, you will have the vapor, and then you cannot see. Then what's gonna happen with the paramedic? If he wanna move the sweat, he will do like this, and then he might be infected, and he will infect himself. So they don't want to have this movement from the staff at all. That's why they use the paper. It makes the environment cold for them inside, so they don't have to touch themselves at all during the transport. The last thing is the staff. So the staff of the unit actually for each transport was 4 healthcare workers, 2 paramedic and 1 a supervisor and the EMS physician. The 2 paramedic, so the first one will be fully in the PPE full with the paper and everything, and he's the one who's gonna take care of the patient. The other one will have the same without the paper, just the mask and the goggles, and he will drive the ambulance. If the patient needs 2 paramedic, then the supervisor will don his PPE and he will drive the ambulance, and the 2 paramedic will be inside the ambulance. If not, then the supervisor and the EMS physician will actually follow the ambulance in the supervisor car. And mainly the reason for having the supervisor, he's acting as a safety officer. So they have this checklist when they are donning and doffing their PPE to make sure they are following the protocol specifically and they are not missing anything. And that's how they transported the patient successfully without getting infected. So lastly, just remember that the biological incident, it's really like infectious outbreak. You need to be just cautious, always maintain a high suspicious. If you have a multiple patient with different symptoms, think of chemical versus biological. If you have a patient with abnormal rash, with respiratory or neurological syndromes, all the syndromes that they describe in the morning. And remember, first responder is not the first one usually who counter these patients. You are the one, the physicians and the nurses in the hospital. And decontamination is really not necessary initially, but after they know the attack. And any questions?
Andy?
First of all, I want to say thank you for your wonderful presentation. You highlighted a lot of really important topics related to what I would call biosafety. And I just wanted to point out to the audience that biosafety is a very complicated area. And although we're all capable of understanding this, we're all trained in the concepts of biology, many of the topics that were listed there, there are full courses on waste management, full courses on PPE. And I just wanted to point out a resource for all of you. There is a website, it's the internationalbiosafety.org, internationalbiosafety.org. And on there, there's actually a list of certified biosafety professionals. Many of your countries are represented. Turkey is on there. I believe Jordan is well represented. So you can actually go to this website, find the people that are already trained in that, and call them or email them so you don't have to recreate everything yourself. So thanks again for your presentation.
Thank you, Andy. I was interested in the ambulance, so I'll ask this question to Dr. Ibtihal and Dr. Anwar. Have you seen or heard of a special ambulance for chemical? I mean, I know for biological, you've retrofitted this ambulance. And I know in Los Angeles, actually, they actually made a biological ambulance. What about for chemical or radiological? Have you seen or heard of anything like that? Tim, maybe Dr. Anwar, have you?
We go back to the basic decontamination. site and in the hospital. If you do your contamination outside, it's more than 90% done.
What if you don't?
Well, what if you don't and they jump in the ambulance? Then you have to, first of all, identify the agent, the offending agent. Is it something that's only inhaled, or is it actually skin contact? Or is it actually, as Dr. Ptial mentioned, like airborne or like droplets or something? So it depends on the actual, agent.
What about you, Tim? Have you heard about the ambulances?
If we only have 1 or 2 patients, some of the ERs in the Chicagoland area, especially DC, et cetera, have preset decon rooms. So if we can notify the
You mean the ER?
With PPE.
What about the ambulance?
Yes. So they have the decon rooms, and they can set up faster than we can pull a hazmat team to the scene. So we drape the ambulance very similar to what she demonstrated for Ebola. And we drape it like that, and we can do that faster, put them in the ambulance, and decon them faster at the hospital than bringing, especially in the winter, and then bringing out a full decon team and trying to decon somebody when the temperatures are below freezing outside.
So it's primarily contact protection.
Yes.
Nothing else, so basically just drapes.
Yeah, so what we'll do is then, typically we'll only do that if we know the agent, as the doctor said, so we know what level of protection, because you don't want to be in an A suit in an ambulance.
Absolutely.
If you can work in a C suit, I'm all good with that. I've worked for 4 hours in a C suit with a cooling vest. Right. So we'll put the transport medics in a C suit, drape the ambulance, and then decon them inside of the hospital in a preset decon area, and it's much better for the patient than try to decon them in the ice and the cold.
I think for radiological, if somebody's contaminated, you don't necessarily have to do that. You can just wash the ambulance, because of just a bunch of dirt, basically. But it's interesting for the chemical. Mark, were you going to say something?
More directly to your question about a specific ambulance specifically for a chemical incident or a radiological or a biological? The answer is yes. There are specific units that have been designed for this purpose. They're marketed by various manufacturers, but there is no standard. So each unit is designed per the subject matter experts that particular manufacturer was reached out to or worked with. And most oftentimes it's for a specific jurisdiction that came to the manufacturer and said, this is what we want, this is what we would like it to be able to do, this is the features that we want in it, and then they customize and build the unit and sell it to them. I know they do exist in the US, they exist here in the MENA region. I know that Abu Dhabi has actually a fleet of them, both domestically and for the military. So the answer is yes, they do exist. Can you just order one? The answer is no. Yeah, they're going to force you for
I wonder
liability
if they're
reasons.
necessary.
Yeah.
Mark, I wonder if they are necessary.
For 99% of all events that we're aware of historically, I would say no.
And are they meant to protect? The drivers in a plume, or are they meant to protect the patient from, or the staff from the patient?
It's based on the request. I can tell you that because I was part of the team that helped design some of them, I know the military ambulances, for example, that UAE has, and this is public information, they do have special filtration systems for the engine and for the cab so they can drive into contaminated areas. But the civilian civil defense and EMS units, they don't have that particular capability.
They don't need it.
It's all internal.
Thank you.
Actually, Dr. Ziad, I will add just 1 or 2 points. At the end of the day, it depends on the budget. So if your agency has, quite a bit of budget, you can do whatever you want. For us, we have like decontamination unit for the EMS department, but our turnover number, let's say per hour, is no match to the fire department, and the fire department is no match to the National Guard, at least in where I'm from. But in other agencies, probably the military has much more resources. So we go back to the presentation, is ask for help. That's why you run incident command system. You ask all these agencies to buffer, because the last thing you want is you contaminate few ambulances and you still have to run day to day and actually minute to minute operations. So
yeah, that's a good point.
It depends on resources, basically.
All right. Big hand of applause to our speakers. Oh, did you have a question, Mazda? I'm sorry, I didn't see it. Go ahead. Okay, so let's go ahead and move on to the last part of our day with Mark Chambers and Tim Conley. Both of them are long-standing colleagues and partners with Minatox through the company Response Systems International. They are very active in the MENA region, actually, and do a lot of training on PPE, on decontamination, disaster preparedness and response. And actually, in the US, they do participate in disaster response for the federal government when needed. Their objectives are to show us some of the PPE that they have. Level C is what we're going to do.
We'll go through all.
Okay, very good. Do you want a microphone? You have. Would you like the one that you put on the ear?
About the suits, we'll actually start with the level A suit, and then the B suit, C suit, etc. Explain a little bit of each suit, but then focus on the level C. Level C is most common in the first receiver field. Or in the hospital setting. Well, there's a big difference in where you come from on your resources. Where I work, if you ask for a fire department hazmat team, you're waiting for an hour and a half. They're not fast. In most cases, the hazmat team will be committed to the scene. So now you're waiting for a farther away team. So our hospitals have to have their own decon capability and have to have their own teams. And Mark and I have actually taught at a number of hospitals together to build that capability. So we'll start with the suits. This is a level A suit. And Mark, you want to hold it up? Level A suit is one of the safest and most dangerous suits at the same time. And it's safest because it completely creates your own ecosystem. Nothing can get in, nothing can get out. It requires you to wear an air pack, a self-contained breathing apparatus with pressurized air. So the benefit is you're safe from nothing getting in. The downsides are your core temperature is going to go up fast. You know, you are your own ecosystem. Nothing escapes. There's no air movement. You know, so your core temperature goes up, the humidity builds up, your vision is off, and you have a very limited work time. So if you're wearing what they call an hour bottle, which means if you were sitting in a chair perfectly still in 100% shape, you could work for an hour. It's not true. Because you're moving, you're working, you're sweating. You all know as physicians that with your core temperature goes up, your tidal volume increases, you're burning through more air. All right? You also have to allow for decon time because you can't run out of air while you're being deconned. So you have to watch your air carefully, and I've seen people run out of air in the decon process and it does not go well. Okay? So it takes a lot of practice. In order to wear this suit, you have to, in the US, you have to go through almost 100 hours of training just to be able to wear the suit. And then in the states that I work in, you have to do 20 hours a year of continuing education to work in this suit. So it's not something that you can just jump into. Additionally, it's twice a year, Mark, you have to pressure test the suit. So 2 times a year, you have to test the suit, make sure it doesn't have any holes in it. Now, when you test the level B suits or the JS list, it's pretty simple. You can use flashlights, you can use other tricks. These actually have to be pressure tested. So that's a complex process in itself. It depends on your resources. Some larger organizations have the ability to pressurize it and test it. Some places do have to ship it out. But it's not something you can just do. You have to be trained in that process too. Okay? Again, the suit's fully integrated. You have gloves, you have boots. You're still required to wear the over boots that have the basic chemical protection and the over gloves that have the basic chemical protection. Also, where we teach people to wear medical gloves and then like a silver shield glove under that, and then a medical glove over that to help with dexterity a little bit under this. And then you'll have another glove over this. Well, technically you only need to wear 3. I always wear extra medical gloves over it. Reason being, the silver shields is what we call them. You have no dexterity. I mean, it's really hard to work in those. Where if you take a medical glove and put those over the silver shield, it helps with the dexterity and you can work a little bit better. I kind of do the same thing in level B suits, is I take the medical glove, go over the top of everything, and because that helps with the dexterity also.
Silver industrial gloves are not fitted, so they're kind of floppy on your fingers. So that's why he said.
I'm gonna ask a question here.
Mm-hmm.
I was in Abu Dhabi at the Ruwais Medical Center. Maybe I believe you all worked there a little bit. Yeah, in Ruwais.
Is that the one we taught it?
In Ruwais, and they have they actually they want to insert IVs with these suits on and intubate. And is this realistic to insert an IV with these 3-4 gloves on?
Not to do an IV, but to do an IO, it is. So what we typically teach is you can do, I've intubated in level A suit. I would prefer to put an eye gel in because initially that's just as effective. You can do tourniquets, you can do countermeasures, you know, Mark 1s or dual kits. You can do IOs. You know, if somebody needs an IV, they're gonna take an IO in that situation. So you can do IOs. We train people to do bleeding control, rotate tourniquets. So if somebody has massive arterial bleeding, put a tourniquet on, bring them into the decon process, decon them, apply a second tourniquet, remove the first one, decon them again, and they're good to go. So you can do a lot of treatment, and actually that's one of the things that we really push hard is by the time, if you have a number of patients, by the time they get through the decon process, they're going to be dead. So treat them before they go to decon. That's actually one of the principles Mark set when we was teaching in Abu Dhabi, was triage outside. So you're getting the right people to decon first. You know, don't try to treat everybody, use common sense. But stabilize the patient best you can before you get them into decon, or you're going to have a lot more fatalities.
What are some of the more common indications for the use of the level A suit? So
level A suit, I hate a level A suit. Everyone loves to put a level A suit on because it's cool. It looks hot, it's cool, you see it on TV. I hate level A suit. Level A suit I only wear if I have to make entry and I don't know what the product is, or as Dr. Nelson talked about, the SDS sheet says, this is really bad mojo. You need that level of protection to go in. If there's any way I can bump down to a B, especially a C, I do it as quickly as I can. Just because of the work time and that kind of stuff. So level A, to answer your question, is you don't know what the stuff is, or it's so bad
and
that you can't
what are some
get in.
examples, some chemical examples of so bad?
Well, off the top, if I was making entry into high concentration parathion or marathion, something like that, or
nerve agent.
What's that? Nerve agents, absolutely. Or the simple trick is, and this is what I call common sense hazmat, if you look in a room where there's a release and everyone's dead, it's immediately dangerous to life and health. That's a clear indication. Well, you got to go in eventually. But if you look in and they're still alive, that room's not an ideal H environment. So you can you can go in a B or you can go whatever if you don't have the A resources available right away.
And what is the cost?
That one I'm going to turn over to Mark because I don't know that one.
So the cost varies. And PPE in general, like Dr. Nelson said, it's a whole other world of details and intricacies and references. So a level A suit, for example, is called a level A because of the respiratory protection as designated by OSHA standards, not necessarily because of the chemical protection. So it's completely self-contained, has an element of chemical protection, and that's why it gets the level A designation. Now, however, the suit material itself can be a number of different materials. This particular one's a training suit. I think it's made by Kapler, maybe DuPont or Lakeland.
Yeah, it's DuPont.
It's DuPont. So there's several manufacturers that use proprietary materials to make their suits, and then they publish the breakthrough times of some of the more common chemicals that hazardous materials professionals would use the suits for, and that's kind of how you pick. So back to your question, when would you need a level A? I'll give you three scenarios. One will eliminate hospitals. There's virtually zero scenario in which hospital staff would need a level A. In the field medicine and responder world, we can get into this, but number one, it's a completely unknown agent with suspected IDLH levels of some sort. That's your level A. And number two, you know the agent, and the concentration dictates the use of a level A. So those are the two times you would want to use a level A.
Yeah.
Another question was, there's no reason to have this in an immersive one.
No, agreed. And just to reinforce that point,
You don't need it. You don't need it.
You know,
There's and the only way you would need a level A at a hospital is if the incident occurred at the hospital, and in that case, still the hospital staff would not be the ones responding to the incident. It would still be an outside agency that does this coming in. The hospital staff would be more in a reactive isolation, avoidance mode, protecting the area, getting people out and making sure that the contamination was controlled as much as possible so that these guys could come mitigate the actual event.
Yeah, just to reinforce that point a little bit, there's two scenarios where you get patients in ER. They're gonna self-transport to the ER, which is what 90% of them do in an emergency or a disaster. I think it's 93% is what the average is. If they were exposed to something, no matter how bad it was, and they were able to self-transport or get to the ER, how much exposure do they really have? Okay, they made it to the ER. They're still alive. They don't have a tremendous amount. They're not going to off-gas. They're not going to sing. So a level C is absolutely appropriate for that. The other scenario is they go down on scene. The fire department or the first responders or whoever are going to show up and decon them and then bring them to the facility. So again, you're only doing a secondary decon in level C. So I agree with Mark and Dr. Kazi. There's absolutely no reason to have anything more higher than level C at a healthcare institution.
And you do not need a level A for a radiological incident.
No. I would go in radiological. I personally would go in level C with a PAPR.
Level C on the scene and level D at the hospital.
Yeah, absolutely. Whenever you're talking about hazmat suits, you can always decon at one level lower than whatever the suit is. So if Mark's in a level A suit, I can be in a level B suit to decon him. Okay. All right, so any other questions on the level A suit? Okay, so level B suit is, it has splash protection as a suit. Would you mind, Mark? Sure. Okay, but you can see it does not have integrated gloves, boots. It could, but not all of them do. That kind of stuff. So it requires a little work or a little love to put it together. So there's gloves, you would wear medical gloves, and then the silver shield typically is what we would wear, and as Mark described, and then the outer glove, which is, I'll hold this, Mark, if you want to show them the outer glove over there.
An example of an outer glove.
This is butyl rubber. This is butyl rubber.
This is not butyl, this is another type of rubber. But butyl is, butyl's the gold standard for chemical. So if you know it's chemical, and you get a choice of glove, then butyl is what you want to choose. This is your standard hazardous material glove.
Okay. So you're going to have those gloves. Because it's not a fully sealed suit like a level A suit, you're going to need to tape the gloves, the boots that you'd wear over the suit, you need to tape those on, and you use chem tape. And a lot of people say it's duct tape, but it's really not. The chem tape has been rated for chemicals, just like the suit and the boots, because you can't just buy boots at Ace Hardware or at the hardware store and put them on. Those are rated boots, and they meet federal standards or for, go ahead, Mark.
I was just going to say, there's only two types of boots, at least available in the United States, that meet the chemical standards for chemical response. One is manufactured by a company called On Guard, and these will always be yellow or green with a yellow sole, so they're easy to recognize. The other is a boot called Tingley, which is an orange boot with a white or eggshell colored sole. So you can spot the real boots a mile away.
I didn't realize you were into fashion, Mark.
A little bit. Little bit.
Yeah. So the chem tape, again, the ones I've always seen have been yellow, and they say chem tape on them. And if you know the chemical, take a minute and research the breakthrough time on the tape too.
What
Just
about
don't
the
rely on the
biological?
suit.
What tape for the biological?
So biological, and feel free to jump in, please. Biological, the chem tape will cover it. If you've got a Ebola patient or something like that where decon is appropriate, the chem tape, all the same procedures will cover it. And I've never seen a biological agent that had a breakthrough time. So.
Yeah. Yeah, but
Yeah.
For bio, any tape that can stop airflow is sufficient. Duct tape's going to be the main one you're going to see in bio.
Yeah, I don't stock duct tape on mine just because I don't want people to get confused on game day at 3 o'clock in the morning when they haven't done this in a while, because then they might accidentally grab the duct tape and use the chem tape. It's kind of like train how you fight kind of deal. I made a mistake once. I was teaching somebody to operate a fire pump, and I didn't want to pull all this hose off, so I was showing them a lever to pull, so water would go out a different spot. Then we had a really big fire with people trapped, and he couldn't get water because he was pulling the lever he pulled in training and not the one he was supposed to do. So I kind of believe train like you fight. So if we're going to train, let's use the real stuff. So on game day, you use the real stuff.
So this tape, by the way, is the only tape in the world made specifically for chemical response. With ratings. So if you look, and we can pass this around if you like, right here on the label, it gives you the chemicals that it's been tested for, and it's a minimum breakthrough time of 480 minutes. So it doesn't, there are a lot of other chemicals it's fine for, but it just lists the main ones that's been tested for, and it doesn't make the list unless they can hold for at least 480 minutes. So you can.
Yeah, one more point on the level B suit, is that one requires a self-contained breathing apparatus to be considered level B. So you have to wear an air pack for that. And go along with that, you have to do fit testing and physicals. And before you put any suit on, you should do vital signs measurements and that kind of stuff before you put the suit on to make sure the patient's healthy to put the suit on. The funny part is, though, everyone sets a level of tachycardia. And on game day, everybody's tachycardic because something bad happened and they're putting a suit on. So, all right, so we'll talk about level C. Level C actually is the same suit. The difference between level B and level C is respiratory protection. So for level C, you can have two different types of respiratory protection. You can have an APR, air purifying respirator, and this is an APR. Okay, this is actually my deployment APR, the one that I bring with me when I'm deployed. Okay, and then this is a filter. It screws in here on the side, and we're actually going to address some sort of volunteers up in a minute. They kind of, well, you were voluntold. So, but this is a filter that you screw into here, and this filter is a CBRNE filter. If it's dry, it's rated for 7 hours on most chemical agents. If it's wet, that cuts it down to an hour. So if it gets wet, your evacuation time is a lot faster. It's not comfortable. No, with the product. Yeah. So this is, I mean, I've worked in this for probably 45 minutes to an hour comfortably. The difference between this and a PAPR, is everybody familiar with what a PAPR is? Is anybody not familiar with what a PAPR is? Okay. I can work much longer in a PAPR than I can in an APR. Because in an APR, I'm pulling air through the filter with my respirations. So without realizing, you're going to fatigue faster. You're going to dehydrate a little faster between that and the suit. So it works, and it's very safe. And I'd rather be in this than an air pack because I still have more work time, and I don't have to worry about running out of air. But I'd much rather be in a PAPR. I mean, I've worn a cooling vest. So in the U.S., they have a training facility, CDP. In a few years, I go there every couple of years just to keep my skills up. And a couple of years ago, I went to the hospital training program, and I worked during an exercise in 4 hours in Atlanta in August in a level C suit. And I was okay because I had a cooling vest on. And the air is moving in the suit and all that. So I would much rather be in a PAPR than an APR. But again, my deployment one, if something happens, I can put it on very quickly, and I'm good to go. Okay? All right, and we'll go through more of the level C when we bring our volunteers up. and and we'll go through this soon. We'll have Mark be our trained observer. One of the practices that I like, and it was a big topic during Ebola, is a trained observer. Somebody just standing back and just watching and make sure we're doing it right. Simple things with the chem tape. If you don't put a tab on the chem tape, you can't get the suit off. And people make that mistake at 3 o'clock in the morning. Have you ever made that mistake, doctor? Thanks for being honest about that. All right? So simple things like that, if you're doffing your suit, did you just make a mistake? Stop. Because a lot of times you make a mistake, you can fix it before you go to the next step. It's okay, we're going to change the order of things. So the trained observer for biological chem, I think, is a really good idea. Okay? So this is JS list. This is military protection. Okay? JS list, Mark, do you remember when you switched from MOP gear to JS? 04? Okay. JS is a joint service list, so all the U.S. military got together and they wanted a common system. So this is it. This particular one is missing its suspenders because it's kind of a teaching one and actually not a real one. But it's an absorbent kind of protection, which is a little bit different than how the civilian systems work.
It's charcoal lined. So it's a completely different approach to protection. It has a barrier like the other suits, but it doesn't have the same type of chemical materials. It's designed to breathe, so air can move in, but liquid has trouble, and liquid gets caught with the charcoal.
And you can wear this actually with VX.
Yeah.
If you had the appropriate CBRNE filter, you can.
Yeah, if you were in an APR, I'd be very comfortable. To be honest, I'd be as comfortable in this as I would in most of the other hazmat suits. This is actually reusable. You can wash it 6 times and keep reusing it. You can wear it for 24 hours in a contaminated environment. So it's actually it's very safe. It's got cinching, so you can cinch up under your boots. And actually, when you wear the coat, there's a strap. Would you mind showing them the strap, Mark, that goes on between the legs? There's a strap that goes between your legs to pull it in tight around your waist. It's actually, if you think about it, it's one of the best designs. It's flexible, it's easy to use, it's reusable. You can take it off, you can put it back on. Okay? Anything to add on the JS list, Mark, you can think of? All right. And then, Mark, would you mind showing them the vacuum pack?
Sure. So while we're talking about military, these guys, they often have bigger budgets than the rest of us do, so they come up with a lot of things. They also have the luxury of plenty of experiences to test things. So they teach us a lot. And one of the things that they've taught us is, the bare minimum grab-and-go PPE. They've done very well with that. And so
have a seat on stage.
This is an example of a little bag that they use for their grab-and-go PPE. You would put an APR, which is a mask and a filter, an FR57 from 3M, a CBRN filter, something like that. You would have your inner gloves, a pair of basically hospital, healthcare gloves. Throw your outer gloves in there. A vacuum-packed suit, rated however you want with chemical protective fabric to whatever degree you want. Maybe level B, maybe level C, whatever you want, but your suit's right here. You can use your regular shoes that you have on, and you throw these booties, rubber booties over the shoes and then tape, and you're ready to go. So all this fits in a nice little bag. You can keep it wherever you need to keep your emergency supplies, or in your vehicle, or at the nurse's station, Starbucks, wherever you want. You can do that. And before they do the demo, I wanted to talk a little bit more, just for a minute, on the selection of PPE. So you've got the A, B, C, and D, and the good doctor earlier talked about D. D would simply be any level of outer protection you desire, but no real respiratory protection. Possibly a mask, but not a fit-tested mask. So it's just a very rudimentary level of PPE. Throw on a rain jacket and a surgical mask, and some hospital gloves, you're in level D PPE. So, it helps, but it's not a real solution for anything. So when you select your PPE, you have to know that there are dozens and dozens of suits that are level B. And you have to select the one, that works best for your application, which is very difficult when you don't know exactly what your application will be. And so that presents a problem a lot of times. Tim talked about the trained observer. Each piece of PPE has its own very specific donning and doffing procedures. Every single suit is different from the other suits because it's based on the way that it's manufactured. Maybe it has integrated gloves, maybe it doesn't. Maybe it has a D-style hood instead of a Q-style hood. Maybe you use chem tape or duct tape. They're different procedures. Maybe you use these orange booties, maybe you use these boots. Depending on your application, maybe your gloves go, maybe your arm goes over your gloves, or maybe your gloves go over your arm piece. So you guys have to know this in hospitals. Based on your selection of PPE, you have to put this together. This is not commercially available. The donning and doffing procedure for your specific PPE, for your filter, for your mask, for your suit, for your hood, for your boots, all of that. And that's very difficult. We learned that we learned it long ago, but we relearned it during the recent Ebola crisis. And thankfully, one of our flagship universities, Emory, has a stellar interdepartment group that put together a very specific set of PPE that worked with the proper donning and doffing procedures. And they went several steps further, and this is available through Emory. They have a scenario-based chart or matrix. If we have this situation, we use this PPE, and this is the donning and doffing procedure for that. They furthered that, and you talked about earlier the trained observer. A trained observer came out of Emory's effort in better preparing the donning and doffing of PPE. So now there's an actual position in the process that has the procedure in front of them that watches you specifically and says, okay, step 2, you do this, and they make sure it's done correctly. Okay, step 3, you do this. This way, the wearer of the PPE isn't burdened by having to do all this mentally on their own. So the takeaway from that is be very specific and selective on what you choose for PPE, and also understand you have to generate procedure and policy based on that decision that you made. Otherwise, it won't work for you. It won't protect your employees or your staff from what you want to protect it from.
I'm going to go over putting a level C suit on with the APR. So before we put the suit on, a couple things we want to do. We want to get his vital signs, make sure he's fit for the suit. If he's got a fever, tachycardia is one of the things. If they're grossly tachycardic, don't put him in the suit. But to be honest, who's not going to be a little tachycardic when you're putting a suit on? So unless you do it every single day, you're going to be a little tachycardic. You got the stage fright going, exactly. Make sure that he's not dehydrated, he's not hypertensive, all those kind of things. Hungover. Not that ever happens. Okay. We're also going to want to make sure, at this time while he's getting him dressed, we're also going to want to be looking at the patients. And we were talking about this a little bit last night. When you have an incident, the fire department or whoever's on scene is going to take a long time to set up, to get down range to meet her. If they're coming to your hospital, look at the syndromes. Does it look like a nerve agent or organophosphate? Or let's get our Mark 1s or say that for me, Peter. Duodo, thank you. Get that ready. Those kind of things. There's a lot that we can do, especially as physicians, standing back a little bit and looking at the patient that the caregivers might not see because they're focused on getting suits on, all these kind of things. So kind of look at the people you're dealing with and get an idea of what you need. Okay, so first thing, you never want the person in the suit to dress themselves. Okay, I've dressed myself in an emergency before. But ideally, you don't want the person to dress themselves because they're expending energy, those kind of things. And who's had these suits on before? How warm are you in these suits? Even level C, you're sweaty fast. Okay, so you want to try to do as little as possible while they're getting you ready. And in fact, Andy should be sitting here drinking water. You should be pounding water to try to hydrate himself. And we all know it takes longer to get in your cells, but at least get some water going. So there's many names for it. Some people call it angel. Some people call it everything. I like the angel thing. So Peter's going to be his angel and help him dress. All right? So we're going to kick your feet off. Shoes off, I'm sorry. I should put the APR on now. Sorry, man, I saw this. Yeah. All right, so he's going to help him do that. While he's doing that, Andy would be putting medical gloves on. The bottom layer is always a medical glove, so it makes it easier in the doffing process, and in the decon and doffing process. So he's going to slide those in. You notice he took his shoes off because we're using this boot. As Mark said, if you're using that boot and that suit, you would leave your shoes on and this all goes over it. But because we're using this one, we're going to take the shoes off. I prefer myself to use this type of setup because when I use this one, I don't have that big of feet, but when I use this one, every time my feet or my shoes get caught in the suit. Just for my thing. All right, so we're going to go ahead and stand up. Okay. We're going to slide the arms in, but we're not going to zip it up. Okay. Go ahead and sit back down when you're ready. Okay. And you can see why it takes a little bit of a help. All right, so go ahead and sit back down. So we're not going to zip it up. The reason being, once we zip it up, he starts cooking. He starts getting hotter. And we got to do some work before he's ready to go. So we'll go ahead and put the boots on. What's that?
Headstand's going to be hard.
Andy wants to try to do a headstand in the suit, handstand in the suit. It's a training suit, I promise. All right. But that can happen in real life. It's time to change suits.
What size shoe do you wear? 12. Yeah, those are 13. You want to go, usually you want to go 2 sizes up on your outer boot from your natural shoe fit.
Unless you want to be like this the entire day. All right. So if you got more than one person helping him, he's got his medical gloves on. You can be sliding these gloves over his medical gloves, as Mark talked about with the several shields. Where did duct tape go, Mark? The chem tape?
We didn't have. Oh, we're not.
I'm not going to open it, but I'm just going to show him.
Oh, there's some in here.
Okay. So at this point, we're going to put the chem tape around the boots. And he would have the gloves on. He would have medical gloves, depending on the chemical, the silver shield, and then these gloves over. So why don't you throw these gloves on, Peter? Okay.
So again, depending on the application and the style of suit. So for example, if he had a suit that did not include the footies, the feet in the suit, he would have the option of putting the legs over the boots. So for example, he was working in a very wet environment, that contaminated material would run on the outside and not so much risk going inside the boot. So because he's wearing a footed suit and his boots are over, we have this entry point there. And so when we tape that, we want to make very sure that nothing can get in that. One of the major pitfalls that we see in people as they start out in the hazmat business is they tape too tightly and there's a circulation issue. So you want to make sure that you do that correctly. This is not something anyone can do without a serious amount of practice, a serious amount of training. Virtually everything that you do here can cause injury or even death if it's not done correctly. And those stakes go way up when you're dealing with some certain chemicals like VX, but more importantly, biological agents.
Okay. So the next step is we'd start taping the boots, the gloves, all those kind of things. Again, we're not zipping up until we have to. So when you tape, which we're not going to tape, that kind of stuff, but when you tape, you want to make, people make tabs like this. You have to remember, in most cases, he's going to have to try to take that tape off himself as part of the decon process. So when you make a tab, unless you don't like them, that's a tab. Be generous. Something they can grab with their whole hand and pull, so they're not trying to grab the little things. Okay? So you would tape here. What's that?
So death is not part of the
Exactly. And I'll even ask, if I'm the angel, I'll even ask the person, are you right-handed or left-handed? You know, because that way I know where to put the tab to make it easier for them. You know, put both tabs on this side, put both tabs on that side, whatever is going to be easier for them. Also, don't wrap it 12 times. Okay? Just go around so you can seal it and leave it at that. When you wrap it 12 times, then I have to get a seatbelt cutter out and cut myself out of the suit, and I don't enjoy that. Okay? So, which again, we're not going to actually tape. So at this point, we would go ahead and stand up for a second. We go ahead and zip them up to about here. All right. So again, this is the APR, and then this is the filter. These filters have a little tab right here. I've watched many times people put this in the mask when it's on, and they can't breathe, and they wonder why. Make sure you pull that tab. This particular APR, and some of them are different, are designed to have a cap on one side and screw in on the other. Okay? So when he puts this mask on, before he puts the filter on, you want to do a safety check to make sure you have a seal, which we'll do. So he'll have the mask on, he'll cover this filter, and then suck in, and the mask should collapse to his face. If air leaks in, it's going to leak in when he's breathing it, so we have to readjust it and make sure that he's got a good seal. So you might want to lose your glasses for that part. So there's a couple of things you can do. If you got lots of money, you can actually get the masks with your prescription. For everyone else in the world, they make little things that will hold your glasses in place without the side portions. So, and that's what most people do, is they just get the holders within their mask.
Okay. Tim, before you put him in the mask, Dr. Bahshat has to catch a flight.
Mm-hmm.
He wants to say just goodbye.
Okay, absolutely.
Because he may take more than 15 minutes.
I'm sorry. Thank you very much. We are working together since 4 days. We are very pleased from our side, from Turkish side and EPAT, and also Minatox. Thank you very much for all speakers, for all participants. Please forgive us for lax and deficiency. As for EPAT size, it is our, I kind of asked you if you can send what does done good, what needs to be improved. It will be our pleasure if we get. Yeah, thank you very much. Just one sentence. There is a very famous from India. He's one of the past president of the India. He's not just a politician; he's also a philosopher. His name is Abdul Karim, I think. Abdul Kalam has a very, very good suggestion. Just one of them. He said, "The dream is nothing that while you are you see while sleeping you see it. Dream is the thing that doesn't make you to sleep." Yes, I think as a Turkish emergency physician, we come over 1 hour dream. Thank you very much.
Thank you.
You are welcome, everybody. I wish you to reach your family in safe.
Thank you so much. Thank you. Thank you. Thank you for the support.
No problem. He wants to see the handstand. All right, so we're going to go put the mask on. And again, he's not doing it himself. He's having somebody help him. Okay? So once he gets the mask on, we'll put the hood up. We'll check the safety. We'll duct tape, screw in the filter, and he's ready to go. This will be type C because it's air purifying and not an air pack on his back.
So the major difference in B and C is B, you have your own air in a bottle. Or yeah, it's like a vest with it, like the firefighters have. That's B, or they have what they call supplied air, which is a big hose that goes into your suit that runs to an air generator. Level C is an air filter of any type. Pepper, this type, there are other types. If you're filtering the air, it's level C. If you're bringing your own air in a bottle, it's level B. If your own air in the bottle is inside your suit, it's level A.
All right. So this particular one has tape here that you can peel off and secure. Check his tape. Just do, the trained observer, as Mark explained, would do a safety check. Make sure we didn't miss nothing. You good to go? Yeah. All right. And then he's off to decon or do whatever his mission is for the day. Okay. What? Ask Dr. Kazi.
So we're not going to go through the doffing procedures, but you guys get the idea. Just like there's a very specific, oh, he's really going to do it.
Please get a picture of this.
No good. No dice.
All right.
So just like there's a very specific procedure of how to put it on, there's a very specific procedure to take it off. The doffing or taking it off is actually more important than putting it on. As we learned in the Ebola event as well, most of the healthcare providers' infections were caused by improper doffing of the PPE. They took it off wrong and infected themselves. So it's very, very important.
Yeah, and just to reinforce it, I think Mark hit it, but it's such an important point, is that's the importance of that trained observer. Because when he comes out, he's hot, he's tired, he's sweaty, he wants water, he wants air conditioning, he wants to sit down. Would you agree after being in this right now? Those are the things you want. You want out of this suit. So if you don't, like Mark said, if you don't have that trained observer, mistakes are going to get made. Okay. Any other questions about this, or do we want to let him bake for a little while?
You can get him out of it.
All in favor of baking him?
We do get cases occasionally where we have given antivenom and there is refractory coagulopathy. For us, for me, I rarely found the antivenom is not working. I cannot remember maybe few cases.
And then, though we are sharing the same, and that's the other point, though we are supposedly sharing the same species and the same use of the antivenom, we give way more doses than how much.
Maybe you have other new species which are not covered. That is what is. I'm sure, if you in Oman, do you know which types of snakes are available in each area?
We know.
It's available there.
I don't think you exactly know what exactly is there. Nobody knows exactly what's there.
Well,
I mean, we know historic data,
Universities,
anecdotal data.
I think universities, they have data.
We have good data on the type of species that we have in the country.
Not published.
It is there. Maybe not published, but it is there.
The WHO don't have it. Even as grey, they call it grey data, which is unpublished, governmental data. It's not there.
It is available.
But, okay.
But there isn't any specialized herpetologist in the area?
There is.
Yeah, so they know.
They would know.
Like in Lebanon also, there is one only few published, but there is a good...
Yeah, Ashraf, this is another problem in the MENA region. Data are there but not published, and we do not have access to these data.
No,
but I'm sure if you will look, you will find it.
I will show you the slides. They will show published. They have everything.
Yeah, because they will check from where they will have their data.
Governmentals. They go to the government.
No, I don't think they will have it.
So WHO, let's be clear, WHO, they don't go governmental. WHO, they go to Ministry of Health. And
yeah, Ministry of Health is the government.
No. It's different there. So the one who's taking care of this, responsible for this, is Ministry of Agriculture or Ministry of
Environment
Education or Environment or universities.
So universities, snakes?
Yes.
Yeah.
So it is not the Ministry of Health. It's the College of Science and the universities usually, and that's the situation we have there in Oman. Yeah. And so WHO are basically reaching their own agency to get the information from. And most of the time there is no much collaboration between the two. So even if you are approaching the Ministry of Health and assuming that the Ministry of Health will get you the information, they will only provide what they have, but not what the others have.
Interesting. I didn't know that.
Yeah. So you cannot rely even on the. I mean, WHO send the guidelines about the management of snake envenomation. We don't use it at all because
that's African.
Yeah.
It does not.
Yes, that's African. Well, at least I talk from experience in North Africa. We don't know what's going on.
See, in today's date and time, if we say that I'm talking from experience, which is unpublished, nobody would believe.
Yeah.
Doesn't stand anywhere.
Yeah.
So I think the first step, forget the collaboration, go back to your own hospitals or your institutes. If you have a poison center, start making a local snake bite registry. What you can do at Minatox is make it similar. You know?
Yeah, so that's what it should be, and then you have that collective.
If you say that Minatox has made a snake bite registry, then you will have to go through the whole ministry setup and get permissions to
We're not going to do it in that formal way. We're just trying to.
What I'm trying to say is that you start doing it individual levels, start collecting the similar kind of data.
Exactly.
And
But
then
that's the
share it
collaboration we're
at
talking
this.
about. Yeah, that's the collaboration we're talking about. Is to have it in different area, whatever, whichever way it's going to be. And just try to start to collect.
And it won't be a bad idea if you are making a workshop on envenomation to invite your herpetologist who has actually seen the snake. Because they would have a reasonably good idea what are they dealing with.
I think, so the hepatologists that you have in Oman, Badriya.
Yes.
So do you use them a lot? Do you?
When we have difficult cases, like we don't know exactly what's going on, and we have the snake, we do contact them to identify the snake.
So keep those snakes preserved if you can. Make a museum, keep those snakes preserved, whatever you can get, because that will help you.
So
is that right what I'm saying?
Yes.
Because if you keep those snakes preserved, at least later on it can be used to teach, show the clinician, what you see on the picture sometimes, and what you see real snake may be a little different.
Yeah. Do any center or any one of you have already a file to collect the data?
Yeah, I do.
Do you have?
I do. I'm using the.
Do you have Badriya?
Data
The file to collect the data.
Like a database for snake envenomation.
Yeah, so a file to collect the data. So maybe we can take all the files, compare them, and make a common file, and send them to everybody, so that everybody has the same kind of data.
Same kind,
Yeah, so that's what we will.
And then we can start.
Yeah. So I think that's what we should start with, is to unify the form to collect this data.
The sheet of
the sheet, that's
to
correct.
Collect. So I think somebody has to collect all the sheets and make it.
And then look at them. And we can do it in a year, we can do it on a regular basis. We can create it.
Whenever you meet at Minatox.
Actually, I found a nice article recently published about all the terrestrial venomous snakes in the Middle East and Toxicon. So it combines all the different areas in the Middle East. And it's an excellent article that I found through ResearchGate. I told him, can you share, because he cited my article. So, and they talk about different, like Oman, like in Jordan, like all the different areas.
But this is not based on.
Right.
The article was written by actually people from the UK and Jordan, by Zuhair Ahmed, Hamad Abu Bakr, and David Warren. And it was published in Toxicon.
When was it published?
It was just published, actually. Like
Yeah.
very
Is
recently.
this
2020 now, and I asked him to share the
Yeah.
article.
And do they have a list of parameters to collect? Or
Everything. I mean, they have literally
I mean, that
a
model
lot
I
of
was
all
with
the
it.
countries.
Yes.
All the with pictures with anti-venom from where they're getting it, the complications even. Certain cases.
So that's a theoretical.
Theoretical.
Yeah, I got
Very
it.
interesting.
David Wall, I met with him in Australia. I don't know if anybody knows David Wall. You know him,
David Warren.
David Warren.
David Warren.
You know him, but
Who's written this article? David Warren.
David Warren.
The person from Middle East,
Jordan.
Is he a physician? Is he a herpetologist?
The biology department and the Department of Biological Sciences. So I would think he's a.
So he's not a doctor, most
herpetologist
likely.
or-
So that's what I'm. That's the point I'm trying to make.
Yeah.
No, but
You know-
but I think Bruno was right on the spot. This is a theoretical.
It's a theoretical
view.
Yeah.
It's not based on
data.
But it's
There's
based
no
on
data.
the published articles and data from other places. in
There is
other
no-
countries.
there's not
For
much,
example, I published about Lebanon all what we know about our snakes.
Yeah.
And then he used
Lebanon
material
you
from
have.
Lebanon, and he used similarly from different.
I'll tell you an
places.
example. I'm
and
not
then-
trying to there is no data. There is no data. I'm telling you. Lebanon you have, and I know you have, and I've read your article. Saudi Arabia they have. Oman they have some. They have some. The rest is nothing. I mean, so that's the
See,
issue.
the point which I'm trying to make is, you are a clinician, I'm a clinician. If a person comes to me with a snake bite which is resembling viper bite, I'd say this is a viper bite. And that's it.
It's correct.
Right? I haven't seen this snake. What viper? You know, why I'm trying to make this issue is because we believed for donkey's years that we have only 4 toxic snakes. But now we have found that there are more.
Interesting.
You know, there are at least 4 more toxic snakes and we have no antivenom for them.
That's probably tally with what.
That's what she was trying to say, that we end up with
doesn't
patients
work.
who
Antivenom
have
doesn't work.
persistent coagulopathy. We will still label it as viper. So when we publish it, it will get published as viper, and somebody who quotes it will quote it as viper. But what kind of viper? That is where the herpetologist would come in and tell you, you know, what kind of snakes are prevalent in that particular area.
I understand.
And then you go from there. What do you think? Yes. I'm right, because if I write neurotoxic and I write that it is cobra,
look,
it'll get recorded in the medical sheet as cobra. It will be cited as cobra.
But
it'll just go as cobra everywhere.
Yeah, but
Maybe
you
it
need.
will be like cobra is causing coagulopathy.
Yes,
and this
yes,
is
but you need both.
That's,
But you need
that's
both.
what I'm trying to tell you. This is the problem.
No, but you need
With
both.
the physicians,
Ashish.
most
You
of the
need, you
time.
need both.
You need both.
You need the
right? You
clinicians
need-
and you need somebody.
You need both, but you need someone who will identify what snakes are.
Yes,
We had Ian Simpson who worked with us on this project, and Bob Norris from Stanford. So they went all over the country. They didn't only meet the physicians. They went to the villages. They met these snake charmers, these snake catchers. Looked at what snakes were. And then they came out that there are more, which you don't know.
So I think the best step now is, I think what we do, we will start with this data sheet with the guys. We start with this data sheet. And we send it and people start to collect. And whenever you have the opportunity to ask a herpetologist, get him to identify or take a picture.
You can take a picture also if you have a dead snake and you
Not
can't
smashed.
store it.
Not smashed snake.
No, even
Even
see,
if
for
it's
them,
smashed,
even
they
if
can-
it is smashed,
Listen.
even if the head is smashed,
No,
they can identify by
probably,
the
yeah.
scales. So So if you have a good picture, they can sometimes, but obviously if you have a snake in front, then it's better.
But we have to start from one point.
One point.
If we don't start,
You
I
just
think,
keep discussing.
We'll be at the same point next year. So
one of my...
I think the easiest is to start by sheep. So maybe you, Ashraf.
I will start it and I will send it to everybody to edit it. I have it, so I'm just going to send it to you.
Yeah, but maybe first all the people can send you their own sheet.
Okay. Okay.
Do
you want to send me yours?
You have one sheet to collect
The
that?
the sheet. Saudi and
we don't have across all level. No.
But you have one you.
I have one what appears on our center.
Okay, can you send it to Ashraf?
Can you send it to me?
Yeah, it's I have the article, the details are
Make an announcement.
Send it to him. So
Do you mind?
all will send you their own sheet.
Yes.
And then you can make a common sheet by taking all the parameters.
Variants, yes.
And then
Send
it to everybody. We criticize, we give our opinion, and we send it back to you. And then you make the final version and you send it to everybody.
Yeah.
So that
collect data.
Yes.
So the ones that I know it's limited because one center, but this is was done in collaboration with herpetologists, which is the best one in Lebanon, and we know about all our like spiders or snakes or lizards or so.
No, probably it's good, but he has to say it's applicable everywhere.
Correct.
That's the important thing. What you just said, applicable everywhere. Now, if you write that you want to do some fancy coagulation parameter as a data collection, may not work. So you need to know what is available where and what can easily be done across the board. So that is again important.
Yeah.
Let's say somebody says thromboelastography for every patient who comes with coagulopathy. May not be available.
No. It's true. Just need
Okay, so it was a good introduction.
That's a very good introduction, actually.
So now we can maybe start different lectures, make them more interactive.
So we'll make it, so how 20 minutes?
Yeah, take your time.
So welcome everybody, just for the snake information. This is the second year we do this and hopefully we'll carry on doing it. Every year it's an important issue that's not only in the Middle East but worldwide, as everybody probably aware. That there are more than 3,000 species of snakes, 250 are of medical importance, and WHO classified them of category 1 and category 2 based on whether they're high or low venomous snakes and the encounter with human and the effect that they cause on human category 1, category 2. And as just we tried to discuss earlier, the Middle East in somewhere between, every country have between 4 and 9 medically important snake species. So we are not as bad as Southeast Asia or Sub-Saharan Africa or South America, but nonetheless, we have our own share of bad snakes. So in terms of the types of venomous snakes, I'm going to concentrate today on Lapid and Vibridii because this is what we have mainly here. So the elapids, as you know, the cobras, the mambas, the coral snakes, they're typically neurotoxics, but not exclusively neurotoxics, short front-fang snakes. The Vibridii, they have two, the true vipers and the pit vipers, hollow long hinged fangs that inject and withdraw. They are commonly necrotizing, hemotoxic, and anticoagulant. However, you do have anticoagulant, necrotizing, and hemotoxic, but you do have the neurotoxic ones. Example, Namahabi rattlesnakes. Sorry. So, in terms of just a bit of definitions, the venoms is a mixture of toxic proteins and peptides, and the toxin is a pure toxic substance with natural origin. Snake venom is a product of protein synthesis, and it's a mixture of enzymes and toxins. And there are about 20 types of toxin known, and there are so many unknown yet of toxic enzymes. Some of them are very specific. They go and target specific areas in the body, and they don't touch others, while others have effect on different areas. And it's so the snakes. So the function of this venom is three things: acquire the prey, digest the prey, and defense against enemies. So this is extremely important, because in no way in the evolution of the snake that the venom being produced to cause consumptive coagulopathy, that does not serve the snake purpose in any way, shape, or form. Because what you need, the snake need if you need to kill, to eat. So the effect of that hemotoxic effect of the snake bites, compared to on a small prey like a bird, it's completely different from a bite on a human. The effect on a small prey is sudden thrombotic effect that will kill the prey instantly, while in human it gives you consumptive coagulopathy, which will carry on for days or hours and days. So the effect is different. So that's that we need to understand. The other things which is important, some classifications which say elapids are neurotoxic and vibridiaes are hemorrhagics, which is a completely wrong definition, because some elapids have both local local toxins and hemotoxics, and vice versa. Some of the vibridiaes have neurotoxin. So the notion that elapids are neurotoxin and vibridiaes are hemotoxic, hemorrhagic is a completely inaccurate classification. So neurotoxins mainly are elapids, but as we said, they are in the vipers, like the Sri Lankan Russell vipers and some European adders, the multiplayer snakes. They have neurotoxins, and it's very unique. It is very important to understand what sort of neurotoxins that you have in your region, because the management is different. Because of the mechanism of action is different. So if you look at, so we have two types, either presynaptic neurotoxin or postsynaptic neurotoxin. So the presynaptic neurotoxin, which is mainly phospholipase A2, and the postsynaptic, which is mainly polypeptides. So talks about the presynaptic neurotoxin. What they do, they come, attach to the presynaptic membrane, enter into the cell, damage the synapses, release the acetylcholine, causing a surge of acetylcholine, depleted, followed by paralysis. That process is irreversible. As soon as it starts and the damage happens, it is, as much as you give antivenom, it's not going to work. And you just need to wait for the axons to start to repair, which just takes days, weeks, or whatever. In reverse, the postsynaptic, they block the receptors on the postsynaptic membrane, so they stop the acetylcholine from working. So displacing the acetylcholine from that receptors will give you a recovery. So giving antivenom, anticholinesterase, which some people try, will help, is a form of a treatment. So that's an extremely important distinction that one has to make when looking at the neurotoxins. So presynaptic neurotoxin usually take more than an hour to develop by the toxin to reach the motor in the plate and start to work. And as we said, this is the damage cannot reverse. If damage starts, you can't reverse it. And good example, your crates, your tiger snakes, and taipans. The postsynaptic neurotoxins, which we're mostly talking about the cobras, they are polypeptides, bangarotoxin and cobra toxins. And as we said, they attach to the postsynaptic membrane and they block the receptors. You displace them, you get some recovery. Now it's been, I don't know from experience of the panel here, but it's been postulated that the paralysis you get with the presynaptics are tend to be worse and more severe, and probably that has something to do with the way that they damage the synapses completely. However, there's published data now with the cobras that they are life-threatening. Paralysis has been documented with the postsynaptics neurotoxins. There are other two types of neurotoxins, dendrotoxins and fasciculins, and good example for those is the mamba, the black mamba, the African black mamba, where they work synergetically. So the dendrotoxins will do the presynaptic effect, they will go into the cells, they damage the synapses, they release acetylcholine, and the fasciculins will block the anticholinesterase. So the surge of the acetylcholine will continue, and that will give you the paralysis. It augments the paralytic effect. There is the Taiwan, the Chinese branded crate has a unique neurotoxin. Anybody knows what is it? It has both the pre and postsynaptic neurotoxins. And this is a unique thing for the Taiwan branded crates, or Chinese branded crates. Time of onset of paralysis, as we said, it may take more than an hour. It usually starts with tingling, numbness, sensation, then the cranial nerve first to start to get affected. Bit of ptosis followed by ophthalmoplegia. 6 nerves usually start to affect first, and it progresses from there on. And then you start to lose your reflexes, and you start to have respiratory depression, and death. And this is the best example how to start with the ptosis, your ophthalmoplegia left the 6th nerve palsy, faceless or expressless faces, and then fixed dilated. So that's pretty much about neurotoxins. Then you have the myotoxins. And the myotoxins, you have the two types. That you have the local and you have the systemic. Systemic is associated with potential, it's devastating and lethal. And the locals, it works on different effects. Before that, we ought to say, not only skeletal muscles get affected by myotoxins. Although smooth muscles very rarely get affected, you have the cardiotoxins. There have been documented cases of severe cardiotoxicity and cardiomyopathy following snakes and venomation. Though it's not clear whether that's a direct effect or indirect effect of being sick and etc. Having said that, you have the local myotoxin and the systemic myotoxins. The local myotoxins, the most important, the snake venom metalloproteinases, which we're going to talk about later, which have both direct and indirect effect. So it causes damage to the muscles by this myotoxicity, plus the edema and the ischemia surrounding it, and the hemorrhagic effect on the capillary leak. It will give you the indirect myotoxic effect. Local myotoxin cause damage to the basement membrane. The systemic myotoxins, they don't do that, and there is some differences, and we'll show you it later how that's important. And then you go to the systemic myotoxin, and there are two types here. The ones which are pure myotoxins, they go systematically, but they don't affect anything else apart from the muscles. And the phospholipase A, which affect both. The presynaptic neurotoxin also have an effect of the muscles. Now, it's been postulated that the pure myotoxin is more associated with more severe rhabdomyolysis and muscle damage effect because the presynaptic, the mix, they have the diluted, the acceptors of the enzyme, the enzymes are different, so and they don't cause damages on other organs or other tissues, so you get a diluted effect on the muscles. Not sure how true is that. So chemical types of mytoxins, we said there's some cardiotoxins, the phospholipase A, and non-neurotoxin mytoxins. Not going to dwell too much on that. And this is an interesting slide. Tiger, I think. Yeah, a tiger snake, phospholipase A2, injected into a rat's skeletal muscles. After 3 hours, the damage, 24-hour transverse section, and 24-hour longitudinal section. Yeah, so we discussed this, that some of the mytoxins, they don't specifically attach to certain acceptors and attach to many acceptors, but the damage only on skeletal muscles, acceptors or receptors, and you end up with a systemic muscle effect, but that not necessarily a severe one. The ones who are attached specifically to certain acceptors on skeletal muscles, they tend to cause more systemic effect because of the concentration phenomena. With systemic effect, the basic membrane remain intact, so regeneration is muscles can occur. However, you get a regeneration only of slow twitching muscles, and this is an effect of, see, the long-lasting effect of the systemic myotoxic of snake bite. And when we talk about mytoxins, we talk about rhabdomyolysis, which can be severe, very, very severe, and end up with renal failure, hyperkalemia, etc. And the long-lasting effect of muscle wasting if the inflammation was severe with systemic effect. Urolipids, many Australians, licked crates, sea snakes. Do you see Ashish in India?
Sea snakes? No, we don't.
No, so your crates, do they cause mytoxicity?
No, we haven't seen any mytoxicity.
No. The vibridii, some Americans, rattlesnakes, or American colleagues, mytoxic effect is a lot.
You see it, yeah. You actually can see myokemia with lots of even the non-Mojave rattlesnakes.
They do?
Yeah, and you see muscle breakdown. CK goes up all the time.
Yeah. Talking about the hundreds of thousands of snakes.
What was that?
The CKs.
CK goes actually in the tens of thousands, not hundreds of thousands.
Okay.
It's not
and the long-lasting, is there the systemic long-lasting disabilities effect of muscle wasting?
Very few chronic effect that we see. There's some local effects in terms of if it's your fingers, toes, you see some waste is there, you can see some.
But that's most of the probably a necrotic effect.
Yeah, it's not, and very rare you see like neuropathy here and there because post-acute inflammation.
Yeah, that's correct. Okay, interesting. So the coagulopathy, and this is an interesting subject. And as I was saying earlier, the snakes in their evolution, they did not intend evolution did not bring them to the point that they wanted to cause coagulopathy in their prey. It does not serve them any purpose. The effect of the same venom on the small prey is completely different on a human. They wanted to paralyze the prey and get it eaten. They're not interested to let it go for bleeding for a day or two. So your consumptive coagulopathy, thrombotic, anticoagulant, antiplatelet, and direct hemorrhagic effect. And you can find a single toxin which has two different effects and augment its action. We'll talk about it in a minute. Most species have hemorrhagic effects, hemorrhagic toxins. So, for example, the metalloproteinase prothrombin activator of the EK species has also a hemorrhagic effect. So the concept started the concept of coagulopathy that activate the prothrombin activators that the coagulopathy, the consumption. Meanwhile, the hemorrhagians cause the damage to the blood vessel wall, give you a shear stress effect, and that will augment the bleeding. so you get worse bleeding. And in a study, they compared the efficacy or the potency of the prothrombin activators of the Australian lipid and the ACEs, found that the potency of the prothrombin activators in the ACEs much more potent than the Australian. However, the bleeding is worse with the ACEs than with the Australian lipid, and they put that down to the effect of the augmenting effect of both the consumptive coagulopathy and hemorrhaging effect. It used to be called BIC, which is wrong descriptions, and it's basically that you activate the coagulation cascade to the point that you consume all of your coagulation factors. And you have three types of activators, the prothrombin activators, the factor 10 and 5, and thrombin-like enzymes. And you end up into that circle until you consume all of your factors. And it's give you somehow clinical biochemical picture similar to DIC, but it's not DIC, because as you know, DIC is associated with multi-organ failure and it's associated with much worse prognoses. So we discussed that earlier. Don't want to go through it. Now, anybody has any experience using point of care INR for snake envenomation? I don't know. It's just interesting to mention it here. It should not be done in snake envenomation because of the fact, and this is proven. There's a couple of studies on this. Because of the fact is the laboratory tests on INR test the clot formation. So you get the blood, you get the plasma, you add to the tissue factors, and then measure the time to form a clot, and that's what you need. But when you use the point of care, it will give you. They will add the tissue factor, and then they will add a substrate, which is electro substrate, something substrate. And then they see the cleavage, the thrombin cleavage of that substrate, and they measure that. And that's the wrong way of measuring INR in this situation, because thrombin is always there. But you don't want the thrombin, you want the clot. So it gives you a wrong reading, and it tells you it's normal, while it's not normal. So point of care of INR is pointless. Sorry to mention that as well. I thought it was a bit of an interesting point. Although you might be bitten by snakes who has hemorrhagic or hemostasis effects, not all of them can give you the clinically significant bleed. Some of them get unseen. And this activity of the bleedings might cross over with the necrotic effect, the cytotoxic effect. You get bitten here, there's some necrosis, you have direct effect on the blood vessels and start the oozing. And as soon as the systemic effect of coagulopathy on the antithrombotic or the antiplatelet aggregation, you start this get worse and worse. In terms of necrotoxicity, not well understood, but it probably is related to phospholipase A2 and the metalloproteinases, which has several reaching effects, so we're going to discuss briefly in a minute. And also the secondary effect. It used to be thought that the necrosis or the local effect is not of a significantly clinical importance, but that was, again, a misconception. It has a major devastating effect on the life of the person who's getting bitten by venoms which has a local necrotic effect, not only from an immediate clinical point of view, where you have fluid shift and you have hypotension and shock, infection, which can be devastating. You end up with severe morbidity and mortality. And for these areas where the most snake envenomation happen, these people are manual laborer, and any form of disability is a devastating effect on them on their family. Yeah, so, and as you know, there are several snake species who are linked with local injuries, and that span the whole 4 species that we have. Yeah, so the hemorrhagine metalloproteinases, SDM, there are 4 classes, and the effect is they have a wide range of effects, some of them locals and some of them not local, and it is in a way, main effect is to immobilize the prey and digest the prey. And an interesting fact is that the vipers and culprits feed on what they call type 3 prey, which is big and heavy-bodied. So they need an enzyme which can digest the prey. So they have a large, they have prominent SVMPs in their venom. The elapids, they usually tend to feed on elongated low volume surface to ratio. And for that, they don't need to a potent SVM to digest the prey, so it's not a prominent toxin. And we talked about the effect of the CMV. They damage the basic membrane, cause local hemorrhage, shock and secondary effect, ischemic change, and direct and indirect injury. I think finally the renal toxicity, again, there are some renal toxins, and it's been proven that there are some renal toxic enzymes. However, from experience, from anecdotal evidence and from some literature data, the most prevalent is a secondary effect because of the shock, the infection, etc. And the pathology is varied between acute tubular necrosis to bilateral cortical necrosis in severe inflammation. I don't know if we have a Turkish, no we don't, so just for interest for the people here, they have in Turkey, they have mainly the vipers. I think they have 11 vipers types, and they have the one cobras more than the cobra. In terms of the vipers, the procoagulants and hemorrhagens, that's the main toxins, and their neurotoxic is postsynaptic neurotoxic. Just the last couple of slides, just what to tell. This was not intended for you guys, it was intended for general physician or AR physician, but just want to tell them not every bite is a wet bite, not every bite is going to give you inflammation. There's some studies suggest up to 80% of soft-scale viper inflammations are dry bite. And there's a lot of various reasons why can that happen. So not every bite has to be given antivenom. And unfortunately, for our colleagues from the West, the cultures in the Middle East and here is, when a patient comes, you want to do something, and you show the family that you're doing something. And this is huge impact on the decision making for the doctors. So when somebody comes with snake, to come to the family and give it to teach them, oh, it's a dry bite, it's nothing, we'll wait and see. You are unlikely you're going to get somewhere with that. And if anything happened later on, it's not like you've evidence-based your decision. You made a mistake. And that has an influence on decision making. And I was with Badria just recently in the emergency Society of Emergency Society, the Emiratis one.
Emirates Society of Emergency Medicine.
Yeah, we did a track on toxicology and we talked about inflammation. And after that, 3 people came to me, 3 doctors who works in the peripheries of the main cities, and they told me that they had same experiences, copycat. Inflammation, dry, no symptoms, whatsoever. And all 3 of them, they gave an antivenom. All three of them. And then I asked them, all three of them, and then I asked them, I mean, I just tried to elaborate, and they all say the same. It's a family pressure or something down that line. So it's a way to go. I think we've discussed this. I don't need to dwell about this too much. Anaphylaxis, that's a very important aspect that can happen with any snake inflammations, and the management is following your ACLS, and it is a feature of systemic inflammation and its indication of antivenom, a topic which Dr. Ashish will talk to us about it. Thank you very much. I'm sure you don't have any questions. I'm sure you're
just going to kind of, some of the slides I'll rapidly skip through. Touch our life in Southeast Asia, every possible way, worshipped as God in India. And yesterday was Mahashivratri, where you worship actually snakes, right? Source of living for many, food for many, wine, and then lots of movies. Right now, currently, the #2 ranked serial in India is on a snake, right? And then there is fashion, jewels, and tattoos, and pets. And this is me.
Someone is holding it.
Much younger.
Much younger.
Yesterday.
And the deadliest animal in the world is human. So, this is a person who was a priest in a local temple. Probably had developed immunity because he was maybe bitten again and again and again. But why did the cobra die?
Nobody knows.
Nobody knows. These slides you've already seen, so I'll not show them again to you. Know about what are the 4. These are the major snakes in Southeast Asia: king cobras, vipers, common krait. This is what I was talking about. This is a hump-nosed viper, which we see. This is Pangarus sindanus, which is mostly common in Pakistan, but in some parts of Rajasthan you see these snakes. And we don't have venom against them. Now this is what you were talking about, dry bite.
Yes.
Do we ever document a dry bite? I have not seen a dry bite till date. What do you mean by dry bite? Is that you have a person who's actually witnessed bitten by a venomous snake and does not develop any. Since I work in a tertiary care hospital, most of the time people reach me when they have something. So what you were talking about was that people who are practicing in the periphery,
that's correct, yeah.
They would be seeing most dry bites. And this is a wonderful article. I don't know if you have seen this. No envenomation, no local signing symptom. That's dry bite.
We see this in Europe.
You see it in Europe
because I think people go to the events as soon as they're
yes.
That's what we see.
So this is a review article where they have reviewed the complete literature. I say that there could be a natural immunity, there could be absence of venom in the gland at the time, it could be a diseased venom gland. The fangs may be broken, or there could be a mechanical failure. Or then one of them was, one which is not here, is that maybe the snake misjudged the distance between the victim and has probably already injected it somewhere, and the second time when he bites, it's a dry bite. So what are the problems? Identification, first aid, definitive management, and the supportive treatment. I don't know what happens with you guys. In India, this is the problem. At the time of monsoons, you have these kinds of growth all over. Their burrows get flooded and they come out in big numbers. And they enter your home in search of food. They are not interested in biting you because they can't eat you. You get accidentally bitten because you are in their way, right? So this is, we see majority of our, I'm going to present that in the EAPCCT meeting, majority of our snake bites are within 3 months. And that's it. It starts at the onset of monsoon, with the end of monsoon, it's over. And we don't see any snake bite in between. Occasionally...
In a tertiary center, but in a periphery they still see.
I have not any idea because most of the time they are referred to me from the periphery. So if they don't see it there, they won't send it to me. Very occasionally we get some viperine bites or cobra bites in the winter time from the handlers, not general public. General public is monsoon.
So that's interesting because we in Arizona also have monsoon.
Yeah.
Actually call them monsoon. And we don't see a correlation with that. As a matter of fact, our season starts around mid-March and goes to about October.
Wow.
And the peak of activity, snakebite activity, is peak when we see people going outside performing, which is not too hot. And usually people don't go out during the monsoons and right after the monsoons because of humidity. But when it's nice and warm but not too hot,
then they get it. Okay. Okay. Now the first principle is identify your susceptible population. For us, it is males, rural more than urban, workers in the field. Most of the times, in one study from Baviskar, most of the times the people who are harvesting time, that's where you get bitten. You either get bitten on your left hand, and he showed at one particular meeting that he got in an hour's time 3 women who were harvesting, and all of them were bitten on the left. Because what happens is when you grab the wheat or rice and you want to cut it, so you end up grabbing the snake or touching the snake, and that's why your left hand, with the right hand you are kind of, so you need to identify. For us, for me, in Chandigarh, it is this, construction site workers. Most of the times, because they have area, they are staying in small makeshift rooms and no doors, no nothing, they're sleeping on the floor. And in the monsoon time, the snakes also want to come out and be on a dry land, and that's the dry area, the floor where they are sleeping. So that is where they get, or workers in the forest. We don't have any big forest nearby. Sometimes we get from the forest in Himachal victims, and that is occasional victims during the other time.
So that's interesting because I just reviewed about 1,000 envenomations, recent envenomation. In the U.S., it was sexy. What I call trash bias gets replicated all the time, and it was we had this derogatory 7T, testosterone, intoxicated, tequila, nonsense, really. That because it was sexy, everybody reproduced it.
Yeah.
I looked at our data, and our data shows that these are people who are doing landscaping, golfers, gardeners, hikers. So ours is also, to a large extent, people who are doing what I call industrial activity or work activity, and then leisure activity. I actually presented that about 3 years ago at it was in Dubai. It was the International Society of Occupational Health. At that conference we presented. But in the US, the same trash gets recycled and regurgitated all the time.
But we have a lot of our army in the area, which is dealing with, and it's if you know the Maoist area, the right-wing area in the eastern part of India, lots of forests there, and the terrorists are hiding there. The police and army is behind them. So all three get exposed. So all three
the terrorist comes to your hospital?
We treat
I'm
it.
a terrorist.
Well, we see, I don't know who you are. right? If you are here with me as a patient, I have to treat you. You might be a terrorist, I don't care, right?
They don't have a bandana, say I'm a terrorist.
Now this is again which is very important. I think when you're making a sheet, you should know this, that you need to include comorbidities. You know, most of the time the armies, the policemen, they are active people, they do not have so much comorbidities. Construction site workers, who will work at a construction site? A person who is healthy. A person who's got diabetes, hypertension, coronary artery disease is not going to go and work there. So, but if you have comorbidities, this is again important, the part between what we looked at, our data, that if you get bitten on the foot or on the hand versus you get bitten on the ear or on the scalp, you're likely to have more severe inflammation, right? So this is what we realized, that near the face, you're likely to have more severe inflammation. Then you have individual sensitivity, the species, and then the secondary infection. What kills most of the patients with viperine bite is not the bite itself. It is renal failure and it's the secondary infection. Principle number 2, snake identification is difficult. You try to identify snake whenever it is possible. They run away, they bite at night, so people, they get killed, crushed, so sometimes, but if you have a snake which is brought to your ED, preserve it. Preserve it and send it to a herpetologist or maybe a picture to them.
Have you had somebody brought you a live snake?
Yeah, we've got. I'll give you an example. There was this guy who came in, had classical symptoms of envenomation, and said, "Did you find a snake?" "No, I didn't." He's like, "Okay, want to?" He says, "Just some itchiness here." He took off his vest and there was the snake there. Live snake in my ED. It was a small snake, crate. And it was chaos. Everyone just ran here and there.
It's great, the worst snake.
Yeah. So clinical toxidromes sometimes do overlap. And venom assays we don't have. I don't have a venom assay. I don't know whether you have a venom detection.
Australia, I don't know if in America they have. Australia, I think they only
Australia, they have venom detection kits.
Yeah.
Right? I'll tell you why we can't use venom detection kits, or very limited use for us in our. This is general symptoms remain the same. Viperine bites, you may have cardiovascular effects in the form of arrhythmias sometimes. Bleeding, clotting disorders have been already talked about. This is the picture which was again shown. I had a picture of a real patient, a video of him, but the thing is my laptop crashed, so I can't put that, so I picked up. Now this is sometimes one of the manifestations of viperine bites, and it doesn't progress beyond that. Right, so if you have a kind of Russell viper's bite, having neuroparalysis,
yes, it does happen. Yeah.
but it does not, it just goes to ptosis and it does not have very severe respiratory paralysis as compared to the crate and the cobras, which cause very severe respiratory paralysis. This we have already seen. This happens with Russell's viper with us quite a lot. This is what we published. I don't know if any one of you ever read this paper or not. We published it in endocrinology. That in the chronic phase, following a Russell's viper bite, there is something like a Sheehan syndrome, which these people develop. It's initially a hemorrhage, and then they go on to develop these kinds of manifestations. So we did a study over 3 years' time, collected all kinds of viperine bites, followed them up, and found that there is a definitive evidence of pituitary dysfunction. So if you don't have the venom detection kit, if you don't have anything else, how do you identify? What we use is this: paralysis, severe local envenomation is, or necrosis, is cobras do cause tissue necrosis, and severe local envenomation with descending paralysis. This is what I see every day, every day. You know, very interesting thing, I walk into the ED one day, and there's this my resident talking to a family, saying that we can't do anything for this guy, he's brain dead, right? And I start talking to him and say, what's happening? So this guy slept at night. In the middle of the night, he wakes up with severe abdominal pain, vomits. And the wife says, maybe you've eaten something, you know, which was not gelling with your GI tract. So go back to sleep, gives him something and goes back to sleep, never wakes up in the morning. So this patient had dilated fixed pupils, no doll's eye, cold calorie negative. And they were sending him home, that this guy is brain dead. So hold on, give him anti-snake venom, put him on a ventilator, and 96 hours later, he walked out of the emergency. So a person who was declared brain dead was not brain dead. He was just having severe ocular paralysis. And that's why you were not getting anything which was, his brain was intact. Nothing wrong with his brain. But if he was not given ventilation, he would have died. And it would be hypoxic kind of death. We had one death in hospital in a crate bite victim. We ran out of the ventilator, so we were giving them manual ventilation. The person who was doing that fell asleep for 2 hours. And that lady went on to develop severe hypoxic damage of the brain. She was put on ventilator and things like that. She never recovered, and she died of complications of ventilation rather than the snake bite itself. But she had suffered, we had an MRI done, she had a definitive evidence of hypoxic brain damage.
So Ashish, are they bringing you the patients then within a period of time?
I'll come to that.
That they're not hypoxic?
No, no. Rhabdomyolysis, I'll talk about that also. Renal failure, rhabdomyolysis, it could be sneeze snakes, could be Russell's viper, shock, bleeding, coagulopathy, renal failure, and severe swelling. Local swelling is viperide, and then some amount of neurotoxicity may be there, as I said earlier. This is very important. First aid, what are the guidelines? Hardly any guidelines. This is a review article published in Tropical Medicine. It says definitive evidence is this: splint, rest, and avoid movements. That's it. Just splint the limb. What is a natural reaction if you have somebody running after you? You run. What is the natural reaction if somebody bites you? You want to get away from that place, and if you know it is a snake, you want to run as far away as possible. When you start running, that's when the damage starts happening. So you have to splint, rest, and avoid movement. Now this is pressure immobilization is written here, but you have to be very careful. You don't want to very tightly tie a tourniquet.
Because just for your colleague, in America, that's no.
What?
The pressure embolization.
Yeah.
It's a no.
No, we still say, but no tourniquets.
There's a position statement.
No tourniquets.
On pressure
Because
embolization.
tourniquets can cause.
No, even pressure embolization. This is the Australian one. In America, they have a position statement.
Yeah, we don't do it.
Because of the local necrosis.
Yeah, I'll talk about that in my...
Yeah.
So then there are these two new things: topical nitric oxide inhibitor and trypsin injection locally. But there's, as far as possible, don't do anything in the field because you don't know what you'll end up with, right? Why I was telling you it is important to involve the herpetologist and know this is the data which has come from India, from the snake park in Chennai. Now they milk these snakes and they find out how much is the maximum amount of venom which is there, you know, after a week or after a month, whenever they milk them. So you find that Indian cobra, it is 60, common krait is 20, Russell's viper is 63, and saw scale viper is less. So maximum around 60 milligrams is with cobra and viper. Why is that important? It's important because when you want to devise your anti-venom properties, you need to know what exactly you want to give and how much maximum. Although the fatal dose is just 12 milligrams and 15 milligrams. But you want to neutralize what the snake can inject maximally. And that's where your herpetologist will tell you. And then you can decide, based on the calculation, that how much of venom would 10 ml of or 1 ml of your anti-snake venom neutralize. So that's how you make the calculation regarding the doses. So Indian snake anti-snake venom against cobra and against Russell's viper, 1 ml will neutralize 0.6 milligrams. So if 1 ml neutralizes 0.6 milligrams and you have 60 milligram as the maximum dose, so you need to give nearly 100 ml. That one vial is 10 ml and you give 10 vials. That's the way calculation was done, right? But you need, this is known. This is known, but what the snake has injected, until unless you have the venom assays and the venom levels, you'll never know. So if you have a venom assay, and if you know that how much is the circulating venom present, you can titrate your anti-snake venom dose. If you don't know that, then you need to make calculations based on what can maximally be injected. So that's how our treatment protocols have been devised.
How do you calculate the fatal dose in human? How do the lethal dose in human?
There is the 50?
This.
How do
Well, it's extrapolation.
It's the extrapolation.
Extrapolation from.
They have not done the venom analysis. This just the express. What is known is this, and what is also known is when you make your anti-snake venom, how much of 1 ml of anti-snake venom will neutralize. Now you have this much, but you may not inject that much per person. But when you are giving anti-snake venom, you need to cover. Again, this is a normal, natural kind of a snake which has been reared in a snake park. Now, if this snake hasn't had a meal, if it is dry weather, then the venom would be far more concentrated. Right? So you get that. So the
venom content is actually both the content and the amount is different in the wild type versus the capture.
Yeah.
I've known that for a long time.
Yeah.
And I agree with you in a sense that if you don't have anything else, but if you have clinical trials, it's based on severity and what really happens in humans that you can determine the dose of the antivenom or how many vials you need. This is in lack of having clinical trials. And I think we keep doing this to ourselves. We need clinical trials.
The problem with this kind of a trial is that if I don't know what is the venom concentration, how can I lower the anti-snake venom? Then it becomes a trial and error. You know, I give one person 10 vials, 100 ml, and I give another person, 5 vials or 50 ml, and then see what happens.
Well, we do it in clinical trials based on severity. That's why we come up
No,
like
but
trauma,
most of the-
like ICU, we come with either snake bite severity scores or other clinical scores that will guide you. And then it's based on the practical activity rather than potential.
Okay, I slightly differ from you on this. We have cases who come to us early, have just doses. We give them anti-snake venom, and within 2 hours or 3 hours, they go down to in spite of giving them 100 ml of antivenom, they're going down. And they go down to develop severe paralysis. Right? So,
but what's the harm, sorry, the question, but what's the harm of having that graded severity approach if you are
that's what I'm saying. So, if I have a graded severity approach, and if I say that if a person presents to me with doses only, I'll give him 5 vials. And if he has full-fledged paralysis, I'll give him 10 vials. I'm delaying institution of maximum amount of antivenom by a couple of hours.
But you're reducing the risks of side effects, you keep your antivenom storage.
You are weighing the risk of the
You are weighing the risk and benefit.
And that's what you do also in clinical trials.
Yes.
Clinical trials, they're designed, and then you look at it and see whether your patients are moderate, severe, okay, mild, and you don't make the recommendations based on a mild, right?
I'll show you the data again a little bit later. So, principle 5, whenever you get a patient in the emergency, reassure, use IV injection, look for respiratory risk. ABC is the airway kills first, right? So ABC remains always. You have persistent vomiting, you can give chlorpromazine. If you have syncope, shock, angioedema, you can give adrenaline. Clinical assessment, again, is something very important. How fast the swelling is progressing. The swelling starts within 15 minutes, but it may take up to 2 hours, right? This is very many times the patients are bleeding in their mouth. You don't even see that. You don't even ask them, until unless they bled enough and they're spitting it out. You won't even look at that. This is something which I haven't encountered too much. Regional lymph nodes. Although it is mentioned, but I don't.
I've seen it with the European ones, European other lymph nodes.
We see that all the time with the American crowdlet. As a matter of fact, some of the worst bites I've seen in terms of local effects is women who have gone under mastectomy and lymph removal. They actually have much faster development of the local effects than a person with the intact lymph node.
I haven't seen too much of sea snakes, so I don't know how much trismus and generalized muscle weakness, because we stay way away from the sea. This is what I was talking to you. Whole blood clotting time has its problem. But in a clinical setup, this is probably we've done trials, my colleague has done trials on thromboelastography and measuring INR versus the whole blood clotting time. So if you talked about the point of care, we don't use point of care, use lab INR. And lab INR, if you can get done, is more sensitive. But as you said, that if a person comes to you early, may not have developed consumptive coagulopathy, may still be in the phase where the coagulation is going on and they, all the factors have not been consumed till now. So your whole blood clotting time may be normal. In the initial phase of a viperine bite, but you need to repeat it. You need to repeat it. So that's very, very important. Always examine urine for both hematuria and myoglobinuria, because viperine bites can also cause IV hemolysis, right? So that's antivenin, we all know this. This is what happens. 1 ml of antivenom. These are studies which have been done over a period of time, and 1 ml neutralizes 0.6 milligram of cobra and 0.6 milligrams of Russell's. So if it is 60 milligram maximum, you give 100 ml. These are the indications for giving this. This is very important, dose of antivenom. Now there are lots of issues with how do you dose antivenom. This National Snakebite Protocol was developed around 15 years ago with the help of Ian Simpson, who's a herpetologist, who talked to people all over India, looked at how much was the snake venom which could maximally be injected, and what were they doing. So what they said that if you want to neutralize 60 milligrams, you have to give at least 100 ml stat. Now you have to, what you said, that the snakes which are inbred and the wild type may be different. So you reassess after 2 hours if the paralysis persists or increases. Well, there are only 2 snakes which can cause paralysis. That is cobra and crate. And if you look at the amount, 20 milligrams, right? So you need a much lower dose for crate bites. But you don't know. You want to cover cobra. Although we don't see local envenomation. So your point that you want to rationalize giving antivenom, could do a trial on this by trying to neutralize only 20 milligrams and not 60 milligrams, which would again be different dosage.
In your center, what's the average number of vials?
I won't finish? Okay. This is what I was telling you. This is what it is. This 2001, 900 ml.
The average?
900 ml. Wow. That is huge. 90 vials. Right? 2005 came down to 500 ml. Then they did a trial, the same group. They gave 150 ml in 28 patients and 600 ml in 27 patients. Now we've come down to 200 ml. Because that's the guideline. It says that you give 100 ml up front, right? And then you give 100 ml again in 2 hours if the paralysis is.
But what's your end point? What are you comparing?
Comparing?
Yeah. Besides the patient walking out.
Mortality.
You gave 900, they walked
out. Mortality and the duration of hospitalization. I haven't presented here, but I can, share with you what was the total duration of hospitalization, which was much higher in all this, and it has come down here.
Did the time of the presentation affected the outcome?
No.
Or the amount that you are giving?
No, because we are following this standard protocol everywhere. But the recent guidelines which have come from the Ministry of Health, not for the neuroparalytic snake, but for the viperine bites, they have decreased the follow-up dose to 6 vials. From 100 ml, they've decreased to 60 ml based on whatever a little bit of clinical trials which have been.
And these are FAB2, right?
Yeah.
FAB2.
Yeah. So this is the total cost. Okay, I'll not talk about this. This is important. Ventilation works in neuroparalysis. Now, when I was given this talk, Ziad gave me a question. How do you deal with snake bite if you don't have an anti-snake venom? Now, we talked about the crates causing the presynaptic destruction of the nerve terminal. There have been studies which have been conducted in Sri Lanka, and they've shown that the nerve terminals take anywhere between 72 to 96 hours to regenerate. So you don't have an anti-snake venom, don't do anything. Ventilate them. They'll come back, right? With the anti-snake venom, the average duration of ventilation in a crate bite is around 36 hours. So if you want the nerve to regrow, you might have to ventilate them for double or slightly more than that. And then there'll be associated complications with ventilators, right? Long-term ventilation. But if you have nothing to offer, just ventilate. And why ventilation works in a crate bite victim? Because their lungs are clear. They are not ARDS patients. They do not have dirty lungs. They do not have anything which is flooding their alveoli. It's just that the muscles are not working. And the ventilator is doing that muscular. They don't require very high FiO2. They don't require very high rates or pressures. What they require is something which can work as their muscles. This is the mortality. It was 3.5%. It was 11%, and this is the last study, 2.73%. This is what you were asking. What was the mortality?
Yeah.
In different studies when you were using different kind of ventilators. So it was 3.5%. There, in this group where they were using high dose of antivenom, the mortality was more. So we have kind of come back. Okay. Yeah. Look for complication, look for antivenom reactions. This is something which has again come from Sri Lanka. We don't see too much of it, but it has come from Sri Lanka that people who have been, we followed up our snake bite patients. I haven't seen anyone coming back with these issues till date to me. We have a very big rheumatology center and we initiated this. Any new patient who comes with any of these arthritis or mononeuritis or any kind of a problem, then were you ever bitten by a snake? Did you receive anti-snake venom? Till date, we haven't kind of found this. But somebody has come out with this, that this can happen. So there is a possibility that there can be a long-term. Look for hypotension, look for oliguria, look for local infection, look for compartment syndrome, and then some other unusual complications. So if you see a snake, don't panic. Do not disturb it. If the snake is moving towards you, stamp the ground. This was for the president. This can be, for the general public. Yeah. And avoid stepping, protect yourself. That's it. Thank you.
Thank you very much, Ashish.
To give you our perspective and how we have kind of gone from very high to reasonable anti-snake venom. We'll probably try to reduce it further.
We are trying to do a randomized control trial comparing two doses for the snake antivenom because the guidelines in Oman, they give us for severe envenomation quite a huge range between 50 to 100 ml of the snake antivenom. So we are keeping it up to the physician to decide.
And each vial has what, 10?
10 ml.
10 ml, and how much protein in each one?
I think 14.
What's the question?
Protein in each vial of anti-snake venom.
Saudi snake antivenom.
Paul, do you want to make your presentation before or after the break?
I'll do it now, if that's okay.
Okay.
Okay. Unless you want to take a break, then I'll answer. Thank you very much for inviting me to give this presentation. I think I don't really need to give a presentation because it's already been given by the previous speakers, but I'll highlight my perspective as well and try to focus in on antivenom. But much of the key teaching points have already been presented this morning with two really excellent talks. So I'll just start off with this slide about the cost of antivenom. So in the U.S., which is my experience with treating snake bites, most people who are bit by snakes don't die. So that's not the endpoint that we deal with in the U.S. In fact, the number of fatalities from snake bites each year is just really a handful. I think they've made estimates of maybe 10 or fewer people from around the U.S. die from snake bites each year. But we still use a lot of antivenom, and the first speaker is real interesting in terms of, well, when someone comes in, is it a dry bite or not? The family wants us to do something, give antivenom, and that's often, you know, the quandary we face when someone gets bit by a snake, or even if they come in with other medical complaints, is the family wants us to do something. But one of the factors with snake antivenom has to be factored in is also the cost. And not only is the basis of the cost very expensive, but in the hospital makes a lot of profit on antivenom. And so while most antivenom cases, they don't spend $143,000 US, the typical amount of antivenom cost may be $10,000 or $20,000 or $30,000 routinely, which is extraordinarily expensive. You know, we associate that sort of cost with open heart surgery or some major operative procedures, and the cost of antivenom is almost that much. So given the cost of the antivenom, that's part of how I factor in whether I'm going to give antivenom or not. So I've had the opportunity over the last now 7 years to be part of the North American Snakebite Registry group, and we're a group of toxicologists from around the United States that have been putting in our snakebite cases into this registry. We have about 1,000 cases or so at this point, and we're continuing to enroll cases, and hopefully we'll learn more about snakebite with this large accumulation of data, particularly in terms of treatment. I think our approach, as you'll see, is kind of one size fits all in terms of how we dose our antivenom, but there's certainly subgroups which would be, I think, very interesting. People with coexisting morbidities, diabetics and other folks, and children versus adults, and whether there is a strategy to differentiate how much antivenom to give. So a lot of this is not known, and through the collection of this data, hopefully we'll learn more in the future. I think what I did in terms of my research to prepare for this is that in Turkey, the most common venomous snake is the black viper. We don't see black vipers in the U.S., but we see, as you'll see, mainly the crotalids. So this has already been discussed previously. These are very interesting and very pretty sorts of snakes. But other than the coral snake, which we see in the southeast in the U.S., these other snakes are the exotic snakes, which occasionally people have as pets, or so we occasionally get a call about one of these other sorts of snakes, but these are not native. These are the old world vipers, which have already been discussed, which belong in the old world, not in the U.S. except as exotic snakes, and we see the crotalidae snakes. And particularly the rattlesnakes and the copperheads, the cottonmouths are less common, depending on the geography of where you're positioned. So in Arizona, for instance, it's predominantly rattlesnakes and their subspecies. Where I practice in Texas, we have a predominance of copperheads, but we also have some rattlesnakes as well. And the venom effects are different between these two types of snakes. The rattlesnake envenomations tend to be more severe than the copperheads. The copperheads tend not to have as much of the hematologic effects, and even the direct tissue toxicity tends to be less with the copperheads. But still, when patients come to the hospital, they get bit by the snake, they bring in the snake, they want something to be done. Do you use antivenom or not? And in fact, many of the copperhead bites that we see, even if they have the local effects, we may choose not to give antivenom, particularly with the copperheads, just because the course is relatively benign. So, thinking about when to use antivenom, in the U.S., I'm not sure how good this data is, but approximately we say 20% of the snake bites are dry bites. So my sense of a dry bite is there's really no direct inoculation of the venom per se. There may be some minor physical injury from the bite, but no envenomation. But of those who become envenomated, many of these cases, or some of them, may be mild cases just with some local effects, really without extension, without any systemic effects. In those cases also may not require this very, very expensive antivenom. So these are some of the species we see in the U.S. And in terms of identifying snakes, it's nice to get an identification. We often don't have an identification, and we just treat them as if it's some sort of rattlesnake or a copperhead snake. We've already heard a lot about venom and various proteins and the clinical effects. With the U.S. snakes, most of the clinical effects are the effects causing local tissue toxicity, and for some reason those slides are not appearing. And then some hematologic effects. And the hematologic effects are of interest because you can measure these hematologic effects. We do not measure antivenom or venom levels or any sort of additional information that might be helpful in assessing the severity of the stake, such as a venom load. We don't have that sort of technology. So, but we do look at, obviously, the hematological factors, the platelets and the coags. So in terms of the management of the snake, as was already discussed, we do the initial evaluation. If the patient's been envenomated, we do hospitalize the patient even if they don't need antivenom, just to provide some time to observe the patient to see if there's any progression. If we feel it's a dry bite, particularly if it's in the upper extremity, then we'll send them home after a short period of observation. Usually with the lower extremities, and in children, we'll admit them over to the hospital and watch them at least overnight, even if we don't give the antivenom. This has already been discussed in some detail. The complications, we've also discussed again. Death is not a common endpoint at all in the U.S., but certainly the potential for a compartment syndrome or something that looks like a compartment syndrome is probably our most concerning problem, and rhabdomyolysis. And here's just some folks that have had fasciotomies, and traditionally, particularly in some parts of the U.S., before the wide use of antivenom, the primary approach was to be a surgical intervention with the swelling, and patients had very disfiguring surgical procedures, which with antivenom are probably not required. And estimates are maybe 1 out of 100 cases of envenomation require some sort of surgical intervention, whether it's a dermatomy or occasionally a fasciotomy, but this is very uncommon. Of interest, though, in certain parts, as I just alluded to, in Texas and elsewhere, the traditional approach was the fasciotomy, and that's why where the patient gets admitted in the hospital, it really does make a difference. If there's a toxicologist, if they're admitted to a toxicology service, we tend to primarily use the antivenom. But in other hospitals without toxicologists, they see swelling, they say it's a surgical problem, they may admit the patient to a general surgeon, and they may end up with an unnecessary fasciotomy. So
in the U.S., it's a trauma code.
Trauma.
Yeah.
Yeah. So in terms of antivenom, again, unlike my Indian colleague who's really saving lives with antivenom, these patients, almost all of them are going to live regardless, but when do we use the antivenom? So if there's progression of the swelling, again, limited swelling, we may not use the antivenom. And then hematological effects we use. And some of these rattlesnakes, a minority of them do have some neurotoxic effects, and any neurotoxicity would be treated with antivenom as well. Oops, the wrong way. Okay, so different types of antivenom. So up until about 2000, the only antivenom that was available in the U.S. Was the old Wyeth antivenom made by horses. It was the whole IgG, and there were lots of side effects. It was very immunogenic, and many patients, in fact, the majority of patients, you gave them the antivenom, and they developed significant, even severe reactions, anaphylaxis at the same time that you gave them antivenom. That's why a little bit of caution about just moving and giving antivenom to everyone, just because of all those side effects. And there were patients that in one arm you'd be giving them the infusion of the antivenom, and the other arm you'd be giving the infusion of the epinephrine to treat the anaphylaxis. So fortunately, those days are behind us. And in the U.S., as you'll see in the next few slides, the main antivenom we had up until last year was the FAB antivenom, known by the trade name of Profab. And then the newer antivenom, which really just came out, is the FAB2 antivenom, which we'll discuss. So this was the old Wyeth that came from horses, lots of hypersensitivity reactions, including anaphylaxis. And traditionally, when we approach the care of patients, if something causes anaphylaxis, that's the last thing we use. If they have an allergy to an antibiotic that causes anaphylaxis, we never ever use it. But in the case of treating snake bites, this was the quandary. Not only the acute hypersensitivity reactions, but also the delayed hypersensitivity reactions. And most, if not all of the patients practically, would develop the serum sickness from the horse serum, which we see occasionally, but not very often now with the newer types of antivenom. So Profab came out in 2001, came from sheep. It was made by immunizing the sheep with certain venoms, so, the rattlesnake and also the cottonmouth. And it's just a very small amount of the FC fragment, so much less immunogenic than the IgG antivenom. It was is useful in stopping the progression of the swelling. At least that's one of the endpoints, and also to reverse the hematologic toxicity. There are a small subset of patients that develop systemic toxicity from snake bite, including hypotension, for instance. But those are really the minority of cases. Most patients have the swelling, which can be quite dramatic, and then a subset of those patients will have the hematologic effects.
Based on the clinical trials, Profab was John Sullivan who created it at the University of Arizona, and all the antivenom go back to actually our poison center. But even then, it was the clinical trials was on 48 patients, and it was on mild and moderate.
Right.
Yeah. Never treated anybody with severe in that clinical trial.
And whether it prevents tissue loss or not, I mean, if someone presents already with necrosis, it's not going to suddenly reverse the necrosis and prevent that sort of tissue loss. Hopefully, it will prevent worsening tissue injury, but it doesn't reverse severe tissue injury by any means. So in terms of dosing, I wish we could do this stoichiometrically. I wish we knew, the total amount of venom that was introduced, and that we would calculate this based on the venom load, but we don't do that. So the way this antivenom was approved was to use a starting dose, and generally, we say 4 to 6 vials. With the old Wyeth antivenom from years ago, it was a larger number of vials, 10, 20 vials at a time, but this is a smaller number of vials. Whether you give 4 or 6, kind of depending on the severity of the bite. If it's more severe, I usually give 6. If it's less severe, but I want to use antivenom, I give 4. And then you reassess the patient, and that's the critical thing that you need to do after the initial administration. You come back after an hour or two, and you see what the swelling has progressed or not, and you measure the coags and the platelet count to see if there's been any reversibility. And we often see platelet counts that are very, very low, of 5 or 10. So if you give the antivenom and there is a good response, the platelet count will bounce right back up. The same thing with with some of the coag factors. Those can be totally depleted dramatically. So, although the patients tend not to bleed a lot, they just you'd expect them to be bleeding if the patient was on chemotherapy and had some sort of cancer and had those sorts of numbers. You'd be worried about head bleeds and other sorts of really devastating hemorrhages. But you don't see that much with snakebite. At least that's my experience. Then in terms of continuing to give the antivenom, particularly with the Profab, as you'll see in the next couple of slides, there was this feature where the, the patient seemed to sometimes get worse again, or there was a delay, and because of this, the initial standard approach was to give them these extra doses, even as they recovered, just to prevent the late onset of other sorts of symptoms or the delayed toxicity, as you'll see. Whether that's required or not, it's still very debatable, and there's no standard of care. There's a recommendation under the package insert, but there's no standard of care. And I think in the last number of years, a lot of people have been deviating now from the traditional approach, which was used after the release of Crofab initially, which was to give this maintenance antivenom to patients. And again, one of the factors in terms of the decision making is the cost of it, if nothing else. Do you spend another $10,000 or $20,000 when the patient may not need any of this at all? So the problem with the Crofab was the pharmacokinetics and the fact that the half-life was relatively short. And so the effects of the venom, in some cases, were outlasting the effects of the antivenom. And because of that, you would sometimes see this late onset hemotoxicity, which was certainly of interest in terms of how long do you observe the patient for after the treatment. And then the other problem is the recurrence. And so patients seem to recover, you'd send them home, and then 2 days later, you check their blood counts again, and their platelet count would be back to 10,000, and you'd say, well, they seem like they've had a late venom effect. Do they need to come in for retreatment? And these were the decisions that need to be made. So, particularly with the rattlesnakes, less so with the copperheads, the approach is to follow them up after discharge from the hospital to test their coags and their platelet count again, and to follow them closely. And if they had an isolated coagulopathy, we wouldn't necessarily treat them. Again, many of these patients, most of them never bleed anyway, so you're treating numbers. But if they have two-compartment coagulopathy, or thrombocytopenia, for instance, or platelet counts that are real low, then we may treat them. Whether there's data to support that approach, there is none. But this was kind of a gestalt that those who treated these snake bites felt like, well, do we leave these patients to go home with platelet counts of 10,000? It's dangerous. What happens if they fall and hit their head? We probably should retreat, but again, based on anecdotal information. And these are some other risk factors for bleeding as well. So moving on to the newest antivenom in the U.S. is the FAB2, which those of you from India and elsewhere have much more experience with. This was under clinical trials and a long delay to the release for many, many years. Some of the clinical trials were done literally 6-8 years ago, but it wasn't released until late in 2018. And the potential advantage of this antivenom is that it has much slower clearance. It hangs around for a lot longer period of time. So these were a couple of the studies done during the clinical trials. It's only been released, like I said, in October 2018, so there's really practically nothing published yet since it's been released. But there are a number of folks studying this, and there should be a lot more papers coming out in the next few years about the use of the antivib and also comparing the antivib with the Crofab to see whether there's truly a difference or not. So this was from one of the early clinical trials, and just really a couple handfuls of patients comparing the two groups. But the group that got the FAB2 seemed to have more detectable antivenom when it was studied further out than the group that just received the Crofab. So at least on paper in these small series, there seems to be an advantage. And we'll see what happens in the future. Now, in terms of the use of particularly the FAB2, that was approved for the treatment of rattlesnake bite and actually not copperheads, which are less venomous, as I described, but we have a lot of copperhead bites in the U.S. And so whether it will be used off-label, like a lot of things are used off-label for the treatment of copperheads, will still be to be determined. The typical starting dose for the antivib is thought to be about 10 vials. And Mazda, you have a lot of experience now with the antivib. You usually use 10?
We have used it. It looks like for mild to moderate 10 vials, and then anything more than that, you actually need to repeat it.
Yeah, okay. So again, all this will be coming out. So I just want to close with this one little case, and I continue to learn about toxicology with my travels. So this was a patient who was bit on the toe, but it turns out you know, he did not have much in the way of local tissue effects because it was a crate bite, and as was described very eloquently, had severe effects in terms of the neurotoxic effects. Ended up on ventilators. The patient on the right was really interesting because when it was presented to us on rounds, they said, well, we have no idea whether he's bit by a snake or not, but he presents like a crate bite. He's unconscious. He's a young guy. He's healthy, so we're going to treat him as such. And because of that, they have really good success in treating this patient.
Are they giving him antivenom?
Yeah. Yes. Yeah.
This is what we, as I said, that in that particular time period, any young person who comes with this kind of a symptom, I might end up over-treating a couple of them, but I would treat them.
And this is the antivenom that's used.
Yeah.
So thank you very much. Any questions? Yes.
Yeah. So what's your experience with the delayed coagulopathy from the rattlesnake? I know there's also some evidence whether if they presented like delayed 2 days later and the role of loading antivirals at that point. So do you see a lot who do not present initially with coagulopathy and then like 2 days later have delayed coagulopathy?
Well, there are some, and you know, the initial dosing of the antivenom with the Propam may mask the coagulopathy, and once it wears off, then it presents itself. And I think that's the issue. They come in, you know, those patients, they come in really early. They have swelling. You check their blood count; it's normal. You give them the Crofab, and then 3 days later, you have to send them home, and then you check your platelet count. Now it's very low, or the PT is very high. And the question is, well, why wasn't it like that at the outset? It's probably because they were treated so quickly.
50% of the patients that present to us are coagulopathic, defibrinated, or platelets that are below 150. And is not our, I guess, by consensus, we decided that that's thrombocytopenia in the snake bite. Of those, 75% will go to develop recurrent coagulopathy in our care. Now, Paul is correct. Majority of the Arizona population in the cities are within an hour of presenting to a hospital. Now, our understanding, because our center takes care of most of the rural Arizona, we see the same thing, even when they present later. It says 50% are coagulopathic and 50% are not. And you can't predict which ones are going to become.
Yeah,
and the longest we've seen has been 82 days. 82 days of platelets under.
And that does not have to do with the reabsorption from tissue?
There are lots of theories about why that happens, that whether there's a depot or not, or maybe that individual, you know, when we're talking about smaller individuals. We follow them up to 21 days, and then we call them every 6 months up to a year out, just to look for local damage on the, you know, because we get lots of local damage and they need grafting when it's on the tissue of the fingers and toes.
How often did you experience anaphylactoid reaction? I mean, in Atlanta we had mostly copperheads, so we didn't much recommend them. But how do you often really see it? I mean, we talk about that.
Well, with the Propam, I've yet to see a case of true anaphylaxis, but it's been reported. But that has to be compared to the prior experience where anaphylaxis was happening about 1/3 of the time. I mean, with the old horse serum, and that's why, you know, we're very cautious about the potential of developing adverse effects. But the number of adverse effects with the FAB is much lower.
The total reactions is actually there are good publications on it, both from Phoenix, Tucson, and it's less than 0.05%. All reactions, not anaphylaxis, but all allergic reactions with Crofab. With the now, if you're talking about anaphylactoids, We see that all the time, and that's rate. You know, if you start giving the antivenom really fast, especially in children, we see lots of anaphylactoid. We just slow it down.
Okay, perfect. Thank you very much. So now the real break.
Break.
And do insurance cover venom?
Most insurance are, if you don't have it, goes up Medicaid.
But they have to pay some percentage, right?
Treat snake bites. Within the season that we have, we see about 50 snake bites at the bedside, and then we treat another 70 in the hospitals that are under our care. So the most common types of coagulopathy that we see with snake bites are defibrillation and thrombocytopenia. Now, thrombocytopenia has been explained in many ways. That is it due to demarginalization? Is it due to clumping? But that's something that we see that immediately is reversible, almost. So platelets are almost gone, individual comes in, and again, we do not run into the problems of people presenting late. Now, do we have late presenters in terms of snake bites? Yes, but those are volitional. One individual, for example, did not come in for 2 weeks because he didn't feel he's sick enough. And again, our snakes do not kill you, right? Our snakes are rarely kill you. And you can look at actually the rate. We did a study with Frank Walter, myself, and we published the rate of snake bite deaths in the US, even when you include the elapids that we have, it's almost rare. It's a rarity, okay? And again, access to ICU care, access to ventilation, you know, almost, if you have that type of care, nobody dies from it. But thrombocytopenia we see early on. It's reversible both with Crofab and now with Anavib. So both with antivenom that is Fab1 and antivenom that's Fab2. Remember, lots of people talk about antivenom snake bites, but they don't treat them on a regular basis. Antivenom Fab1 came to be why? Why did we come up with the Fab1? There's only 2 Fab1. There's a European and there's an American Fab1 anti-snake. The whole idea was they have better penetration into tissue because we were worried about tissue toxicity. And I don't know, Bruno, do you guys have a Fab1 in France? No, we have a Fab2. Fab2 is actually a better antivenom in terms of lasting and being effective. But what we see is a different problem with it. Now we're talking about coagulopathy. Platelet reversal we see almost the same with the antivenom that's a Fab1 and antivenom Fab2. So people come in, you measure their platelets, it says 30, 60, undetectable. You give them antivenom, back to normal, right? Now, are they as effective, meaning functional? Most of the functional studies that are done, whether you're talking about epinephrine activation, collagen activation and stuff, they do not show any difference. There are shear activation studies that show that maybe in a snake bite, depending on the venom, that the activations are not one and the same, meaning platelets are not functional as they were before seeing the venom. Now, the other thing that we see is defibrillation. So fibrin is totally gone. It is interesting that with antivenom that was a Fab1, we would give it, and it would take almost tens of hours before we could see a detection on the levels of fibrinogen. Okay? So what happens, fibrinogen, if it's destroyed, right, then it takes time to regenerate it. You don't all of a sudden come up with fibrinogen. I would tell you, our early studies and looking at the Fab2, we see a different pattern. And I don't have an explanation yet for it. We give Fab2, And what do we see? Return to normal. Why? I don't have explanation for it. You know, is it that somehow the venom actually is, you know, enveloping fibrinogen and other factors, and they're not seen based on the assays that we're doing, and now we give the antivenom and you can see it? I don't know. I don't know if those studies have been done. But I know that you guys have been using FAB2 longer than we have. And are you seeing anything with fibrinogen and other factors? Do you measure them?
Yeah, we do measure them.
And what do you see with the FAB2?
Yeah, well, a few hours.
Return to normal?
Going up.
They start going up. But do they return to normal?
Yeah, yeah, fibrinogen. Yeah.
So fibrinogen going, you get somebody that comes into the hospital, fibrinogen undetectable. You give them antivenom, and now they're normal. Is that what you're seeing?
But not within not within a few hours. I mean, within a few hours you start to see it going up. 6-8 hours, you have some.
Because our protocol basically, we don't measure after 2 hours. We measurement is mainly after 6 hours, 6, 12, 18 hours.
So we do it an hour before and an hour after infusion. So, Bruno, what's your experience in France?
With
the fibrinogen. So one thing that we're seeing now with this new Anavip, which is a FAB2, fibrinogen, we used to see it go down, and we get FAB1, it would not affect it. Maybe 6, 7, 8, 10 hours later, it would start going up.
Let me ask you first. Did you see any difference for the local reaction between the FAB1 and FAB2?
What do you mean?
Local reaction.
Local, no.
Because
we're not seeing any.
We know that when you give antivenom, FAB2, right, it doesn't go well to the tissue.
Mm-hmm.
So the tissue reaction is called inflammation, right?
Mm-hmm.
And fibrinogen is the acute phase reactant.
Correct.
Yeah, and we see that when the patient have really bad local reaction, it's gonna increase fibrinogen. That is the factor that counterbalance the venom. You know, the one who has severe reaction, those patients have high level of fibrinogen, you know, really early on.
So we see that with, for example, when we were talking about antibiotics, okay? People who come in and they have high levels of fibrinogen,
yeah.
And I'm talking about 600 to 800, we look at them and they have an infection already, something going on. And majority of them, they've done something. They manipulated the wound, or they were out of care, and you know, they were not sanitary, and they do have some sort of infection. We looked at 2,000 snake bites and showed that nobody needs antibiotics unless they've done some manipulation of their wound. Now,
at what time did you diagnose infection?
At what time we diagnosed infection?
Yes.
Well, the whole thing was in the EDs, a diagnosis of infection. Oh, I better do prophylaxis.
I know, because you know, usually
we do not do.
You know, venom can cause local reaction, right? It's inflammation. It's not infection in the first few hours, like up to like 6 to 12 hours. It's not possible. Infection can, you know, happen within like 6 to 12 hours. So if you diagnose infection in 6 or 12 hours, it would be not that infection. It should be inflammation from venom, I think.
Well, yeah, that's what the toxicologists consider, right? But the regular emergency physician, even in the United States of America, right?
Yeah.
One thing that they did is like, let's give them antivenom and let's give them antibiotics immediately, okay? And we used to see, actually, with that practice, we used to see more reactions because the risk of having a reaction to the antibiotic is much higher than even to the antivenom. So we used to see lots of it. And that was a common practice. And still goes on, although our recommendation after we published this is that you do not need to do any prophylactic treatment. The venom itself, at least the venom of North American corrodal is bacteriostatic, okay? Even if you don't consider anything else. So, but when we're talking about acute phase reactant, right?
Yeah.
So the patient would come in and they had a high levels of fibrinogen. We would say, okay, this is probably an infection. Now what we're seeing is low levels, okay? And we're seeing a rise, immediate rise.
Mm-hmm.
So I can understand when you're saying the inflammatory response to the antivenom, but that wouldn't be within an hour.
Yeah, that's true. Because
That, you know,
I mean,
when you get things within an hour,
I mean, the half-life of, I mean, for liver to produce fibrinogen is between 3 to 9 hours.
Correct.
The median time is 6 hours. But we don't know if inflammation can increase the rate of fibrinogen production.
Sure. Now there are, when we're talking about, anticoagulation and measurement of anticoagulation, there's even suggestions of, for example, and that's why I was asking Ashish about hypoxemia, how many percentage, what percentage, because there is a talk to actually allow patients to rebreathe their own air, increasing their carboxyhemoglobin. Carboxyhemoglobin actually pushes fibrinogen up, and it decreases its degradation. But really, does that have an effect on coagulopathy and bleeding? Now, as it is, our rate of bleeding, even with severe thrombocytopenia and defibrillation, is rare. The only times I've seen it, it's been on somebody who got envenomated multiple times. So, and that's one of the things that I wish Ashish was here. I disagree with Ashish because I've seen people who were bit twice with the same snake, 3 times with the same snake. And their presentation is not the same presentation as one bite, okay, of a snake. These guys are usually severely thrombocytopenic, severely defibrinated, and they bleed. As a matter of fact, I think it was the first venom week that I took David Waddell and Julian White to a hospital in Tucson and showed them a severe GI bleed from a snake envenomation, rattlesnake envenomation, which is usually not seen. And this was an individual from New York, came to visit her family member, went to pick up a trash can, and most of you have seen trash cans. They're these big buckets that you pick up in Arizona. She went to pick it up, and she was wearing flip-flops. Snake got her foot. She took one foot back. She got the other foot and put the other one down again. So 3 times she was envenomated. Severe coagulopathy, bleeding, GI bleeding, or GI bleeding. We couldn't stop it. Another one we saw was a case of a single bite of a pet, Chlorus cerebrus, one of our worst rattlesnakes, and the gentleman was actually a son of a hematologist. He ended up getting severe coagulopathy. He has epistaxis. His nose was bleeding. He was transferred to the floor out of the ICU and out of our care. And by the time we got to his bedside again, they were giving him blood products, and his hemoglobin was 4. And when we turned his back, from the back of his, all the way down, he was bruised.
No
So
antivenom.
What?
No antivenom.
They weren't giving him antivenom.
Just blood products.
So, just blood products. He was under care of the internist, unfortunately, at that time. And then we put him back. And as you guys know, or are aware, our system now, we have internists that take care of the inpatient. They're called hospitalists. And if they're not attuned with the state or the hospital or the region that patients, for example, snake bites come in, they do the same things that they do with anybody else that bleeds, which means give them platelets, give them fresh frozen blood, give them blood. Which is like the worst thing to do is like, let's give them something else to break down.
To the fire, yeah.
So we do see severe coagulopathy. Defibrillation is the worst one that we see. As you saw with Paul's presentation, that there is a point that we become concerned. When do you treat them? Okay? When do you treat somebody that comes back to you with platelets that are under 150, and I'm going to give you a range, and also with fibrinogen that's under 150. So they come in, platelets 100, fibrinogen 100, right? Are you going to treat? Most of us say no. You know, risk of bleeding is low. Now, they come back with fibrinogen under 50, platelets under 50. Would you treat? Why? The risk of bleeding is really low, but I'm not saying I wouldn't do it, but I think most, even toxicologists, we lose the control. It's, oh, okay, now this is too high of a risk for me. Not that that's actually for a patient, and we would retreat.
Wouldn't you argue that you have an evidence of systemic envenomation from step one? You would treat that. I know you because you know your demographics. You know what you're dealing with, so you have some sort of reassurance. But in a general toxicologist, when you have that evidence of systemic envenomation.
So I would suggest that maybe we should go back to total clotting time, 20 minutes and 30 minutes in these individuals. Because really, our empirical data is dictating that these people are they're not at risk. There are our recommendation for anybody that goes home after snake bite, rattlesnake bite in Arizona, is that no provocative action. You do not go to dentist to pull teeth. You do not go for any cosmetic or elective surgery. You do not go under any high-risk activity, which are contact sports, okay? Jumping out of a plane, and the reason is we get lots of young people, and Arizona is known for their activities, right? We have people who go out of the hospital and says, okay, can I go and do a skydiving now? You know, of course we tell them no, because they are at high risk. But in our general population, these people don't bleed. Those studies have been done. Fibrinogen low, platelet low. The only study that I've seen was actually a torsional peg that was done. And it showed that platelets under 60, okay, it didn't matter how much fibrinogen. Platelets almost played the role of what you would call a spoke in a wheel. If you didn't have that, fibrinogen didn't matter how high it was. If your platelets were low enough, that clot was not stable. So really, maybe we should be looking at just platelets being under 60. My suggestion is going back to total clotting time, or looking at the limited 20 minutes or 30 minutes clotting time for these people, at least in the United States. I opened the forum to my colleagues who've been using FAB2 more often, and for a longer time, and hearing your suggestions also.
Yeah, we use 20-minute whole blood clotting test at the bedside test.
Thailand?
We use the 20 whole blood.
In Thailand?
Yeah, in Thailand. Yeah.
So you do it initially for determining treatment, but not for disposition.
For disposition as well.
So when you send them home, you also make sure that they're...
Yeah.
Same as minimal.
Yeah.
So you do also that?
Yeah. No, in minimal.
Oh, in minimal.
In minimal, they have the same protocols as Thailand.
Minimal,
We don't. We do the clotting test is on the patient arrival, and the reason is because the coagulation profile tend to...
You're doing the INR you're talking about?
No, the bedside.
The bedside, okay. You do it only in the...
At the time of presentation.
We actually have a study already. It's a prospective study to compare 20-minute whole blood clotting test with the PT, TTT, and fibrinogen. We use the fibrinogen level less than 100 as a gold standard, and then we compare 20 whole blood clotting test with the fibrinogen level. Is the sensitivity is about 93-95%. Oh, I'm sorry, 85% sensitivity, but specificity is about 95.
95%.
95. And the sensitivity is the highest one for the 20 whole blood clotting test, nothing else. And same thing with PT INR, but you need to use the INR cut off as above 1.2, not 1.5. to reach the highest sensitivity at 85%.
And when you go to send them home, usually for us is about close to 36 hours that we send them home.
Usually in Thailand, for green pit viper bite, we take the blood at time when they visit, about 2 or 3 hours, and then another 2 or 3 hours later, if it's normal, we send them home, and we have them follow up at the outpatient, but go back to ED, not at the outpatient clinic.
And the rate of
under toxicologist, observation. Yeah.
And what's the rate of reoccurrence?
Yeah. We follow them for 3 days, okay? But we have them follow up once a day until 72 hours. And we did a retrospective study back 8 years if we have any revisit between the time 6 or 7 hours to 24 hours, because we send them back home at that time. So we are concerned about their safety. So there's only 3 patients came back in 320 cases.
320 and 20 patients, you said, or 3 patients?
3 patients came back.
Okay.
Out of 320.
320. So that is...
And 3 of them had no any coagulopathy to come back. They only have swelling, pain, and fever.
Okay.
Nobody died. I already published that in ClinTalks. It just last month in ClinTalks. Look it up.
Okay.
Yeah.
Thank you very much, guys, for the sake of time.
Yeah.
Thank you.
I'm going to sit down, but I will tell you, 50% right off the back are coagulopathic, 75% of them are recurrent. So our rate is much higher.
Yeah.
Interesting. Interesting. And me.
Okay, so
sorry, Dr.
no. Okay, so I'll be talking briefly in 10 minutes about first aid concepts and controversies. I have no conflict of interest. Just as an intro slide which has been presented, snake bites occur frequently with a global estimate of 421,000 up to 1,842,000 cases of snake envenomation and up to 94,000 deaths yearly. The prevalence is high in the tropical regions of the South, the Southeast Asia, Latin America, and Sub-Saharan Africa. And they are most common in the rural areas where you do not have access to professional health care. So rapid antivenom therapy and appropriate first aid measures are of utmost importance to decrease the mortality and the morbidity. Many different practices have been described in literature regarding the use of first aid techniques, and they are being practiced in some areas with no really solid evidence to back up their use. I'll be talking briefly about each. Tourniquet. They are used as a first aid, mostly in developing and rural places. And the problem, unfortunately, is that they can be very harmful. The lack of local oxygen supply will rapidly damage the tissue and result in tissue death and amputation. And once you release the tourniquet, it's even worse because you will have an abrupt systemic absorption of the venom and severe systemic envenoming can occur. Bahat et al. Found a significant increased incidence of local swelling with the tourniquet use. Another study by Franca et al. Described a significant increase in the severity of the local envenomation in those who use tourniquet, and Wang et al. Showed a significantly increased risk of skin grafting even in those who use the tourniquet. There's an inconclusive evidence regarding the duration of hospital stay. Some showed no significant difference, while others showed actually an increased an increased duration of stay. Even there's also an inconclusive evidence regarding the amount of antivenom, whether you use the tourniquet or you did not use a tourniquet. So the guidelines briefly do not support the use of tourniquet. According to the WHO, arterial tourniquets are contraindicated, and their effectiveness and relies really on the occlusion of peripheral pulses, causing pain, ischemia, nerve injury, and gangrenous limbs. The deleterious effect can occur, and they are usually seen within 20 minutes and up to 2 hours after its use. And the Wilderness Medical Society does not recommend tourniquet for envenomation by pit vipers in North America. So no tourniquets. What about cutting the bite site? This is also some of the practice that's done in some areas. It's an oldest form of treatment, and the theory is that you promote local bleeding, and eventually what really happens is that you will have severing of the tissues, including the arteries. You will have, even the wound chewing can increase the risk of a secondary infection, and persistent bleeding can occur as a consequence of the venom-induced uncoagulable blood. So it's really a terrible way to just consider it as a first aid measure. Regarding venom extractors, this is also has been described as a first aid approach for snake bite management. There's different actually venom extractors. There's some of the forms are called the black stones, and they are long advocated as a first aid. The premise is that they will absorb the venom once you put it at the bite site due to the porous nature of the black stone. There's no evidence to support this. There's other even venom extractors which can range even from a negative pressure extractors to so different complex forms, and they are even online. If you just Google them, you can find them online, and they are being advocated. They actually give a false sense of security and cause local tissue destruction. And the current guidelines from the Wilderness Medical Society and the American Heart Association do not support the use of any venom extractors or mechanical suction for pit viper envenomation. What about freezing, burning, and shocking? The use of extreme cold as a first aid is another option that has been used, and it actually results in local tissue damage without any benefit. These shocks neither reduce toxicity in rats that were injected with sublethal doses of the Bothrops atrox venom, nor reduce the lethality in the mice. And in one case, actually, it resulted in coma and incontinence. The United States FDA has banned the use of these devices, and which were previously actually sold to the public for the treatment of the snake bite and the spider bite venom. So there's really no role for any electric shock or any freezing cryotherapy. What about lymphatic flow inhibitors and trypsin injection? This has been described that the lymphatic flow inhibitors release nitric oxide, and which will inhibit the intrinsic lymphatic pump and delay toxicity. Another form is the use of trypsin, which is a proteolytic enzyme that will degrade the protein toxin. And the injection of trypsin at this site has been efficacious in the treatment of eastern coral snake envenomation in an experimental study. But up till now, since there's no really solid evidence for that, they are not recommended, neither the use of trypsin or the lymphatic flow inhibitors such as the GTNO. Further studies are needed to really show its benefit. Now, what about pressure immobilization? There's lots really of controversy regarding the pressure immobilization. The use of pressure band immobilization is controversial in North America. It's due to the perception that they worsen localized tissue damage, and it's discouraged in the American crotalids. The logic is that it's better if you let the venom diffuse to reduce the local tissue damage rather than apply a pressure immobilization. And most pit fibers are unlikely to usually cause lethal systemic effect. So that's why they are really not recommended in the American crotalids. However, also a joint statement has been issued in 2011 by ACMT, by AECT, and AAPCC, and other associations. And briefly, it mentions that the available evidence failed to establish any efficacy of pressure immobilization in humans, but it does indicate the possibility of serious adverse events from its use, actually. And the use of pressure immobilization for the treatment of North American crotolid envenomation is not recommended. So this is a statement from multiple societies in 2011. However, if you look, some authors actually supported its use in the potentially potent neurotoxic or coagulotoxic in the non-Australian snakes that are limited to these snakes, the Echis, the Dysphalidis, and the other ones, and the Naja and the Microrulis. However, further research is required as there is insufficient evidence to support or discourage its use. If you look at the American Heart Association first aid, you will find a little bit different, that they actually state the use of pressure immobilization for venomous snake bites could be considered by applying a pressure immobilization bandage with a pressure between 40 to 70, not too tight and not too loose in the upper extremity, and between 55 to 70 in the lower extremity, around the entire length, and you splint and transport the patient. It's just a reasonable way that it will slow the spread of the venom. But the effectiveness really has been demonstrated for non-neurotoxic American snakes. So you can see.
Let me make a comment on that. That was based on a study that Sean Bush did when he was in California on a pig.
True,
and it was actually a misunderstanding of the results of that study that American Heart Association established this recommendations, and we have informed them multiple times. But as you don't want to go take care of your heart when you have you don't go to a proctologist for your heart, you shouldn't be going to a cardiologist for your envenomation.
Correct. But again, I mean, different associations, those really discourage its use, just the American Heart Association. And in Australia, where there are neurotoxic elephant snakes, the recommendations is pressure immobilization bandage to be around broad or to be applied over the side to cover the whole limb, and the patient should be immobilized, and then the bandage should remain until the patient are transferred to the hospital and received an antivenom. So you do not remove the bandage until the antivenom has been given, so if the patient is envenomated, then the bandage can be removed after antivenom. So they do the testing and then give antivenom, and then they release it. So you can see different guidelines, and I think it's the only most controversial, the pressure immobilization, regarding all the first aid techniques that have been described. What about traditional herbal medicine? It's also described, if you see it in some of the articles. The ingestion of plant extracts and local application of the herbal medications have been really mentioned, but it lacked any robust evidence for that. And many of them even are toxic, such as the strychnine containing monkey fruit, and it can result in secondary infection. And in one of the study by Madeke et al., the use of traditional medicine was not found to be to decrease any of the envenomation risk compared to receiving no aid. In another study in Brazil, it showed that extracts of the plant jatropha, which is a common plant there, it really reduced the local effects from snake bites, but if used as an adjunct to the antivenom. And also another plant or herb was found to reduce the lethality in a mouse model in Indian cobra, the naja naja. This was the Euphorbia hirta. But again, these are experimental studies, and there's no robust evidence for their use. As a position statement, the WHO guidelines have found that there is actually more harm with the use of traditional therapies, and their use is discouraged, and the recommended first aid is really to reassure, immobilize the patient, and move them to a place where they can receive appropriate medical care as soon as possible. So as a conclusion, the tourniquets cause limb ischemia and amputation. Electric shock is dangerous and is not recommended. Suction devices have no efficacy in experimental studies and cannot be recommended. Pharmacological treatment with a topical nitric oxide or trypsin injection delayed toxicity in experimental studies, but as of now, there is no solid evidence to recommend their use. The pressure immobilization bandage, compression bands, and rings have shown in experimental studies to delay systemic venom absorption, but it should be individualized to certain regions, species, depending how timely there is a definitive treatment, and to your local guidelines. Antivenom is the definitive treatment for venomous snake bites and should be administered as soon as possible. Splint rest and avoidance of the movement should reduce the movement of the involved extremity and should be really the practice for first aid. That's it. Thank you.
Thank you. Any question? Any comments?
No, that was a great review of it. But these, these what we call first aid. In the U.S., another company came up with a new extractor. Another one came up with a pressure bandage that now has a hole in the middle of it. And lots of them are driven by financial, by financial concepts.
But the other thing that is important, and I've been to Australia, I don't know if this is applicable in some of the countries where most of the patient will be in hospital within an hour or two. When in Australia, you're talking about 9, 10, 12 hours. That might have an influence as well. Next speaker.
Australian colleague here.
Yes, please.
Okay, thank you. I'm going to talk about the anti-venom storage project in Thailand. I'm the conflict of interest, and just give you about general idea where Thailand is here, and this is Turkey, and this in the Middle East, and we have about 69 million people in the country, and for toxicology coverage for all 69 million people, we only have about 20 toxicologists in the whole country. And we have 2% control. All of the 2% control is in the middle of the country. This is the whole country. This is Laos, Vietnam, Cambodia, Malaysia, and Myanmar around here. And we have 7 significant toxic snakes, venomous snake. Up here, there are vipers. This is Russell viper. This is Calosilasma rhodostoma. It's a pit viper. This is a pit viper as well. This one is found in Bangkok a lot, about 90% where I work. And this is cobra, king cobra, and crates. So from 2010 to 2018, about 6,000 cases reported to one of the poison control center, with the mortality rate about 1%. But we have about 5,000 to 6,000 snakebite cases per year.
Where poison center?
No, for the whole country per year, annual bite rate. But only 6,000 were reported to the poison, one of the poison control. We have 2 poison control, okay? Between 2010 and 2018, and that is about 1% death rate. And in Thailand, we come together and we have a society called Thai Society of Clinical Toxicology. We do the guiding and collaborating national organization for better serving poison and overdose patients. And also we oversee the medical toxicology fellowship training, and also we do guidelines, book, and also we host conferences.
How many toxicologists did you say you had?
About
20.
20. In 2000, we come together and in 2010, and then we established one project. This is based on what's going on in the country. We know that the market of antidotes is small. Often their patents have expired. Demand is unpredictable, and sometimes profit margins are very low. And pharmaceutical industry has limited incentive to develop, and it's not their interest to produce and improve the antidote and antivenom. Moreover, the antidotes are expensive, and sometimes they have a short shelf life, which discourage individual hospitals from keeping large stocks. So WHO recommends establishing a central bank of antidote as an effective and efficient way to ensuring prompt access to these drugs. In 2002, the National Health Security Office in Thailand set up a special system to improve the system to high-cost medicine. And medicine was selected and procured centrally. Okay, that is the I think the key word that I'm going to talk about. And manage all the supply chain, and was outsourced by the government pharmaceutical organization, which called GPO, to the private sector. By this method, we can save about $1 million a year.
1 million or 100 million?
I'm sorry, 100 million.
Oh,
100 million US dollar a year. And also, even we have the new innovative, the way that we can reduce cost of medical care by having the central procurement of the medicine. but we still have some challenges for the antidote and antivenom. So we want to improve the way that we have access to the antidote, and the antidote we have problem with accessing it, but for the antivenom we have another problem. The problem is that because it has a wastage a lot, because each hospital want to stock their own antivenom, and sometimes they stock too many, and then it's just go expired, and then they just discard those medicine, and sometimes we have shortage of antivenom because this hospital have too many, another hospital cannot buy enough, something like that. That is a problem.
Antivenom is produced where?
Antivenom is produced by the Thai Red Cross in Bangkok, and it's non-profitable organization, and it is WHO collaborative center for
And
snake
the cost of it to a hospital?
One vial is about $30 US.
$30 US.
30 to $40 US. Not expensive at all. It's cheap.
That's cheap.
Yeah, and because this is FAB Prime 2, and we only give one time, 5 vials one time, at most 2 or 3 times, Yeah, it's not expensive, yes, because we produce it ourselves. And some of the antidote in this stockpile, we also ask the Thai Red Cross to produce for the country as well. So we have like antidote for cyanide for sheep, methylene blue very cheap as well, because we can produce in our country by the Thai Red Cross and the government. And the program made intensive use. Our program also use the extensive use of information and communication technology, and not only to support the procurement and supply chain, we also use the consultation by the person center to help healthcare provider in the remote area to manage the patient, and also to prescribe antidote and also antivenom. So this is the National Antidote Stockpile Project established in 2011 with all of these organizations: National Health Security Office, GPO, Thai Society of Clinical Toxicology, that is 2 person center, Thai Red Cross. These guys, they help us to produce antidote, and this one is to produce antivenom. This is the first set of antidote in 2012. You can see that no antivenom at that time, but a later year we included antivenom. We have 7 kinds of venomous snakes, but you can see we have monovalent, which is one antivenom for one species of snake. We also have polyvalent as well. In Thailand, we have 2 groups of venomous snake. One is neurotoxic, like cobra, king cobra, crates. Another one is for hemotoxic, is viper. Okay, so we have polyvalent for viper and one polyvalent for neurotoxic. So it's really easy in Thailand. When somebody come in with paralysis, we give polyvalent for the paralysis. And if they have like after bite and they have breathing, we give the polyvalent for the hemotoxic snake.
And that one is made in the US?
No. It's something wrong. It should be something else, not USA. Yeah.
So all of them are produced within
the same,
okay.
same institute.
Thai Red Cross.
Yeah. We have 7 types of snake, but we have low incidence rate of king cobra bite because they are in like jungle. Usually people don't get bitten really very easily. So we did not stock it. We did not keep it in this project. We asked them to use the polyvalent instead. Okay, because
why they have the monovalent like monthly?
Because monovalent is in a long time ago. We just produced the polyvalent, and the number that the manufacturer produced the antivenom more for the monovalent and less for polyvalent.
But I don't know. And most of the time, these patients they'll come without
No, in Thailand we know.
We know which snake has been.
We have a diagram to identify which one is which snake. Yeah, and many times they bring.
And the patient, they will bring the snake with them?
Yeah, many times. They snake. Yeah. And in Bangkok, we only, for the viper, in Bangkok, we only have green pit viper, so it's easy for us to identify. And also for neurotoxic snake, you know, king cobra usually in jungle only, not in the city. If somebody has paralysis after bite, it should be cobra. We know, yeah. We have epidemiology study about that too. And this is all the antivenom. Some of these are exported to USA as well. I see some of these at the zoo Atlanta 8 years ago, 10 years ago. Yeah.
We have in Phoenix Zoo, we have also.
Oh yeah.
Because the exotic.
Yeah, because
yeah,
of the exotic.
Yeah. I also had a publication about exotic snake bite in Quintox into back 2010 probably. Yeah, you can look it up. I write about it. And this drug accessibility, we use the IT technology. We use the Geographic Information System, the GIS, and we stock it based on the risk and the agency of the antidote and the antivenom. You know, for example, for the antidote for cyanide, it has to be at all of the level of the hospital because it needed in 1 hour, something like that. But something really expensive, something not really emergency, like antitoxin for the botulism. Because it is very expensive, we only have it in Bangkok, and then we can fly it to whatever happens. This is based on the urgency, like cyanide antidote. You can see all of the provinces in Thailand. The mercaptan, you know, fewer, and then botulinum antitoxin only in Bangkok.
Do you locally produce it? The botulinum?
No.
You import it?
Botulinum is from Germany.
Germany.
And it is heptavalent. I'm sorry, trivalent. Trivalent. We only have like, we only procure about 10 vials a year because we don't have that much maybe. Yeah. And this is the web online that any hospital in Thailand can access, and they can know exactly. It's in real time. You can pinpoint the antidote, antivenom in real time, and you know the stock in real time.
Yeah, we have a similar thing called antivenom index.
Yeah, I'm going to.
All poison centers have access to it, so that they know where.
Yeah.
Exotic.
And you can put like.
Exotic?
No, we have, well, everybody else has non-exotics, right? It's the exotics that you have to procure because you need it and they're not available. So based on the zoos, based on the, you know, various institutes, research institutes, like in Tucson, we have an agreement with Phoenix Zoo because we have our own exotics and our own snakes. So we have an agreement with them to keep certain number of vials of exotic snake antivenom.
Yeah, it's everywhere in the US like this. In Atlanta, the same thing. I did the exotic thing by drill at the zoo Atlanta. They also have a whole refrigerator for antivenom from outside the country. Yeah, any kind of toxic animal they have, and if the antivenom is available, they have all of those antivenom in the fridge. Okay. I'm going to finish soon. So after we put everything, we want to know like what kind of antivenom, what is the antidote, what is the distance that we can go, number, address, hospital, and then we can know exactly where we should go for. And relevant changes after we have this project is adjusting the sub-national stocking and distribution of antivenom to match the local prevalence of snakebite cases, resulted in more efficient stock management and also reduce the cost. So how much we reduce it? You can see here it's about $2 million US dollars, and in 2012 from 2.2 million US dollar down to 1.2 million dollar in 2013 to 2016. It's about 50% cost reduction. And this is because, you know, we For example, when antivenom is like 6 months, it's going to expire, and then they relocate that antivenom to another place that has high turnover rate of the antivenom, something like that. And this is already published and also on the lesson from the field on the WHO website. You can look it up. And for the summary of the main lesson learned, the strong and sustained policy support and full funding from the national budget ensure adequate supply of essential antidote and also antivenom. And a web-based centralized procurement and distribution ensure these essential medicines were available, minimize cost, reduce waste, and save lives. Thank you.
Thank you very, very much. So at that time, we'll progress to the next session on the debate on pre-medications. Dr. Mohammed Al-Mohammed.
Yeah. Good afternoon. So as I totally agree with Dr. Ashraf, our community different than USA. So I remember in the emergency department once there is a family of 5 people. They came to the emergency because they found there is a snake in one of the rooms. They are seeking to be examined and to be screened because they get scared and maybe they had a venomous from this snake. But yeah, people, they are always seeking to have an intervention. You have to do something for us. Otherwise, you are not a good doctor, or we go and complain. Even if they have a problem after 10 years, they will say, oh, that's because they missed that snake. So I will start my talk about debate, actually. So it is a debate regarding the pre-medication. So just to convince you, this is my aim, actually, my main objective, to convince you with what I will do is to give the pre-medication before the antivenom. To convince people they are very expert in this field is one of the difficult things, but again, I will try my best to convince you. So for things like this is a controversial, we depend on many things, not only the evidence base or the study, we depend on the experience, we depend on what we are feeling. So especially we are talking of working in emergency department, there is a lot of factors, not only studies or papers written before 10 years, before done in different ways. So I will not try to repeat the things what you mentioned, but imagine that when you have a patient, he developed an anaphylaxis after you give him antivenom. This is a very nightmare for us as an emergency physician. I remember one case, he developed angioedema, and I thought, I tell myself, if the time go back, I will give him everything to avoid this bad situation. So there is a lot of antivenom reaction, which is sometimes severe, to get him worse, which will be difficult. So you need to work more and more. So instead of just you give him antivenom, after that you shift it to start to intubate this patient, start him and medications, a lot of medication to save his life. There is an antivenom reaction, which is, you described it just briefly. There is an IgE-mediated anaphylactic, and there is non-IgE-mediated anaphylactic explained, and there is also virogenic and the serum sickness, which is late. So this anti-serum, it is not 100% safe. It carry a lot of risk. So this is just an estimation that's it's reached to up 50%. The adverse reaction, and severe systemic anaphylaxis, which is the most important things when the patient become hypotensive, cyanosis, altered level of consciousness, develop in up to 40% of these cases. There is variation in the percentage of the reaction. It's all the literature reviews depend on the production of the antivenom. Antivenom, it's not produced everywhere the similar. As one of you, he mentioned it before, in the old one, now they have different technique of producing. Each country, they develop it in their own way. So that carry different percentage of anaphylaxis, of complications. But it depends mainly on these things. What's medication we use? Adrenaline and antihistamine and corticosteroid. So this medication we use to give it in emergency medicine. And actually this is a nice medication. So most of the time, patient coming sick, you give it, you become happy. So if I give it to this patient as a pre-medication, What's the harm of that? So let us see what's the evidence behind it, or is there any good literature supporting that? So I will be biased a little. So this one study is low-dose subcutaneous adrenaline to prevent acute adverse reaction to antivenom serum in people bitten by snake, which is a randomized placebo-controlled trial. They found that a reduction from 43% to 11% if you give low-dose subcutaneous adrenaline as a pre-medication. And there is no adverse reaction to the adrenaline were observed in this study. With limitation of these studies, but again, there show big changes in reduction from 43 to 11% from that side effects. So,
where was the study and what was the type of antivenom?
This is what I'm trying to avoid.
Okay.
I think
that's cheating argument.
No, I mean
it's a cheating argument.
No, that's what I mentioned. Yeah, that's why it's different. So you can't generalize everywhere because the antivenom not similar in everywhere. But this is one study showed it's in the BMJ journal. This is another study in the Medical Journal of Australia. Parallel infusion of hydrocortisone, chlorpheniramine plus injection to prevent adverse reaction to antivenom for snake bites. This they found approximately 80% in the first two group to 52 in the pre-medicated group. So they compare, they make it people they give him placebo, and the other group they give him hydrocortisone and chlorpheniramine, and they found there's a reduction in the first group up to 52% of the reaction. Another studies which is apparent marked reduction in early antivenom reaction compared to historical control. This one, what he did, he collect all the historical from, he collect from 220 to 2006, and he start to give the people pre-medication and he compared with the previous one. Yeah, and he found there is a big adverse reaction from 47 to 2%. There is a lot of things regarding the study. One, the antivenom, it was different before and now it's different. Also here in this study he used previously there was a fast drip. Now in this study they started to make it a slow drip, the anti-serum. So this could be another factor, but we should consider these things as a factor also to reduce this adverse reaction. So just make it, just as an emergency physician or as toxicologist, you will give this anti-serum. It's better to anticipate than to react. So if you face one case in real life, patient he develops severe anaphylaxis, he will say, listen, I will give every patient pre-medication. I don't care for what all this is because this could reduce. Yeah, well, I know. Maybe this patient, he will develop, even you gave him, but at least you are anticipating this one by our preventing, especially if you are not sure about the purity of your antivenom, you are not sure about this, how they produce it and how there is this side reactions. So this is just, I tried my best to convince you. I'm sure you are convinced.
Mohammed will do the other part discussion.
Mohammed, he will try now, he convinced you.
We'll finish and then we give them 2 minutes or 2 minutes to discuss.
Okay, now I would like to talk about the mechanism of this pre-medication. For me, I will not give any pre-medications. They are using 3 medications, steroids, antihistamines, and catecholamines. So just to understand why I will not use these medications, I have to understand what is the mechanism of action of anaphylaxis and how these drugs can help us to treat adverse reactions. Then some evidence from the literature. So basically, antivenom is an effective medication to treat snake bites, but the problem is in the safety. a lot of adverse reactions has been there in the literature for a long time. Yes, it has been improved, but still, like in some studies, in some studies, adverse reactions like reached up to 50%, and in some other studies, adverse reaction has been like at around 10%. So there is a varieties in adverse reaction, and this is most likely secondary to the quality of the antivenom. So instead of trying to treat these adverse reaction, why not to put our efforts to improve the quality of production and to see why like there's variations between the different manufacturers. So these are types of hypersensitivity reactions. Most of the reactions that we see with the secondary to antivenom are antibody mediated. We have type 1, which is IgE mediated reactions, type 2, and type 2 is non-IgE mediated, and type 3 is the serum sickness or the delayed one. So basically we have to understand the mechanism of each one of these hypersensitivity reactions and how we can treat them. So the first one is IgE mediated. Basically IgE mediated anaphylactic reactions are early. So and the main cause for these reactions is the presence of IgE against any component of antivenom. Antivenom, there's proteins and antigens. So if injected in someone and he's having IgE against any component of the antivenom, then they will develop this type of reaction. So this is an example of how these reactions will develop. This is the mast cell. And inside the mast cell we have a lot of inflammatory mediators, including histamines, leukotrienes, and prostaglandins, and other inflammatory mediators like TNF-alpha, interleukin 4, 5, 6, and the others. So basically, once there is interaction between the IgE and the proteins, this will cause degranulation of the mast cell and release inflammatory mediators, and this is the cause of these adverse reactions. So for example, what will happen if histamine is released? You will start to have, because we have histamine receptors distributed everywhere, so they can cause bronchoconstriction, they can cause itching and skin rash, urticaria, increase acid secretion in the stomach. Also, they can act in blood vessels, cause vasodilatation and inflammation of sinuses. So, to summarize, IgE-mediated anaphylaxis are early, caused by basophil degranulation and release of histamine. So these are clinical manifestations. So the other types of hypersensitivity reactions are related to complement activation, and they will have the same clinical manifestations. Like they will have increased vascular permeability, vasodilatation, skin rash, urticaria, and pain. So the last one, which is the late reaction or the serum sickness, this usually occur within like 5 days to 2 weeks after antivenom administration. And basically the patient, they will present with skin rash, sometimes renal involvement in form of glomerulonephritis and lymphadenopathy. So these are the medications that has been used for treatment of the adverse reactions. The first one, histamines, steroids, and catecholamines. So if we go for histamines, they will act on antihistamines, they will act on H1 receptors. So basically, they will prevent adverse reactions secondary to histamine. They will not prevent release of histamine. Histamine is released already. So even if you will give a pre-medication, they will not prevent release of histamine. So only they will counteract the actions of histamine. So theoretically speaking, they are not useful in treatment of these adverse reactions. So what about the literature about histamines and steroids and preventing adverse reactions? This study, what was the result of this study? Yes, they found that pre-treatment with low-dose adrenaline was safe and reduced the risk of acute severe reactions to snake antivenom. But for Others, adrenaline significantly reduced severe reaction to antivenom by 43 in 1 hour, 43% at 1 hour, and by 38% up to 48 hours. So steroid and antihistamine, they did not. So there's no evidence from this study that antihistamine and steroid can prevent adverse reactions. Yes, there's evidence about only adrenaline. So again, another study, in this study again, they concluded that yes, there's evidence about adrenaline, but the other antihistamine and steroids, there's no evidence that they can prevent adverse reactions. Again, this is another study done in Australia. They found that hypersensitivity reactions occurred in 11 out of 40 patients receiving any form of pre-medications, like so 28%, and 2 of the 11 given adrenaline for pre-medication, versus 20 of 86 not receiving pre-medication. So they concluded in this study hypersensitivity reactions were not common, but most were not severe, and pre-medication was not associated with any reduction in these adverse reactions. Even, for example, steroids, we know that steroids, they will need time to act. Like they cannot, yes, they have a lot of beneficial effects, but their effect will take time. They cannot like, they have effects like within a short time, like 1 hour or minutes. They need time to suppress immunity, decrease antibody production, etc. So steroids, there was no evidence about their beneficial effects to prevent these adverse reactions. Antihistamine also, it has been found no beneficial effects in preventing adverse reactions secondary to antivenom. Adrenaline only has some evidence. So in conclusion, so there's lack of evidence about the efficacy of hydrocortisone. Lack of any evidence about the efficacy of antihistamine, some evidence about efficacy of adrenaline in reducing adverse reactions, but again, most of these studies, yes, they mentioned that some beneficial effect from adrenaline, but none of these studies has been talking about the side effects. Adrenaline is a medication, and also it has a lot of adverse effects, including cardiovascular, the CNS manifestation. So none of these studies has been talking about the adverse effect of adrenaline. Even why I will give a medication without, clear evidence, and also it has some adverse effects. Also, adrenaline can be used as like treatment. Once these patients, they will develop the adverse reactions, yes, it successfully can be used as a treatment, not as a prophylaxis. So we need further clinical studies needed to confirm the efficacy of these medications. In conclusion, we have to concentrate on the quality of antivenom, not on like to prevent, interact to the adverse effects. If the quality has been improved, most of these adverse reaction will be improved. In some countries, like it reaches up to 50%, it's very high, and in some countries, 10%. And for us in Saudi Arabia, it's less than 5% that we have an adverse reaction. So we have to concentrate on improving the quality of antivenom. Until this improvement will take place, so we have just to be prepared. If any patient is having any adverse reaction, management of acute as well as delayed reaction may occur. So just be prepared. Like, okay, use steroids, adrenaline, everything should be prepared in the health department. If the patient is having any of these adverse effects, then it can be used as a treatment. But for prophylaxis, I will not use these medications.
So can we have maybe he has a response. 1 minute, 1 minute.
Okay, so as he mentioned, he put all the studies that supported. The first one, they said low dose in epinephrine, it's reduced the adverse reaction. And there is a study also that I mentioned that said there is no reaction from the epinephrine when they use it. Agree with the antivenom, the quality, yes, but again, we don't know. We don't have that. You can't say 100%, and there is variety between the adverse reaction between this antivenom. So for me, working in emergency, instead of I observe the patients, keep myself busy and prepare the nurses, I will give pre-medication and I have fun.
Have you tried to do your own study for those to really randomize those with pre-medication, those without pre-medication? If you really have experience with that?
No, actually,
you just pre-medicate everyone?
Yeah, my experience only one case. When I faced it, when he developed a severe anaphylaxis, this is my personal. After that, I said, I will give pre-medication, whatever they recommend, because I was in very bad situation with the patient. He developed angioedema and he has hypotensive from the medication. The family, they said, what did you give him? I gave him, this is the treatment you're seeking for.
Muhammad? Again, like in these studies, one study, the adverse reaction was 50%. Like for this patient, I prefer not to give the antivenom. If you will give antivenom, you will have 50% of your patients, they will have severe adverse reaction. I don't know what is the mortality rate from the snake information, but it will not reach 50%. So it's a very high adverse reaction, most likely secondary to the quality of these antivenoms. We have to concentrate on how we can improve the quality of antivenom production. Plus, again, steroids, their effect will be delayed. They will not have immediate actions. Histamines, again, they will not prevent, antihistamines, they will not prevent release of histamine. So even if you use them, they are not useful. Only they can counteract the mechanism of already released histamine. Adrenaline, yes, there's some.
So you agree with me? You will give adrenaline as a premium?
No.
So he agreed. He said.
There's evidence, but still, adverse actions of adrenaline have a serious adverse reaction, including cardiovascular, CNS manifestation. Adrenaline is useful as a treatment. Why I will not use it as a treatment? Like if someone is having like hypotension, why I can use it as a treatment choice, not like as a pre-medication. This is
we'll have let's say 2 divisions, three divisions goes.
Okay.
Make it quick, please.
I think we should weigh between risk and benefit. And same thing in Thailand, we only have 3% of anaphylactoid reaction. Whatever, like anaphylactoid, anaphylaxis reaction, we only have 3%. Yes, if your country have like 80% of reaction, I would think it would be benefit from pre-medication. But for 3%, even the reduction rate, like 30%, you will, reduce from 3% to 1%. But you have to think about the risk of giving the pre-medication as well.
Can I ask you a question?
Yeah.
You have an experience with anaphylaxis reaction. So
Only
adrenaline, in what form you give it in that scenario?
I did not give pre-medication at all.
No.
Yeah.
You have somebody who developed anaphylaxis reaction in front of you. This is a practical dilemma. So how would you give that adrenaline?
I am.
And that might be a problem for people who have.
I know. I'm going to talk about it. We discussed about this too. So we only use we call it insulin. The insulin syringe, which is very small.
But that's a problem. You are giving it subcutaneously,
yes.
And you're probably not treating it.
No.
Because the absorption is very, very slow.
Yeah.
And this is a dilemma, and I've had that question before. I don't know what's.
We only have really low rate.
Yeah, we treat. If you can give it IV, you gotta give it IV.
If
you can't give it IV, then IM, but you need actually a good sized needle, and you need to have it needs to be 1.5 inches to go into muscle.
And then you're gonna get a hematoma.
Let me give you a scenario. I think what we forget, and in toxicology especially, because we're acute care, we forget the psychosomatic. I would tell you, I'm sitting here, I'm very atopic, okay? I haven't been given antivenom, but I would suggest you come. I tend to scratch. I say, come rub my arm right now, and you see how it's bumped and how red it is. It's a reaction for which, probably if I was in the ED, everybody would have given me they would have given me antihistamines, epinephrine, and such. And we forget these things. Lots of times patients who come in, and that, I was just looking at a study that was done by our colleague Jeff Ispitz. They're looking at anaphylactoid reaction. Anaphylactoid reaction is also, lots of it has to do with the psychosomatic response of the patient. And I would suggest the effect of the antihistamines is more psychological.
Yeah.
Okay? If you give them benzodiazepine, they probably would not be become as atopic. You know, as again, come here, rub my arm, and you'll see that, oh my God, Shirazi over here needs epinephrine. No, Shirazi over here is atopic and just sits, even his clothing causes him to have lumps and bumps. And those are the type of things that we forget. Also, psychological response. One of the main things, you know, I've gone and talked to a toxicologist who they claim that snake bite envenomations doesn't have any psychological response. Now, most of us know that, and nobody has done clinical trials, that you don't need a snake bite and then being rushed to the hospital in order to develop night terrors or psychosomatic response. I have a tox clinic and I see these type of things to it. But most toxicologists, you ask them and say, acutely, no, they don't exist. You know, and they say it like they know it, you know, and it's easy to come up with, again, what I say, nonsense. And not everything, you gotta realize that not everything can be reproduced by clinical trials. Just because you had 50 people in each arm, okay, it doesn't mean that everybody in that arm is gonna develop, you know, any type of anaphylactoid reaction so that you would treat or not treat. So,
I had just, till the time you have anti-snake venom which comes from, which has a foreign protein, you have the risk of a reaction, right? Now, he made a very valid point. Find out what is your proportion. Even if it is 50%, you know, you are giving pre-medication to 50% people, and it is a medication. It can have potential consequences.
I've seen MIs actually.
That's very, very important.
So who is using pre-medication, just to know?
I don't.
Who's using?
I don't. We stopped the infusion and
for pre-medication, I might give somebody a benzo just to chill them out. Because I know that person is going to have not an allergic reaction, but they're going to go haywire. But I've seen MIs actually from, you know, severe bee envenomation, and they gave the individual adrenaline, 89-year-old, and of course the troponin bumped.
But you have to be careful in tropical country, because if you give benzo, many patients got bitten by cobra.
Yeah.
They have, you know, neurotoxicity, and you don't know if this is from
I would
venom or
suggest,
this is from
I would
benzo.
suggest,
We're talking about 1 milligram or 2
we're
milligrams.
talking about looking at your patient and treating.
I know.
The fact that is most of the medicine, you know, the reason it's also art is that you know which patient of yours is going to freak out, okay? And I had a guy that jumped out of a plane, his parachute didn't open, a military guy, landed, broke both legs, tib, fib, and his femur. And he's sitting there, I'm saying, asking, do you need any pain medication? No, sir. Okay? And then I have a guy that his finger, you know, has a nail, is, oh my God, get the surgeon in here.
It's very individualistic. That's what,
That's totally
at
true.
the end of the day.
So welcome Bruno, and now we diverge to Europe.
We'll talk about a French experience with Botrops lanceolatus. So you will tell me why France has a position in the snake envenomation symposium. Because of course in Europe there is really not an issue with snake bites. In France we have only vipers, and we have two kinds of venomous vipers, Viper verus and Viper aspis, and we have a very efficient antidote, which is FAB2, and we just give one vial and generally everything is okay. But maybe you don't know that France has also some islands in South America. And we have Guyana, with probably the second largest Amazonian area in the world after Brazil. And we have also a small island called Martinique, you see on the map. And what is, so this is a French overseas department in West Indies. And what is very interesting in Martinique is that we have a snake there called Botrops lanceolatus, which is a specificity of this island. It is a member of the Crotalidae family. It is considered to be the only snake involved in this Caribbean island, and it is venomous. And you find this snake only in this island. So this is the only venomous snake in this island, and you don't find it anywhere else. And it is estimated to have about 20 to 30 reported bites per year. Also, probably it is underestimated. So the toxicity is related to the Botrops family. So you have what we call the botropic syndrome, with the rapid onset of lesions at the bite site, with hemorrhage, pain, edema, leading to dermomyonecrosis and local infections, with possible severe sequela, and also systemic symptoms, with coagulation impairments, and hemorrhage syndrome and acute renal failure, as you know. That is the botropic syndrome. Botropic syndrome, of course, I will not focus on that, I will go rapidly, is related to various enzymes contained in the venom that may act at different levels, inducing vasoconstriction, activating platelets, activating plasma coagulation, and even fibrinolysis. Botrops lanceolatus is quite different. It belongs to the botropic family, but it has a quite different outcome. The major enzymes in its venom is hemorrhagic snake venom zinc-dependent metalloproteinase called hemorrhagines, and in this species is responsible for vascular damage with endothelium injuries. So it inhibits the coagulation, it activates platelets, and it results mainly in prothrombic activity. So with Botrops lanceolatus, you will have the local signs, symptoms like with all Botrops, but from a systemic aspect, you will have thrombotic complications in 30% of the patients, with brain, cardiac, and pulmonary thrombosis. So no hemorrhage, only thrombosis. And this will lead to organ failure, mainly neurorespiratory failure, death in about 15% of the patients if not treated, and sequela in 20%. So the difference, it belongs to the Botrop family, but it doesn't give hemorrhage, but just thrombosis, extensive thrombosis due to endothelium activation. Hopefully, we have antivenom, which is Botrofab antivenom, so which is just a specific antivenom dedicated to this snake, produced by Pasteur Mérieux. It is obtained from hyperimmunized horses. It contains FAB2 fragments mainly. As explained with other antivenom, its regimen is adapted to the inflammation severity. It was synthesized and first administered in 1993, and it is effective to prevent the consequences of severe bites if rapidly infused, and of course its effectiveness is function of the rapidity you administer it. And till 2000, we have a certain experience with this antivenom. It was published, this experience was published in Toxicon in 2006. About 110 patients received this antivenom therapy within 6 hours and no thrombotic complication occurred. So it is quite efficient. Unfortunately, since 2000, complications reappear. So this is, I think, interesting for MENA region because you will see the reasons. And we performed a study on the 10 years between 2000 and 2010. So this study included about 100 patients envenomated with Botrops lanceolatus and treated with Botrofab. So you see that, of course, we have the local usual complications, but strokes reappear. Where it was 0, some strokes reappear, and even 1 death occurred. 9 patients developed ischemic strokes, including 6 who received the Botrofab within the 6 first hours. So suggesting some resistance to this Botrofab that appeared since 2000. Of course, not all neurological lesions were clinically symptomatic. And you see that MRI performed in these patients showed various thromboses in various areas. But what was characteristic that almost all the patients have infarcts in the territory of the posterior inferior cerebellar artery. So, like, this was very specific with this bite, this illumination. You see here that they have a bilateral infarction in their cerebellar artery, and the branch, the posterior and inferior branch called PICA. So all these patients had a PICA infarction, which is not usually in common patients. There were also other CNS injuries. Here you see injuries in the caudate and bioccipital infarcts. Here bilateral junctional infarcts. And in all these lesions you have diffuse thrombotic microangiopathy. This is the case of the patients who died with infarct in the cerebral cortex and obstruction of the small arteries. We, of course, studied the clinical parameters of these patients, and we saw that all these patients presented biological signs of coagulopathy and elevated troponin in comparison to those who did not experience these complications, and these appear to be key indicators to suspect brain thrombosis. And thrombocytopenia was, in the multivariate analysis, suggestive of this neurological accident with the PICA complication. So, to summarize a little bit, so during the first 10 years of the 21st century, we observed an elevation in the incidence of stroke despite the treatment of the patient with an efficient antivenom with an incidence of about 9%, a mechanism of ischemia induced by coagulopathy, with a documented case of endothelial injury with microangiopathy, and in almost all the patients junctional thrombosis in the brain, reaching mainly the PICA artery. And this is, of course, very specific to our botrops. So we questioned about decrease of efficiency of our antivenom, which is specific and proved to be efficient 10 years before. So maybe the same case that was observed. So we hypothesized different possibilities. The one which is probably the most exact is modification of the venom composition, because the first antivenom was produced based on 25 snakes caught in Martinique, and they were adult snakes. And probably the new, younger snakes developed new epitopes, and those are not covered by the Botrofab antivenom. So it was requested to produce a new antivenom, and about 130 snakes were caught in Martinique, mainly now young snakes, and the venom was collected, and a new Botrofab 2 was produced by the Pasteur Mérieux, because this is a public health issue in France, in Martinique. So a new antivenom was produced in 2011, and since that date we made an observational prospective study, and this is the preliminary results of 7 years of observations. We treated 160 patients with grade 3 and 4 envenomation with this new antivenom. So the delay was relatively short because the island is small, and of course we observed local complications in the majority of the patients: edema, pain, bleeding, but lower rate of troponin elevation and no thrombotic complications of fatality in none of these patients. So we were able to produce a new antivenom based on changing in the epitopes, and it seems now to be efficient again. So
Bruno,
we appear to be optimistic.
Younger snakes had the epitope?
Sorry?
Younger snakes had the
Yes,
epitope?
yes. This is the hypothesis, but it is not still not proved.
Okay.
So we have a collaboration with the team of Guterres. I don't know if you know him. He's a scientist that make experimental studies on snakes, and he's currently studying these antigens from different species, and especially that to answer this
So originally they were all adult snakes? That
yes, originally the first antivenom was produced from adult snakes.
Okay.
Then there was a failure 10 years later, and we produced a new antivenom, and now it's efficient. So we can be optimistic for the future. Unfortunately, no, because last year the pharmaceutical company decided to stop manufacturing this new antivenom. So now we have also some problems, and now we are testing different Brazilian, Panamanian, and South American antidotes that are directed against Botrophab families to see if they act on this specific Botrophab lanceolatus and to choose the most efficient one, because probably in 2 years, 2 or 3 years, when the storages will be finished, there will be no effective antidote to this Botrophab.
Who produces it? What pharmaceutical?
Pasteur Mérieux, which
Okay.
is a French
Is it
company.
Is it a private?
Yes, it's a private. Yes.
Okay. It's Institut Pasteur, it used to be a public.
It is. Institut Pasteur is private too.
Ah, private.
Yes, yes. And Pasteur Mérieux is probably connected to Institut Pasteur, but it's not Institut Pasteur. So I thought that this experience could be interesting for you, because here we have some certainties about the epidemiology, because we know exactly the snake, because if you have an envenomation in Martinique, you are sure that this is only this snake, because there is no other venomous snake, and this snake only exists in Martinique, nowhere else. And it is different from all other Botrops snake family because of its mechanism. Botrop venom usually activate coagulation and results in hemorrhage, while here it mainly destroys the endothelium and results in thrombosis.
Now we see the same thing in terms of juvenile rattlesnakes are much more coagulopathic and without getting any signs or symptoms of local toxicity. So, but in our case, using higher amount of antivenom actually reverses that. And it was interesting, and we presented this. We had 5 patients that we found actually hypercoagulable states. We found DVTs in them, which we had never seen before. So it's interesting that you have this problem,
Yeah.
but this probably exists in other snakes, but not as prominent,
Yes.
because the epitopes are not.
What
as
is
prominent.
here very curious is always the same localization of thrombosis in the patient that were treated, so that maybe the antivenom is not totally inefficient, but it allows to control the coagulation, but not in this very small area of the cerebellum.
Because that's
where
a
it is
different
not controlled.
question.
And how many vials do you give?
So the number of vials is adapted to the severity of the clinical features, and all these patients who develop this have the maximum recommended dosage.
Which
So,
was?
but I don't remember, but I can send you the exact dosage. But it's the maximum one, but we don't test higher dosage. But normally it's adapted to, as it was shown, to the LD50 in mice, extended to humans, the same adaptation, with cases where the venom concentration was measured. Also, of course, in all these cases, no venom was measured, but it is adapted, and especially we have 10-year period of more than 100 cases treated with this antivenom with complete efficiency. So there was something new.
So about the juvenile snake with the more systemic effect, there's a study already published in Clintox as well. It's from Brazil. And I was the reviewer for this study, and they capture the juvenile compared with the adult, and they compare the systemic effect and local reaction. It's true. There's evidence already published.
Thank you very much.
We know it's true. I see it all the time.
Yeah, but we need to prove it.
Thank you. So I know it's not time, but if you spare us a few minutes, just a difficult case that, sorry, you can
Let's
just,
talk.
yeah.
We'll talk after.
In lunch.
We have
Let's
our,
talk, yeah,
we have our
Because
own
we have
set
just,
to be
we're just running late, so it's.
Your reaction.
I thought just to share this. I discussed this earlier with Dr. Ashish Palla, and maybe I get, some feedbacks from you guys. So this is a case as a 16-year-old boy who I received the call through phone consultation on Saturday around mid of the day. And basically they think that this is a case of snake envenomation who has been receiving antivenom, but there is no improvement. And in the initial presentation, you can see that that's his foot. Usually we see, like in most of the cases that we see like quite good marks of the fangs. And you see significant swelling in most of the cases. But in this case, it looks like only bruises. There was no fangs, only like a bruise, and there was no swelling. And so the patient presented to that hospital 2 days prior to the call. The patient having significant severe coagulopathy. His INR was more than 10, his BT was more than 120, and his fibrinogen was undetectable. The rest of his examination was unremarkable, and the rest of his lab investigations, including CBC, liver function test, and renal function test, was normal. Okay, and he is not known to have any medical problem previously. So, according to the protocol that we are using, and it's not really clear, but we have this protocol from the Ministry of Health, and it's been published by an infectious disease team in the country. So, and then they categorize the envenomation into no envenomation, mild to moderate, and severe envenomation based on the local manifestation as well as the lab investigation. So if you have a patient who is having severe coagulopathy, defined as a BT more than 50 seconds, INR more than 3, or platelets less than 50, or fibrinogen in less than 0.75 gram per deciliter, then that's considered as severe envenomation. And in that case, patient should get the maximum dose of the snake antivenom. The snake antivenom that we are using is the Saudi polyvalent, because we don't produce our own. And the maximum dose is 10 vials, which is 100 milligram. So 10 ml in each vial.
How much
So
does it
by the
cost
time,
you?
yeah.
The cost to the patient and the cost to you?
Yes.
A while?
No cost of, there is no cost to the
It
patient.
is like
There's no cost for the
non-profit.
patient?
It's distributed for free for all the hospitals in the kingdom and even to GCC countries. Like I think it's free. Yes, you are getting it. Or
No, we are getting it, but with the minimum fees, so it's not.
It's
And
not
the
like
patient,
not costly.
patient is free
I've
of
been to
charge.
the antivenomous too,
Yeah.
in the harass. I've been there. So,
So eventually, by the time they called me, he was already 48 hours, and so he received around 70 vials, because according to the protocol, they should repeat the coagulation profile every 6 hours. If it is the same, then they repeat the same dose that they started with. So, and then they called, and the reason they called basically because on Saturday, so he presented on Thursday in the evening time, around 9 p.m. And then on Saturday, patients started to develop sublingual hematoma, but there is no active bleeding, and so they were worried. They already gave him FFP and cryoprecipitates, and his repeated coagulation was almost the same. So we said, and that's when we thought this could be refractory coagulopathy. And so I don't know what is your thoughts about refractory coagulopathy, because this was my first case of that scenario. So I looked into the literature. I didn't find much, except some is from the Indian literature, where they say they, instead of giving boluses of the antivenom, they give infusion. So we decided to give him infusion over 6 hours. So the same dose that he received, 100 ml of the antivenom, we give it over 6 hours, and we continue giving the FFP and the cryoprecipitate. The repeated coagulation after 6 hours and after stopping the infusion was getting better. So we decided to continue with the same scenario. Unfortunately, the repeated coagulation after another 6 hours was still, again, severely deranged with an INR more than 10 and BT more than 120 with undetectable fibrinogen, though he showed a little bit of improvement in his parameters the 6 hours before that. So at that point, we decided to shift the patient to the, I will not go with this, but we decided to shift the patient to the tertiary care hospital where I worked, and then I saw the patient in the ICU. The patient was fully awake and conscious, but he had a significant swelling in the low part here on the chin and in his face. And there is a hematoma underneath the tongue, but there is no active bleeding when he arrived to the hospital. And so we did the coagulation again, we repeated the coagulation, and then at that time I contacted Dr. Ashish Balwar, and he said, you might cause more harm by giving the antivenom. Let's stop the antivenom and treat the coagulopathy with the blood products and see. So we continued giving him the blood products, but his condition started to deteriorate. The swelling was getting worse, and he started to have bleeding from the gums. In fact, he was I think he was swallowing his blood into the lungs, and he was.
So before you go forward, why did you not continue with antivenom and blood products?
Okay,
Because
so
that's what we usually
that's what
recommend.
we usually do. Yes. So
If you have a severe coagulopathy,
yes.
and again, the only time when Ashish wasn't here, the only time I saw was the internist was giving blood product without antivenom, and the patient was getting worse.
Yeah, so we are talking about so that what the envenomation happened on Thursday, and we are talking about already Tuesday by the time. So it's almost like 5 days from the time of the exposure. So that's when, according to their experience, basically there is no harm after, there is no effect of the antivenom after 48 hours from the exposure.
Why I say that?
Yeah.
I showed you the data, 900 ml ASV down to 150 to 200. When you give anti-snake venom, you will only take out what is circulating in the blood.
Yeah.
Once you've given your maximum dose, whatever you continue giving is not going to take anything out of the tissue if it is already bound. If it has caused harm,
If it's already bound, but that's making an assumption
No,
that
see-
there is not equilibrium between the, and it's not coming out and going
And also
back
the
in.
site of action of the venom is in blood, not in tissue in this case.
So carry on, doctor, and then we'll have a discussion.
Yeah,
So what
let's see what happens.
Yes, see what
So
happens.
you stop the antivenom, you're giving blood product, a shish is involved.
Is he intubated now?
No, so yes.
Yes. Why didn't you consider that? I saw he was like a very huge zone here, right? There was the
No, that's the heel.
That's
That
was
heel.
the heel.
That's the
Ah,
heel.
okay.
That's
But
what the
didn't you not consider to operate this area?
to
No,
get the
because
blood.
the
No,
patient-
when
no,
I mean
To get the
So
the
that
venom.
picture.
So
If a
the
depot.
idea is, if there is a venom
Depot, that's what he's talking
that
about.
you can. The fact is, you know, I'm not a believer in venom depot, but we last 3 weeks. Our venom
Yes.
lasts 3 weeks.
And there is
We know
there is
because
big
of the
evidence,
coagulopathy.
the big data. You can still give antivenoms even up to 7 days, 10 days.
But with the bleeding, how they're gonna like
So-
do a myotomy or
So
something?
no, but it's not. He basically that picture. He did not develop any significant swelling. By the way, it was only ecchymosis at the same day. By the second day, the ecchymosis almost disappeared.
And did
It's
we
not
do
like
any
it is.
studies on this
Did he
individual?
really have a snake bite?
Or did he have other
So,
issues?
Was it something else?
Let her finish the-
so at this point, we started to question whether he actually had a snake envenomation or not. So we go back to the history. In fact, we involved the environmental health, and they went to the area and did screen. They did not find anything unusual. He was playing in a coastal. He lives in a coastal area near to the beach, and then he. That's how they say it. Right? So they basically he was playing bare feet. And then he went back home. On the way back home, it was already dark. He felt that he stepped on something soft, and then he felt the pain. And then he heard the sound of the sound with something like, but he did not see anything. So we were not sure whether this was snake envenomation or not. But because we
Looked like
were
a
not
duck.
sure whether the
like a duck.
antivenom was helping the patient or not, we decided to stop the antivenom, continue with the FFP and cryoprecipitate, and do CT chest and head because he was becoming a little bit drowsy and he was complaining of chest pain. And the CT did not show any intracranial hemorrhage or bleeding. He had a significant myositis over this area only, not any other part. His foot was completely fine, and he had an evidence of pulmonary hemorrhage bilaterally. Maybe he swallowed the blood because of the active. So we decided electively to do tracheostomy for him to reserve his airway just in case. Then we involved the hematologist at that point, and then the hematologist said we have to do exchange transfusion. And that's another thing that came up in the management. In such a patient with refractory coagulopathy, should we consider exchange transfusion in an early stage rather than waiting for him until that stage? He received 2 sessions of exchange transfusion. He received multiple FFPs and cryoprecipitate, and eventually in the subsequent 48 hours, his coagulation profile improved. He became better, and then we discharged him home without any sequelae.
Did you send any sample of the blood for venom detection anywhere in the world?
Anywhere in the world, I reserved the
would be
sample, but
marvelous.
I don't have anywhere in the world. I do
See,
not.
there are only 2 possibilities when you have a refractory coagulopathy. One, you are dealing with, and your ASV is not working. One, you are dealing with a venom or a snake, which you're not covering with your ASV.
Yeah, most likely.
So what's the point giving liters of ASV to a patient when you're not covering it? I don't know.
So,
I was very kind
exactly.
of.
So now it's when, according to the snakes that we have, there are certain type of species that might. There was a question. There was a paper published in 2004 by a hepatologist, and he basically questioned the efficacy of this the Saudi polyvalent antivenom against one kind of species, which is Echis omanensis. And it can cause delayed coagulopathy and maybe refractory coagulopathy.
Do you have a sea snake?
we have sea snakes. We thought about the sea snakes, but the sea snakes.
Reaction, no hypogenuria.
So I looked into even the anatomy of the sea snakes. The type of the teeth appearance is totally different, and you have to have a local side because they have to have a long contact with the patient before they do the envenomation part. So which was not there in this patient.
And the CK would be.
So, and they don't. And he was not. He was not on the shore, by the way. He was in between the houses. So
we have hump nose pit vipers, which are not covered by AAC. And we reported cases, we had multiple cases. One of them we reported was a severe intraperitoneal hematoma. And he stopped bleeding because there was a compression effect. It couldn't grow anymore.
Yeah.
So there was a compression effect and it stopped bleeding on its own.
He survived.
We didn't touch that hematoma, he survived.
You have a picture?
And there was then a spontaneous resolution. But we didn't give any more anti-snake venom to them.
And no other studies was done on this kid to find out whether he had any type of a pre-existing condition?
Yes,
complicated?
yes.
You mean
That was the second
Protein C, protein S deficiency, factor 5Y, then.
They did, all were negative. He'd been followed up by the hematologist. All his labs.
So which test did they do when you say all of them?
I have to double check, but it's the complements.
GCB, usually the routine in the region.
Yeah.
We did the CBD,
C3 and C.
Yeah, the factors, the ladens.
Factor 5 laden
and there's
routine
third one
CNS.
they do. There's third one. That's the routine hemolysis.
And they check for hemophilia.
And hemophilia, yes, that's the
standard of care.
They check for factor VIII deficiency.
No, that G6PD.
We have had it so that the patient appears to have a wart, and then we check him, and they had one of the hemophilias.
So the question I think for
and we had to give them factors.
So the question now for
No, because you talked about two hypotheses. I understood the first one, that the species is not covered. Okay. What is the second?
One is the species is not covered. Second is that if you have a circulating venom which you are not taking up, when you were saying, then the exchange transfusion. But you can't offer it upfront if you don't know what this person is having. So, see, your 99% or 99.9% of your snake bites would be the usual snake bites which would respond to whatever anti-snake venom you give. So you can't offer it upfront. So if it is not working, then but adult exchange transfusion is a dangerous thing. It's not so simple.
So it's clear from this case, as far as I understood it, correct me if I'm wrong, that you still have a venom active in the body because you're pouring the factors and it's not correcting.
But anti-snake venom is not acting because it's not.
So that's the second part. No, the second. So the first part.
Well, it might be that your antivenom actually is not working at all.
It's not working at all. So that's why I said stop it.
So what I'm trying to say is, you have a venom you're not neutralizing. It's still in there because the evidence that you're giving a lot of factors and it's not correcting.
Yes.
So the question for us here is, where do you go from there? Do you set it out? Clearly, you could not set it out with this patient.
Yeah, I mean, if you look at the timing, when do you decide that your antivenom is not working?
See, we stopped giving. We stopped giving in 24 hours time whatever maximum antivenom we have given.
I agree.
And after that, no more. If it is not working, then it won't work. So there's no point continue giving antibiotics. You're not
What's the
doing
maximum
anything.
for you? You have decided maximum dose.
300 ml.
Based,
Yeah.
But the fact of the matter is, for us, there is no maximum. I have given to the gentleman that was bleeding like, and he was the son of a hematologist. I gave him, I think it was the highest number of Crofab ever given in the U.S., which was close to 68 vials that he received. But we were able to control.
But when you see an improvement,
and he got improvement.
No. So you're given the first one.
See, you were also giving blood products. So he may have responded to the blood products, not ASV.
No.
This guy came in, we got him under control, went to the medicine service after ICU and us let him go. He reoccurred, which is a common thing. The guy didn't know what to do, gave him blood products, got worse and worse. He dropped his hemoglobin to the level of 4. Then we got him back, gave him again antivenom, okay?
Loading
and we loaded him till he stopped bleeding, and then we gave him blood. And he got better.
This patient did not
so
respond
why
at
did you-
all to the antivenom.
Yeah, but what, that's the
problem.
difference. You believe that your antivenom is going to work.
Yeah.
But she did not believe the antivenom
The
is going to work.
antivenom is
I
going to
thought
work.
initially it will work.
Maybe it's a different species not covered.
Yeah,
that's what we
that's what I
That's a possibility.
So you had a belief with what you're dealing with.
So
it
the other
is
thing is,
uncertainty.
you gotta sort of have an idea about your epitopes, right?
Yeah.
And I would tell you that majority of our snakes, now let's say it was, even if you get somebody that comes in with neurologic, and we say, hey, this is not one of our rattlesnakes, right? And what I have seen, at least in my practice, that you give them enough antivenom, you cover many of those epitopes. And they do so. Crowfab is not built for cobras. Have I seen a good effect? Yes. And that's why now there's a move about what they call an international antivenom or uniform antivenom. Because lots of these epitopes reoccur. And, you know, who was it that put Brian Fry's study? Brian Fry studied, the good part of his study, not his human touch, but the good part of the study is that he has shown that venom and reoccurrence of venom in various species has to do with the strategy that's common. So those epitopes that work in terms of a biological warfare against another species tend to reoccur. Scorpions utilize it, spiders utilize it, snakes utilize it, you know, marine, they utilize it. So sometimes you have to give massive amounts, and it does work. I know what she says, but our experience is totally opposite of that.
I'd not agree with that, I'm sorry.
It's
But
okay.
because, you know, if it is not working, either prove that there is venom in the blood, right? If you can't, then it becomes very difficult. Then the only way which I think is, if you don't have an antidote for a poison, you do an exchange. We do that for malaria. We did it, we've done it for severe complicated malaria, very high parasitemia. The patient is going down, you just take out the blood and give him
fresh blood.
Fresh blood. You don't only take out the parasite, you also take out the cytokines and the inflammatory mediators, which are causing majority of the damage.
But I wonder in her case, maybe if they started early on the bolus and then in the maintenance of fusion, he would have not deteriorated, because when they started again the infusion, he improved for a short time.
So
So
that's
this means that, I don't know.
But how?
So I would
Apparently
tell you-
not much.
It
No,
was-
because I'm the only one in the US that usually uses an infusion. As a matter of fact, we're presenting at Venom, we had over 45 cases of continuous infusion, and we show effect, but it has a significant effect. And what I use it, and I'll be honest with you, is there are many times that even toxicologists want to bolus. I say, no, let's give an infusion over. And what it does is it also mitigates the venom effects of the toxicologist's extra activity.
So we don't, as you know, in general, the antivenom that we are dealing with, we don't give it as bolus. We give it an infusion over 1 hour.
Yeah,
So that's
we
usually
just give it an infusion over 1 hour.
But we just
Well,
extended
that's what
the
we call a
infusion.
bolus.
But we just extended the
Right.
infusion. But the problem is that when we recommended the infusion, the treating physician in the other facility, they added the blood products during that period.
Oh.
And then we tested the coagulation. So we were not sure it's because of the infusion or it's because of the
Do they
blood
give any
products.
antibiotics too?
They give him antibiotics, yes.
They give them everything.
Antibiotics.
Thank you very, very much.
That's very good.
Can I have, if you don't mind, can I have a picture, all of us?
Welcome to Istanbul. Please introduce yourself and what do you think about Congress?
It's nice to be here. My name's Hannah. I'm working with Integral Global, and I'm happy to be at the conference. It's going very well. Lots of really important information.
How do you say about Turkey foods or Istanbul?
Well, I like sweets, and so the Turkish sweets are faring me well.
Okay.
Yeah, I'm enjoying the food. It's wonderful.
Thank you very much.
Yeah.
Welcome again.
Thank you.
Hello, my name is Nabil Ahmed. I'm the director for Integral Global, one of the participants for this conference, and this is my 5th time in Istanbul, and I always like coming to Istanbul. It's a beautiful city.
Istanbul.
Yes, I love Istanbul. I love the food, especially the kebab.
Thanks. We love it too.
Yeah.
Welcome again.
Thank you very much.
Hi, I'm Mazda Shirazi. I'm the medical director of Arizona Poison and Drug Information Center. This is my 2nd time being involved with your physician group, the emergency physician group. Last time I was in Trabzon. And it's actually lovely to be in Istanbul. And I'm partly Turk and partly Persian, so I always like to come back to the region that my heritage is
We are
from.
waiting for you every time. Thank you very much.
Okay.
Okay, Mr. Charles McKay, welcome to Turkey. Can you introduce yourself to us?
Sure. Charles McKay, I'm a medical toxicologist, physician toxicologist in Connecticut, eastern part of the United States, and immediate past president of the American College of Medical Toxicology, which is a national organization of physician toxicologists.
Thank you very much for welcome to you also again. Did you like the program of the conference? How do you find our preparation? Can you make some comments for us?
Oh, sure. No, it's been very enjoyable thus far. It's always amazing to see how a group of people will come together from different areas to try and provide some information and training across common areas of concern. And certainly EPAT and Menatox here, the board and all of the participants have been doing a great job running really 3 simultaneous tracks today and 2 tracks in the next couple of days. It's always a challenge, but it seems to be going very well.
Thank you very much.
Today we are with Lucy Schiffer-Bain, and first of all, would you like to introduce yourself to us?
Certainly. So I'm Lucy Schiffer-Bain and I'm from the New Zealand National Poison Centre, and I'm also from the Toxins Poisons Information Database.
Okay, what do you think about this Congress?
It's fantastic, just having the opportunity to be able to participate in a Congress which helps strengthen the capacity in the region is just a wonderful opportunity.
Okay, thank you.
9. Menatox Klinik Toksikoloji Konferansı'nda İstanbul'da Başar hocamızla birlikteyiz. Hocam yurt dışından, Amerika'dan, dünyanın birçok yerinden 70 tane yabancı katılımlıyla İngilizce ana dilinde bir konferans düzenliyorsunuz. Ne hissediyorsunuz? Nasıl gidiyor konferans? Katılımcılar katılımdan memnun musunuz? Düşüncelerinizi alalım.
Yani bu Menatox'a ev sahipliği yapmamız gerçekten bizim için çok önemli bir dönüm noktalarından biri. Çünkü toksikoloji ülkemizde şu anda emekleme dönemini geçip yavaş yavaş yürümeye başlayacak bir branş gibi görünüyor. Şu anda yaptığımız bu kongrede aslında ülkemizdeki en büyük uluslararası kongrelerden bir tanesi. Yani 70 tane yabancı konuşmacının sizin de bahsettiğiniz gibi ki bunların birçoğu okyanus ötesinden geliyor. Ve ülkelerinde de dünyada da saygın isimler, bunları bir araya getirmek, İstanbul'da buluşturmak ve İstanbul'u toksikolojinin bir gündemi olarak oluşturmak bizim için çok önemli adımlar. Gerçekten bu yüzden hem mutluyuz hem gururluyuz. Ama bir taraftan da bu konuda gerçekten bütün asistanlarımızın, bütün uzmanlarımızın daha çok ilgi göstermesini, toksikolojiyi takip etmesini bekliyoruz. Çünkü toksikoloji acil tıbbın ana branşlarından biri olmaya gidiyor. Ana branş derken yani ana altyapılarından biri olacak. Çünkü hastalar zaten toksikoloji hastaları öncelikle acil servislere başvuruyorlar. Onların tanısı ve tedavileri de acil serviste devam ediyor. Bu yüzden acil tıp konusunda toksikoloji giderek ilerleyen süreçte daha önemli bir pozisyona gelecek. Yani toksikoloji acil tıbbın çok önemli bir bölümü olacak. Burada baktığımızda Amerika'dan, Avrupa'dan ve sadece bu coğrafyadan değil, aynı zamanda mesela Uzak Doğu'dan gelen misafirlerimiz var. Bunların da çok ciddi çalışmaları var. Bunlar da gönlünü toksikolojiye vermiş çok önemli bilim adamları. Çok güzel noktalara vurgular yapıyorlar. İnteraktif çok iyi geçiyor. Yani bu konuda duyarlılığı artırmak, farkındalığı artırmak için önemli bir mihenk taşı olacak diye düşünüyorum. Acil tıp açısından da şöyle düşünmemiz lazım. Acil tıp açısından. Yıllardır beklediğimiz adımlar bunlar. Çünkü birçok acil tıpçı aynı zamanda üst ihtisas yapmak istiyor. Üst ihtisasın en önemli maddelerinden biri toksikoloji. Bununla ilgili bazı gelişmeler oldu dönem içinde. Bu daha ileriye taşınacak. Öyle görünüyor.
Çok teşekkür ediyoruz hocam. Ülkemizde böyle bir konferans düzenlediğiniz için.
Neredeydi?
Tut elimi.
Geç kaldım. Gidiyorum ben.
Gidemezsin. Daha ıslanılacak yağmurlar, söylenecek şarkılar, seyredilecek yıldızlar var.
Vardı. Neden gelmedin?
Geldim ya. Tut işte elimi.
İstiyorum. Ama gücüm kalmadı. Tükendim seni beklerken.
Pes etme. Uzat hadi. Uzat elini.
Neden geciktin? Çok bekledim seni. Aramadılar mı?
Aramazlar mı? Hemen aradılar. Ama hemen ulaşamadılar. Saçma sapan sebeplerden dolayı o kadar çok insan aramıştı ki. Çok geç ulaştı aramaları bana. Hadi, uzat elini. Lütfen.
Biraz daha erken gelebilseydin.
İstedim. Çok istedim hem de. Ama trafik yol vermedi kimse. Saat çekip beklemeyi beceremedi kimse.
O kadar ihtiyacım vardı ki sana.
Biliyorum. Ama geldim işte en sonunda. Çok uğraştım senin yanına gelebilmek için. Hadi. Sen de uğraş biraz. Hadi uzat elini.
Uğraşmadım mı sanıyorsun? Buraya geldiğinde bile görmedin beni onca zaman.
Aşamadım ki o meraklı kalabalığı. İzin vermediler sana ulaşmama. Sanki o telefon aramasında, sanki o yolda ve burada istemediler sana ulaşmamı.
Hiç anlamıyorum. Işıkları söndürüyor birileri sanki.
Sakın ha! Onlara rağmen tutmalısın elini. Hadi bir gayret. Ben inanıyorum sana.
Yapabilir miyim sence?
Yapabilirsin. Yapmalısın. Bak ben senin yanındayım. Hadi tut elimi. Hadi kardeşim hadi. Hadi yapabilirsin. Hadi kurban olayım hadi. Bırakma. Evet. Aynen böyle. Uzat. Buradayım ben. Hadi. Tut elimi. Hadi. Hadi kardeşim. Hadi. Hadi yapabilirsin hadi. Nabız geldi. Hadi çabuk çabuk çabuk.
Ne oluyor şimdi?
Elimi bırakmazsan ben seni buradan çıkaracağım.
Uzun sürecek mi?
Evet.
Olsun. Ben bırakmam elini yolda.
Alo hocam. Hasta travma hastası, mavi kod getiriyoruz. Ares hasta döndü. 5 dakika CPR yaptık. Nabız var. Tansiyonu alıyoruz. Şuuru kapalı. Tamam. Acilin önünde kalabalık olacak. Hastalar, hasta yakınları, meraklı bir kalabalık. Ailenden haber alıp gelenler. Onları aşarken de tut elimi. Bırakma.
Görmedin mi diyorsun? Ya olacak şey mi? Burada ne yapıyorsun sen o zaman?
Üzgün ve sinirliler. Kabul edemiyorlar olanı biteni.
Annem doktor! Doktor kızım yaşıyor mu? Ne olur?
Bir suçlu arıyorlar. Acılarını çıkartacakları birileri.
Hanımefendi! Hanımefendi alır mısın?
Burada bulamazlar ki.
Doktor kızım yaşıyor mu? Ne olur söyleyin.
Buluyorlar. Hasta bakıcıları, hemşireleri, doktorlara. Kimi bulurlarsa, kime güçleri yeterse.
Ama siz bana yardım ediyorsunuz. Elimi tutuyorsunuz benim.
Sen sakın elini bırakma. Biz onlara rağmen başaracağız. Sen yeter ki tut elini.
Ya niye bir şey söylemiyorsunuz Allah aşkına? Niye konuşma? Öldüm çocuk.
Kızınız
Çocuk,
yaşıyor. Ambulansla biz gerekli müdahaleyi yaptık. Kızınız iyi olacak inşallah. Tamam mı? Sakin ol.
Çok teşekkürler doktor bey. Başarılı bir müdahale yapmışsınız. Sayenizde hastayı hayatta tutabileceğiz.
Sağ ol.
Merak etmeyin. Kızınız daha iyi olacak. Acil tıp uzmanları gerekli müdahaleleri başarıyla gerçekleştireceklerdir. Bize güvenin, umutlu olun. Ama en önemlisi sakin olun. Bizim yanımızda bizimle birlikte yer almanız gerekiyor. Eyvallah, sağ ol doktor. Sağ ol.
Ben onlarla hayata tutundum. Hayatla ölüm arasındaki o ince çizgide fedakarca çalışıyorlar. Sağlık ordusunun isimsiz kahramanları onlar. Acil tıp uzmanları ve çalışanları. Beni siz hayata bağladınız. Kendim ve sevdiklerim adına hepinize minnettarım. Ben şanslıydım. Ama sizin anneniz, babanız, eşiniz, çoluğunuz, çocuğunuz, akrabanız, arkadaşınız bu kadar şanslı olmayabilir. Ne olursunuz unutmayın. Size rağmen olmaz. Ama sizinle iyi olur.
Acil Tıp Uzmanları Derneği olarak acillerimiz için, doktorlarımız için, hastalarımız için çalışmaya devam edeceğiz.
Acil tıp uzmanlarına ve sağlık çalışanlarına yöneltilen şiddet hastalara, hasta yakınlarına, topluma ve tüm insanlığa yöneltilen şiddettir.
Ne olursunuz unutmayın. Size rağmen olmaz. Ama sizinle iyi olur.
Takan kimse yok değil mi? Dear distinguished, you're welcome to the second section dememe gerek yok ama hadi demiş oldum nezaketen. Şimdi arkadaşlarım bu ikinci günün ikinci oturumunda afetler ve yerel yönetimler diye çok önemli bir başlığımız var. Çok önemli, ben de dahil, ben önemli miyim bilemiyorum ama 2 tane önemli konuşmacımız var. Tabii bütün deneyimleri ve bilgileriyle bize burada büyük bir katkı verecekler. Hatta kayıt bile alabilirsiniz demek isterim. Çünkü bunları bir daha bulamayabiliriz bu bilgileri. Ben hemen vakit geçirmeden toplantıyı açmak istiyorum izninizle. İlk konuşmacı da benim. Sizleri Allah kahretsin deyip sıkıntıya sokmayacak bir profesyonellikte yürütmek istiyorum. Çünkü hem yönetici hem sunucu olmanın avantajları olduğu gibi dezavantajları da var. Yani bu profesyonelliğimi göstermeye çalışıyorum. Ekranda görmüyorum kendimi. Yönetiliyordu ama nereden geliyor şey? PowerPoint'i yollamıştık. Ben bilemedim. Lütfen yardımcı olur musunuz? Oturacağım. Ya oraya gideceğim. Ha, tamam. Teşekkür ederim. Hocam siz 15'te öksürün. Tamam mı?
15'te tamam.
Kamu yönetimi bölümünde eğitim almış bir öğretim üyesiyim. Profesörüm 96'dan beri ve girişimci kadınım. girişimciliğimle bağlantılı olarak bu konuyla ne alakası var? 9 Eylül Üniversitesi'nde afet yönetimi yüksek lisans ve doktora programını kurduk. Hatta öğrencilerimin çoğu burada. Bugün burada ders yapıyoruz. Aslında İzmir'de olsaydık sabah dersimiz vardı. Ama buraya geldiler. Hem sizlerle tanışmak için hem de dersimizi burada yapacağız. Aynı zamanda kamu yönetimi bölüm başkanıyım. Dağlık alanların sürdürülebilirliği ve yönetişimi diye de bir dernek kurdum. Tabii ki iklim değişiklikleriyle bağlantılı olarak Türkiye'nin %80'i dağken, böyle yerel yönetimlerinde birçoğu dağlık alan belediyesi iken ve hala inşallah içimizde belediyeden arkadaşlarımız vardır. Bir dağlık alan belediyeler birliği diye bir birlik kurulması ihtiyacı ortadayken ve kurulmamışken bugün bir geniş bakış açısı içerisinde ben yerel yönetimlerden anlayan, işte 40 yıldır bu dersleri veren biri olarak, neredeyse 40 yıl, sizlerle bazı konuları paylaşmak istiyorum. Görülen o ki afet bizim rutin hayatımızı etkilemekte ve dolayısıyla kayıplar ortaya çıkmakta. O zaman aslında bu kayıpların büyük bir kısmı toplumun bizzat kendisinden kaynaklanmakta. Ama kamu yönetiminin hatalarından doğan sorunlar büyük bir kısmı. Dolayısıyla sabahleyin bir mukavemetten bahsedildi. Ben bekledim mukavemetli toplum densin diye, Resilient Society diye. Evet, burada önemli olan aynı zamanda bu anlatıldığı gibi sabah kırılmadan tekrar eski haline gelen toplumu biz nasıl kuracağız? Burada tabii ki sağlıklı ve dengeli çevrede yaşamasını sağlama noktasında idarenin merkezi yönetimi ve yerel yönetimlerin önemli sorumlulukları var. Geçenlerde Kayseri'de tsunami zerrin toprak deyince geliyor. Ben bu bilgiyi aktarmıştım. O zaman henüz tsunami olmamıştı. Birleşmiş Milletler Afet Riskleri Azaltılması Dairesi'nin çalışmalarına göre Türkiye'de deprem, çatışma, tsunami %30, sel, kuraklık riski var dedim. Hoca dediler uçtu galiba ama oldu. Esasen 1688'de İzmir'de de oldu. Haritadan silinen yer sarsıntısıyla 7.3 ve üstünde ve İzmir'de şu anda yok, Yenikale mevkiinde kale sulara gömülmüş. 19. yüzyılda İzmir'de doğal afetler diye bir kitapta bunu görüyoruz. Bunu ben görünce, bilim zaten biriktirilmiş bilgi demek. Depremde gösterdiler kıpkırmızı bir Türkiye. Fay hattı oradaysa, su şuradaysa, deprem varsa tsunami de olabilir dedik. Yani bunu niye söylüyoruz? Biz birçok afet tipiyle karşı karşıyayız. Ve bununla ilgili de toplumun, yerel toplulukların mukavemetini arttırmak durumundayız. Tabii ki teknoloji elimizde var ve bilgiyle beraber askeri güç, profesyonellik ve diğer kurumsal destekle beraber bazı kaynakları kullanmak durumundayız. Bunun içerisinde endüstrileşme ve rekabetçi kapitalizm bizim çalışma alanımızı zorlaştırıyor afet açısından, bazen de kolaylaştırıyor. Onun için buna fazla girmeyeceğim ama bunların her biri biraz önce söylendi, güvenlikle ilgili. Örneğin yoksulluğu çalışıyorsun, kentlerde yoksulluk. Bu afetle ilgili ekonomik güvenlik. Gıdayla ilgili bir şeyler çalışıyorsun, gıda güvenliği. Bunların içinde bu Birleşmiş Milletler raporuna olan bir tablo. Yıldızları ben ekledim, terör var. Yani laboratuvarda oluşturulmuş da olabilir sağlıkla ilgili konular. Ve içimizde herhangi biri de, yani kamu yönetimi, o kaotik ortamda vatandaşın ya da yerleşik halkın, vatandaş olur olmaz, yabancı da olabilir, ıstırap çekmemesini sağlayacak hamleler yaparken artık bir realite var. Konuşmalarda da gördünüz, terör de ister yurt içinden gelsin, ister yurt dışından gelsin, hatta orada doğsun. Birçok Avrupa'da da görüyoruz. Virüs gibi o ülkeden bu ülkeye sıçrıyor ve kendi vatandaşı. Dolayısıyla biz artık idareciler olarak bunu da düşünmek zorundayız. Çevresel bozulmanın sağladığı doğal afetler, yoksa bizzat çevre kirliliği doğal afet değil biliyorsunuz ama afet kirliliği dehşetli bir kirliliğe yol açabilir. Bu arada fiziki şiddet, suç, aile içi şiddet, mutsuz toplum, kişi güvenliği açısından sorun alanı ve kaotik ortamda sorun olabilir. Toplum güvenliği açısından etnik farklılıklar, dini farklılıklar, kimlik tabanlı gerginlikler ve terörizm bunun içinde sorun alanı olabilir. Politik güvenlik, insan hakları ihlalleri sorun olabilir. Bizde şöyle bir ifade var kamu yönetiminde. O da nedir? Hizmetlerde etkinlik ve demokratik katılımın birlikte sağlanması. Şimdi ben bozulma olduğunu biliyoruz. Bunu tekrarlamak gerekmiyor ama kurumsal sürdürülebilir başarının yönetiminde biraz önce söylediğim inançlar, değerler, kişisel özellikler, çevresel faktörler, kurumsal özellikler, devlet boyutuna çıkan özellikler ve mevzuat düzenlemeleri, kurumsal stratejiler, amaçlanan çıktılar, kalıcı etkileri, kurumsal sadakat, kurumsal imaj, devletin imajı, vatandaşın sadakati gibi kurallar bütünü içinde yönetim hareket ediyor. Yönetim dediğinde planlamadan kontrole kadar olan süreç. Bunun içinde planlama, personel alma, raporlama ki burada çok eksiğimiz var raporlamada, bütçeleme, denetim, bütün bu konular kamu yönetiminin klasik temel konuları. Ve yine bunun içerisinde personelin verimliliği, merkeziyetçi yaklaşım, hiyerarşik denetim veya geniş tabanlı denetim, yürütmenin denetimi, siyasetle ve yönetimin ayrılması gibi kamu yönetiminin klasik duruşları var. Ben bu sunumumda şunu demeye çalışıyorum. Kamu yönetiminin planlamadan kontrole kadar olan süreci içerisindeki tüm aşamalarında biz katılımı istiyoruz. Ama klasik yönetim afet yönetiminin temelinde yer alıyor. Çünkü nihai olarak idari ve siyasi ve cezai sorumluluğu olan birine dönüp bakıyoruz. Çünkü biraz önce saydığım çok farklı güvenlik konuları var, ihtisaslaşmış konular ve bunlar kamu yönetiminin üzerine gitmesi gereken özellikli konular. Dolayısıyla danışma mekanizmaları evet, planlama sırasında, afet öncesi, sonrasında sivil örgütlerin destekleri gibi konular son derece önemli ama bunların her birinin tekrar sıkı bir güvenlik kontrolü içerisinde yapılması gerekiyor. Yansıdaki süreç tablosu bana ait. Afet Yönetimi Anabilim Dalı sayfasında var. Kitaplarımız da var orada 2 tane indirebilirsiniz rahatlıkla. Ve burada bütünleşik afet yönetiminde riskin ve krizin birlikte artık düzenlendiğini görüyoruz. Dolayısıyla yerel yönetimlerin mevzuat düzenlemelerine baktığımızda hem öncesi planlama, arazi planlaması açısından baktığınızda hem de sonrasının başlangıçta riskin olasılığını saptama hareketlerini risk analizlerinde görüyoruz krizin. Dolayısıyla krizle ilgili olarak da şu kavun içi de gördüğümüz alan yine Türkçe literatürde benim ilk defa vurguladığım hızlı chat kavramı var. Yani chat atlatmak ustası olan bir ülkenin chatleri atlata afet riskleriyle karşılaşacağını söylüyorum. Bunun için iyi bir chat planlaması veya stratejik çevresel değerlendirme afet yönetimi açısından hazırlık çalışmalarının iyi yapılması anlamına gelir. Dolayısıyla chat ve hızlı chat uygulamalarını yine internetten adımla bulabilirsiniz. Şimdi vaktim kısıtlı fakat bu basılacak. Sadece şunu demeye çalışıyorum. Evet, kamu yönetiminde biz demokrasi, yönetişim, katılım, ben yerel gündem 21 stratejisyeniyim. Onun için Allah kahretsin yönetişim diyen öğretim üyelerinden ayrılıyorum. Yönetişim çok önemli. Kamu, özel, sivil, ortaklı, katılım ama afet yönetimi için klasik yönetim süreçleri devrededir. Biraz önce söylediğim gibi kimse danışıldığı için cezai sorumluluk üstlenmek istemeyecektir. Nihai karar alıcı kimdir bu? AFAD İl Müdürü, yürütme organı, merkezde, il bütününde vali ve merkezi düzeyde de AFAD Başkanı ve Başbakan'a giden oklar şimdi nedir? Nokta nokta iken direkt çizgi olarak yani doğrudan sorumlu olarak Cumhurbaşkanı'na doğru yönelmiş oldu sorumluluk itibarıyla. Dolayısıyla kamu yönetiminin nihai karar alıcıları rolünde olan kişilerin bu izleme, değerlendirme, denetleme konularında diğer faktörler biraz önce yansıda görüldüğü gibi kurumsal sadakat, liyakat ilkesi vesaire olmak üzere dikkate almaları gerekiyor. Bunun için de uluslararası modeller de önemli. Şunu söylemeden geçemeyeceğim. Geçen yılda AFAD bir toplantı yaptı Ankara'da ve o konuşuldu. Bütün bakanlıkların strateji planlama çalışmasında yer alması gerekiyor. Hala değişiklik olmadı. Olması gereken diğer bakanlıklar kadar önemli olan Bilim Teknoloji Bakanlığı, Çalışma Bakanlığı ve Gençlik ve ilgili bakanlık. Gençlik, spor, top, ot değil. Gençlik ondan istifade edeceğimiz insan kaynağı. Bilim de öyle. Çalışma Bakanlığı açısından da öyle. Dolayısıyla bu sistemin bütün bakanlıkları içine alacak şekilde planlanması gerekiyor. İster il genel idaresi kanununa bakalım. Bucaklar kalkmış olmakla beraber kanunda duruyor. Her günde yeni bir idari düzenleme olabilir. Anayasa korumuyor çünkü idari yapıları. İlla bu yapı olacak demiyor. İl diyor, belediye veya köy diyor. Onun için bütün yapılar anayasaya göre çok korumalı değil. Belediye kanununda görüyorsunuz yansıda da acil durum planlarının hazırlanmasıyla ilgili il ölçeğinde işbirliğine yönelik öncesi ile ilgili önemli düzenlemeler var. Belediye zabıtasının, itfaiye acil durum planlamasının çok önemli görevleri var. Hazırlıkla ilgili plan yapar, ekip donanımı hazırlar diye. Mahalle yönetiminde mahalle çok önemli. Mahalle belediye yönetimlerinde vardır. Dolayısıyla belde sakinlerinin herkesin yani mahalle müşterek nitelikteki ihtiyaçlarını karşılamak üzere kurulan bu modelde halkın yerel mahalledeki herkesin yabancı olabilir, vatandaş olabilir, herkesin burada katkı sağlanabilecek hukuki düzenleme var. Büyükşehir şu anda büyük şehirlerimiz 30 tane ama giderek artacağı düşünülmekte ve büyükşehir belediyelerinin de gördüğünüz gibi gayri müesseselerle ilgili konutlarla ilgili belediyelerin de öyle 5393 veya 5216 çerçevesinde gerçekten öncesi yardımların dağıtılması vesairesinde sonrasında valinin de afet sırasında kontrolü altında çok geniş bir görev ağı var. Peki o zaman AFAD İl Müdürü ve Vali bu görevlerini ne kadar yerine getiriyor? Şunu demeye çalışıyorum. Yani biraz önce söylemiştik hazırlık çalışmalarına ilişkin olarak belediyelerin sahip olduğu bu görevi sorumlulukları çerçevesinde AFAD sisteminin hem il hem merkezi düzeyde bir de GAMER kuruldu biliyorsunuz 2017. Şu anda ne kadar faaliyetleri var işlevsel bilmiyoruz ama yönetişim formatında kurulan ve son derece önemli güvenlik odaklı bir sistem içerisinde yer alan bir birim. Şunu demeye çalışıyorum. Belediyelerimizin görevlerini kanunda yazılan görevlerini ne kadar afetle bağlantılı yerine getirip getirmediği bugüne kadar sorgulanmış değildir. Sorgulanmasının zamanı gelmiştir, geçiyor bile. Dolayısıyla merkezi yönetimin taşra teşkilatının başındaki valinin çok yönlü görevleri içerisinde afet ve acil durum görevleri de var. Hizmette aksama ile ilgili de görevleri var. Dolayısıyla bir an evvel görevlerin yerine getirilip getirilmediği ve düzeyleriyle ilgili sorgulama formlarının oluşturulması gerekiyor. Benim belediyelerde öğrencim var. Diyorum ki öğrettiğimiz bilgileri ne kadar uyguluyorsunuz? Bize hiçbir şey sorulmuyor diyor. Tabii ki idare kendine ait bir takım görevleri idare ederken yerel yönetimleri kastediyorum. Yapıyor ama teyidi gerekiyor. Dolayısıyla bunu bir eksiklik olarak ortaya koymuş oluyorum. Dolayısıyla bir bu boyutu var. Diğer bir boyutu da kalifiye personel olma. AFAD İl Müdürü kalifiye, vali öyle kurallar gereğince ama AFAD Başkanı'nın kariyerle ilgili konulardaki yasal olmazsa olmazları kaldırılmıştır hukuki düzenlemeden. Bunu bir eksiklik olması açısından büyük bir biraz önce söyledik güvenlik açığı olarak görüyorum. O nedenle özellikle güvenlikle yani adı güvenlik afet dediğin güvenlik. Güvenlikle ilgili birimlerin kariyerden gelen tecrübeli, bilgili kişiler olduğunu biliyoruz. Onu yönetenlerin de öyle olması gerektiğinin mevzuatta görünür olması son derece önemli bir konu. O kadar çok yapılacak iş var ki kamu yönetimi açısından haberleşme ağları, can kaybının en aza indirilmesi, ölüleri, yaralıların yakıntı altından çıkarılması, tıbbi yardımlar ki bu toplantının konusu. Dolayısıyla her yapılan iş yönetimin bir parçasıdır. Bunu kabul etmek gerekir. Her yapılan iş, bu sırada elde edilen tecrübe yönetimin bir parçasıdır. Bu nedenle bu sistemlerin doğru kullanılması, tehditlerin saptanması açısından bizim öğrenilmiş derslerimizin yazılı hale getirildiği dokümanlar oluşturmamız gerekiyor. Burada olmamalı. Sen orada olmayabilirsin. Bazen hizmet içi eğitimlere gidiyoruz. Diyor ki memurlar, personel, müdürlerin işi vardı, ben geldim. İyi yaptınız diyoruz biz de. Çünkü müdür belki o sırada orada olmayabilir ama sen orada olacaksın. Bununla ne demek istiyorum? Yani yönetim ağları içerisinde herkese ister yönetici olsun ister müdür veya yönetimin çeşitli aşamalarındaki personel. Dolayısıyla bunların her birinin, sizin her birinizin öğrendiği konular ve bunları aktarmanız son derece önemli. Afetlerde erken uyarıdan bahsedildi, son derece önemli ama tabiat bazen aldatıyor ve biz beklentilerimizin karşılığını alamıyoruz. Yağmurun geleceğini bilsek de fırtına ile geldiğinde şiddeti değişiyor ve zayıflıyor veya artıyor. Dolayısıyla şundan vazgeçelim. Bir klasik öğretimimize sıkı sıkı sarılmaktan vazgeçip yeniliklere açık olarak bilgimizi afet yönetimi itibarıyla nasıl güncelleyebiliriz ve her disiplinde bunu nasıl yapabiliriz? Bunu gerçekten son derece önemli. Bir de bilgilerimizin raf ömrüne bakmak gerekiyor. Öğrendiklerimizin de uygulandığını görmek gerekiyor. İlk konuşmada yansıda vardı. Mezarlıkları gösterdiler. Toplantı mekanları, afet sonrası toplanma mekanları diye. Birçoğumuz bilmiyoruz toplantı mekanlarını. Çoğu da bir şekilde kamu yönetiminin bizzat eliyle değiştirilmiş olduğu için gerçekten bizim işimizi doğru yapma gerektiğinde işte klasik yönetimin öğretisinde bu var. Öyle değil böyle diyebilme gücünü kendimizde görmemiz son derece önemli. Biz eskiden öğrencimize bürokrasiyi anlatırken büroların egemenliği olumsuz yanlarını anlatıyorduk. Şimdi keşke büro olsa, kresi olsa egemenlik ve bürokratlar direnebilse diyoruz. Onun için kamu yönetiminde bilimin desteklediği, tecrübenin istemediği konuların mutlaka kurumsal sadakat anayasada da vardır, her yerde vardır. Devlet Memurları Kanunu'nda da vardır. Dolayısıyla misyonumuza ve vizyonumuza uygun şekilde güvenliğin bütün boyutlarında hızla kendimizi yenilememiz ve belli bir ekip çalışması içerisinde olabilmemiz, zihnimizi buna hazırlamamız ve teknolojinin bütün imkanlarından istifade etmemiz son derece önemli. Nihai olarak bu bizim Yerel Gündem 21 sloganımız. Yani 21. yüzyılın gündemi, bir tanesi de maalesef afetler, yeni bir bilinç, kentine sahip çıkma, yeni bir anlayış, çözümde ortaklık, yeni bir davranış, aktif katılım, hepimizin takip etmesi gereken temel prensipler diye düşünüyorum. Madem ki klasik yönetimde yönetici çok önemli, onun için yöneticinin bilgili ve kariyer sahibi olması, etrafındaki uzmanların da yine gerçekten uzman nitelikli kişiler olması, çok yönlü olması ve uzman sendromuna da bir taraftan kapılmaması gerektiğini, çok tehlikeli olduğunu söyleyerek sözlerimi tamamlıyorum. Tabii ki sorularınızı açayım. İlginize teşekkür ederim. Olarak hazırlanmıştır. Uygulamada bir kadın ve bir erkek el sıkışıyor, yoktur. Bunu biz hazırladık. Böyle olması gerekir. Toplum kadını ve erkeğiyle bir bütündür. Dolayısıyla sevgili arkadaşlar, ben yerel yönetim mevzuatı ve bağlantıları üzerinde bu kısa zamanda söylemeye çalıştım ama yazılı olarak da erişebilirsiniz. Kitapçık basılacak. İkinci konuşmacımız İsmail Hakkı Turunç Bey. Kendisi özelliklerini nasıl istiyorsa ve konuşmasını kendi takdim etsin. En iyi takdim eden kendisidir diye. Buyurun efendim.
Kıymetli konuklar, öncelikle hepinize saygılar sunuyorum. Bu organizasyona katıldığınız için de ayrıca teşekkür ediyorum duyarlılığınızdan dolayı. Hocama çok teşekkür ediyorum. Zaten gerek hocamın, gerek Gökhan Bey'in ve şahsımın anlatacağı, paylaşacağı hususlar hep ortak hususlar olacaktır. Dolayısıyla hocamın çok güzel hazırlamış olduğu ve sunmuş olduğu ve bilimsel bir tabana da tutturduğu, her birimize ışık tutacak bu değerlendirmesi ve sunum için de kendisine teşekkür ediyorum. Ben Kızılay Genel Başkan Vekili olarak hem Kızılaycı kimliğimle hem de İstanbul Büyükşehir Belediye Başkan Danışmanı kimliğimle sizlere takribi 20 yıla yakındır afetlere yönelik operasyonun bizzat içinde olan birisi olarak sizinle bilgilerimi ve tecrübelerimi ve temennilerimi paylaşmak istiyorum. İstanbul özeliyle alakalı Gökhan Bey gerçekten bizim çok değerli bir arkadaşımız. Kendisini her zaman zevkle dinliyoruz. İstanbul'a yönelik yaptığı çalışmaları yakinen biliyorum. İstanbul özelindeki rakamlarla alakalı eminim kendisi yapılan çalışmalarla alakalı çok özel bilgiler bize sunacak. Ben biraz dünya ölçeğinden bahsetmek istiyorum. Yaşanan sıkıntılardan bahsetmek istiyorum. Ya dünyanın hangi ülkesidir bilmiyorum. Yani Japonya'ya gitmişim bundan 5 sene kadar önce. Sydney'de bir tsunami sonrası oluşan bir riskten sonra yardımcı olmaya gittik. Belki Japonya'nın da ihtiyacı var mıydı yok muydu o tartışılır ama Japonlar biliyorsunuz Türkiye'nin her zaman afetlerde ve diğer konularda da bir gönül bağımız ve duygusal bağımız olduğumuz bir devlet ve ülke. Biz de tabii insani noktada sıkıntılarında yanında olmamız gerekirdir diye hem Kızılay kimliğimle hem İstanbul Büyükşehir Belediye Başkan Danışmanı kimliğiyle oraya gitmiştik. Gittiğimizde gördüğümüz manzara gerçekten bir hazırlık içerisindeler ama ne kadar gelişmiş ülke olursanız olun hesabınızı bir yere göre yapıyorsunuz. Belli bir standardı var. Hatta standardın yani riskin en doruk noktası, en tepe noktası neyse ona göre altyapınızı yapıyorsunuz. Ona göre tsunami'ye yönelik önlemler alıyorsunuz. Hatırlayabildiğim kadarıyla siz de yakından takip etmiştirseniz yani sahilde bir nükleer santralın Sydney denilen bir şehirdeydi. 6 metrelik tsunami dalga kırıcı yapmalarına rağmen 7-7,5 metrelik dalgalar geldi. Yine o nükleer santralı tsunami bastı ve çok ciddi manada ülkede bir risk oluştu. Tecrübeleriyle, bilgileriyle çözdüler ama yaşadılar sıkıntı. Şimdi bir tarafta çok gelişmiş ülkeler, hazırlıklı ülkeler, depremin her türlüsünü, afet, yanardağ patlaması, aşırı yağışlar, heyelanlar gibi, nükleer santrallerle riskler gibi her noktada hazırlığını yapan ülke de olsanız yine hesabınızın üzerinde farklı bir tabloyla karşılaştığınızda fırtınalar gibi ABD işte görüyorsunuz son birkaç aydır hatta birkaç yıldır yaşadığı sıkıntılarla birçok manada aşamıyor sıkıntısını ve problemini. Belki de eksikliği kimse görülmesin diye uluslararası yardım çağrısı falan da açmıyor. Yani biz oraya da yardıma giderdik. Gerek Kızılay olarak gerek Türkiye'deki kurumlarımız olarak ama uluslararası yardım çağrısı açmıyor. Gerçekten hakikaten doğal afetlerin boyutu sizin hesabınızın üzerinde gelişiyorsa bunu aşmanız mümkün değil. Burada aslında ülke yöneticilerini falan da yani bir nevi eğer hazırlığı yoksa çok iyi niyetli olursunuz, hazırlık yaparsınız ama sizin hesap ettiğiniz yani günde saatte metrekareye 80 kilometre düşecek diye hesabınızı yaparsınız ama 180 kilometre düştüğünüzde buna ne yapacaksınız? Yani sizi de aşan, yönetimsel olarak sizi de aşan, hazırlıklarınızı aşan bir tabloyla karşı karşıya kaldığınızda aman efendim şu şehirde neden bu noktada, şu ülkede bu noktada demek çok biraz insafsızlık olur diye düşünüyorum. Dolayısıyla iki gruba bölüyorum ben ülkeleri. Sizin de takdiriniz bu doğrultudadır diye düşünüyorum. Bir hakikaten istikrarlı bir ülke, ülkesinin gelişmişliğiyle, kalkınmasıyla alakalı ve her türlü risklere yönelik hazırlıklarını yapmış, bireysel olarak insanları afetin her şekline hazırlamış, ilk yardım eğitimlerini vermiş, bütün hazırlıklarını yapmış, kendi altyapısını oluşturmuş, müdahale ekiplerini oluşturmuş, çok bilinçli bir şekilde bir ülke düşünün. Ama diğer bazı ülkeler var ki kaç tane ülke sayabilirsiniz dünyada bu noktada hazırlığını yapmış olan. Her zaman risk yaşamış olmasına rağmen işte genellikle kıyı ülkeleri ve ada ülkeleri tsunami'den, aşırı yağışlardan veya çok şiddetli depremlerden etkileniyorlar. Kaç tane ülke bu noktada hazırlık yapmıştır? Ben dün 12 itibariyle Bangladeş'ten döndüm. Arakan'dan 800 bine yakın göç eden insanların bulunduğu kamp da değil aslında. Yani işte ormana sığınmış, çok ilkel bir vaziyette yani insanların da çok zor yaşayacağı ortamlarda 800 bin insanın yaşadığı bir bölgeye geçtim. Bangladeş'in zaten bu konuda çok ciddi sıkıntısı var. O sıkıntının üzerine bir de 800 bin kişi gelmiş ve bilgi ve tecrübeleri çok fazla ileri. Ben bir ülkeyi suçlamak, devleti, yöneticiyi suçlamak adına değil de realiteyi paylaşmak adına ifade ediyorum. Dolayısıyla 800 bin insan da yük gelmiş. Kendi ülkeleriyle alakalı zaten her yıl onlarca kez yaşadıkları muson yağmurlarından dolayı çok ciddi sıkıntılar ve altyapısını oluşturmayan bir ülke ve ekonomik olarak da çok iyi noktada değiller. Sanırım ülkenin iç siyasi meselesini sormadım, bilmiyorum. Siyasi istikrar var mı yok mu onu da bilmiyorum ama gördüğüm tablo gerçekten vahim. Biz Kızılay olarak ve dünyadaki sivil toplum kuruluşları olarak ülkelerin, ülke yöneticilerinin, devlet yöneticilerinin, kamu yöneticilerinin biraz önce hocamın ifade ettiği gibi müdürü çağırıyoruz bir toplantıya, müdür yardımcısı şef gelmiş, bilmem kim gelmiş. Ben küçümseme kastıyla söylemiyorum. Hiyerarşik yapı içerisinde devlet kurumlarına, kamu yönetiminde saygı duyuyorum ama müdürün bilmesi gereken bir konu, bir daire başkanının bilmesi gereken, bir genel müdürün, bir genel sekreterin bilmesi ve ehemmiyet göstermesi gereken bir konuda müdür gelmedi, şef geldi, şef gelmedi, ustabaşı geldiyle falan olmaz. Böyle bir mantık olmaz. Ne Türkiye'de bu noktada çok ciddi ama ben de yöneticiyim. Burada varsa benim de payım, yani ben kamudan, toplumdan özür diliyorum ama bu bir realite, bu bir gerçek. En üst noktada ilgilenmek zorundayız. En üst noktada takip etmek zorundayız. Böyle takip etmediğiniz takdirde duyarlı anlatıyorsunuz şefe, şef gidecek müdürüne anlatacak. Müdür bilmem daire başkanlığına anlatacak, tedbiri alacak, bunun için bütçe ayarlayacak. Bunun için herhangi bir yasal mevzuat hazırlayacak falan. Kusura bakmayın, olmaz. Ya ne biz Kızılay olarak bundan gocunmuyoruz. Dünyanın en büyük sivil toplum kuruluşlarından birisi. Bunu siz de takdir ediyorsunuz. Ama biz insanlar öldükten sonra, insanların başına büyük musibetler, afetler geldikten sonra ki öyle bir şeyimiz yok. Yakın zamana kadar vardı. İlk kurtarma ekibimiz vardı. Daha çok barınma ve beslenmeye yönelik AFAD'ın yanında bir rol üstleniyoruz. Ama biz yani insanlar işte ölmüş, geride kalanlara yemek veren, geride kalanlara barınmasını sağlayan bir fonksiyon üstlenmek istemiyoruz. Bu konuda Türkiye olarak biz de tedbir alacaksak devlet olarak, çünkü yani riskli bir bölgedeyiz. Biz de tedbirimizi almalıyız. Yeterli mi? Son 10 yıldır, 15 yıldır eskiden savunma müdürlükleri vardı, il savunmalar vardı. Şimdi AFAD'la daha da profesyonel, daha da teknolojiyi yakalamış, daha da kendini geliştiren, daha da heyecanlı, daha da kurumsal bir yapı içerisindeyiz. Bu tabii ileriye dönük bize bir umut vaat ediyor. Yeterli mi? Yeterli değil. Maalesef yeterli değil. Hele başka ülkelere baktığınız zaman, Ekvator depremine gittim. 2004'te tsunami'den sonra Aceh'e gittim ya, bizzat operasyonların başında. 2005 Keşmir depreminde yine operasyonun başında bulundum. Pakistan Sel'de bulundum. Nepal'de bulundum. Somali'de uzun süre çalıştım. Suriye'nin içerisindeki farklı işte sıkıntıdan dolayı oralara girdik, çalıştık. Yani dünyanın neresinde böyle sıkıntı, problem varsa en büyük sıkıntı ve problemler buralarda. Hem Kızılay kimliğimle hem İstanbul Büyükşehir Belediyesi danışman kimliğimle ekibimizle birlikte buralara bulunduk. Gittiğim yerlerde çok vahim durumlar gördüm. Ülkenin ismini vermeyeyim. Sevdiğimiz, saygı duyduğumuz insanların yaşadığı bir coğrafya. Gittik. Ekibimizden gittik yardımcı olmaya. Hemen bizi çok güzel şekilde karşıladı. Hatta 3 tane bakanın katıldığı, önemsedikleri bir toplantıda nasıl bir sıkıntı yaşadılar, sıkıntıyı nasıl çözerler, bizden beklentilerini falan sordular. Toplantının bitiminde bir beyefendi, yine yetkili bir beyefendi, kriz masasının başında size bizim kriz merkezimizi bir göstermek istiyoruz, görmek ister misiniz falan dediler. Gittik nezaketen bir görelim falan dedik. Yani arkadaşlar kusura bakmayın, kocaman bir ülke, yani bu asırda falan çok böyle ilkel bir anlayış falan olmaz, böyle bir hazırlık olmaz. Böyle bir bodrum katta, düz zeminde, küçücük bir odada 4 tane falan bilgisayar var, orada yaptığı çalışmaları bize anlatacaklar. Bakıyorlar, basıyorlar falan tuşlara falan, klavye tık tık tık pık pık pık. Adam utandı, mahcup oldu falan, sonra döndü, kusura bakmayın dedi. Bu aşırı yaştan dolayı bizim bu odaya da dedi girdi, su girdi. Etkilendik, çalıştıramıyoruz dedi. Yani böyle bir şey olmaz ya, böyle bir hazırlık olmaz. Ben o ülkeyi, o devlet yöneticilerin küçümsemek kastıyla söylemiyorum. Dünyadaki insanların duyarsızlığını bir realite olarak gördüğümden söylüyorum. Kriz masası böyle küçücük bir odada 4 tane bilgisayarla ne kriz masası oluşturulur, ne yönetilir? 302 bin kişi tsunami'de hayatını kaybetti. Haiti'de, oraya da gitmiştik depremden sonra, 232 bin kişi hayatını kaybetti. Etnik kimliği ne olursa olsun, kültürü, dini, konuştuğu dili, yaşadığı coğrafya ne olursa olsun sonuçta insan. Etkileniyoruz. Biz de duygularımız var. Biz de insan olarak etkileniyoruz. O insanların başına bir sıkıntı, problem gelsin istemiyoruz. Yaşasınlar istemiyoruz. Ama bu kadar duyarsız olmaz. Bu kadar risk yaşıyorlar bu ülkeler. Hazırlık. Hani hazırlığınız? Hazırlığı görmek için yani bizzat bu hadiseleri, Sayın Başkanım hoş geldiniz. Hazırlığınızı görmeniz için bu hadiseleri bizzat böyle çok acı, dramatik bir şekilde yaşayacaksınız ve göreceksiniz. Yok böyle bir şey. 2004 tsunamisi sonrası çarpıcı bir örnek olsun diye ifade ediyorum. Yani ders çıkarıyoruz bu ülkeler yaşadıkları tablodan sonra, ben sizin takdirlerinize sunuyorum. 302 bin kişi, önce bir 500 bin kişi falan öldü dediler. Sonra kayıplar, hastanelere falan gidenler, komşu ülkelere gidenler döndükten sonra net rakamı Endonezya devleti, Aceh hükümeti açıklamıştı. 302 bin kişi hayatını kaybetmişti. Gittiğimiz günlerde uzun zaman kaldık. Çok geldim gittim, ekibimiz orada kaldı. Hem Kızılay hem İBB ekibi olarak kaldık. Yeni bir yerleşim planı hazırlayacaklarını söylediler. Eskiden tabii hep denizin kenarı, böyle çok görsel estetiği olan, hemen denize ulaştığınız, tekneniz, yatınız, marinanız, bilmem neyiniz varsa, kotranız, neyiniz varsa orada denize açıldığınız, ayaklarınızı otururken suya soktuğunuz, hemen denize girdiğiniz yerlere yerleşmiş insanlar. 100 yılda bir Sumatra adasında çok ciddi manada depremin olduğunu söylediler, tsunami'nin olduğunu söylediler. Ve arkasından da ölen binlerce insanın öldüğünü söylediler. Yeniden şehri planlayacağız dediler. Gerçekten valilerle, bakanlarla yaptığımız toplantılarda sivil toplum kuruluşlarına, yurt dışından gelen insanlara da brief veriyorlardı. Gerçekten memnun. Belediyecilik yönümüzde olduğu için çok memnun oldum. Yani yaşadıkları bu acı hadiseden sonra bir ders çıkardıklarını, aynı hataya düşmeyeceklerini falan duyunca, görünce sevindim gerçekten. Dediler ki artık yerleşim alanlarını biz sahile falan yapmayacağız. Sahilde rekreasyon alanları yapacağız. Şehri biraz daha yerleşim alanlarını, işte alışveriş merkezleri, ibadethaneler, konutlar, resmi konutlar falan, hastaneler, eğitim alanları falan, bunları yeniden planlayacağız dediler. Gerçekten sevindirici yeni bir şehrin master planını görünce dedim ki gerçekten bir ders çıkarmışlar ama 300 bin kişi kaybolduktan sonra. Aradan birkaç yıl sonra gittim Endonezya'ya, yine Aceh'e gittiğimde gördüğüm manzara, o yıkılan evlerin yerine aynı sıfır noktasına gene evleri yapmışlar. Ya 300 bin kişi hayatını kaybettikten sonra siz ders çıkarmıyorsanız bu dersi ne zaman çıkaracaksınız? Bangladeş keza aynı. Pakistan'da efendim işte 2000 kişi hayatını kaybetmişti. Yine tabii bir kişi de olsa önemli. Pencap'taki 1600 kilometre, 50 kilometre enindeki o sel felaketinden sonra yine oraya da gittiğimizde gene ırmakların kenarlarında evlerin yapıldığını gördük. Diye çok güzel tabii, affedersiniz, kanalizasyon oraya bağlıyor. Balık tutacaksa oradan tutuyor. Evinin bahçesinden çok güzel efendim akan ırmağı falan, şırıltısını falan böyle güzel dinliyor. Görsel estetik güzel. Ama aşırı bir yağıştan sonra o evlerin yıkılmaması zaten şey değil. Zaten yani ileri inşaat teknolojisi kullanamıyorlar. Bir, öyle bir teknolojileri yok. İki, öyle bir bütçeleri de yok. Tuğla üzerine koyuyorlar. Ne raddel temel, ne mütemadi kiriş, ne zelzele kirişi, hiçbir hazırlıkları yok. Bangladeş'te işte yeni geldiğim için yine gördüm. Orada efendim muson yağmurların etkilediği dere yatıklarına ve vadilere insanlar gene yerleşiyor. Burada tabii insanların ekonomik durumları mı oraya yitiyor? Yoksa zevk olsun diye mi? Yani böyle görsel estetiğe dikkat ettikleri için mi buraları tercih ediyorlar yerleşim alanı oturmaları açısından? Bu tabii tartışılır ama biz özellikle kamu yönetimi, yani yöneticilerin bu noktada tedbir alması lazım. Burada mevzuat çok önemli. Yasal mevzuatı mutlaka yani hazırlamanız lazım. Ülkenin risk haritası çıkarılıp buna göre hazırlamak lazım. Yaptırımlar uygulamak lazım. Yani bunun için de tabii güçlü bir iktidar, güçlü bir yönetim, güçlü bir yerel yönetim, güçlü bir merkezi yönetim, yasal mevzuatı beraberce hazırladığı, kamuyla beraber hazırladığı ve bireysel olarak da insanların bilinçli ve şuurlu olduğu bir toplum oluşturmak lazım. 1999 depreminde ben İstanbul'da bir ilçede belediye başkan yardımcısıydım. Vekalet ediyordum başkanlığa. Hepinizin bildiği tarih 17 Ağustos depremi bir salı günü akşam olmuştu. İstanbul'da fazla olmadı. Birkaç mahallede, birkaç yerde risk oldu. Oralara yardım ettik. Sonra hepinizin bildiği gibi Sakarya'da ciddi bir yıkıntı olunca oraya gittik. Arkasından geri döndük. Kendi hazırlıklarımızı yaptık. Merkez hükümet döneminin hükümeti hazırlıklar yaptı. Bakın bir anekdot ama gerek Türkiye'deki durumun bireysel olarak insanlarımızın bir afete bakış açısının ne olduğunu göstermek açısından çok çarpıcı bir örnek. Bizzat yaşadım ve üzüldüm. Belki de bunu birkaç yerde paylaştım. Çok yerde paylaşamadım. Benim toplumun ayıbı. Bizim ayıbımız. 2001 yılında JICA'dan yetkililer, Dünya Bankası'ndan yetkililer, Devlet Planlama Teşkilatı'ndan yetkililer geldiler. Fatih'te belediye başkan yardımcısıyım. Dediler ki bize birkaç farklı denek gösterin. Biz buralarda düşündüğümüz Dünya Bankası kredisiyle JICA'nın binaların güçlendirmesiyle alakalı bir projenin altlığını oluşturmak, yani düşünsel, fikirsel altlığını oluşturmak için biz farklı deneklerde binaları ziyaret etmek istiyoruz dediler. Hemen ilgili arkadaşlara söyledik. Ne istiyorsunuz? Dediler ki çok katlı bir bina ama tek bir mülkiyet sahibi olsun. Çok katlı bir bina, farklı kat malikleri olsun. Tek katlı bir bina, işte içinde kiracılar olsun gibi. Gittik, bunları bulduk. Efendim işte JICA, Dünya Bankası, Devlet Planlama yetkilileriyle birlikte binalarda insanları davet ettik. Efendim mahallenin muhtarı, işte kaymakam bey davet ettik. Dedik ki bu, biliyorsunuz ki riskli bir kuşakta, fay hattında yaşıyoruz. Her an 17 Ağustos depremi gibi veya 12 Kasım Kocaeli depremi gibi bir sıkıntıyla karşılaşabiliriz. Binalarınızın da güçlü olmadığını siz de biliyorsunuz. Bazıları ağır hasarlıydı, hemen yıkım kararı çıkmıştı. Bazıları orta hasarlıydı, bazıları az hasarlıydı. Ve burada insanlarla toplandığımızda şunu söyledi yetkililer. Biz yalnız bir aracı olduk. Yani yerel yönetici olarak aracı olduk. Dünya Bankası ve JICA yetkililer dediler ki sizin binanızı biz 1 yıllığına boşaltmak istiyoruz. Kiralarınızı vereceğiz. Binalarınızı güçlendirmek istiyoruz. Bu çünkü çok ciddi bir proje. Yüz binlerce evi kapsayacak bir projeydi. Efendim, yani hakikaten utandım. Aldığımız cevaplardan utandım. İnsan sağlığından önemli daha ne olabilir? Çocuğunuzun eline bir iğne bassa, eline böyle bir sıcak su dökülse evde kahvaltı yaparken yüreğiniz yanıyor. Ama öbür tarafta afetin altında, binanın altında kalmış, paramparça olmuş evladınızı mı görmek istersiniz? Veya riski azaltıcı tedbirler mi almak istersiniz? Ben hanımefendilerden çok özür diliyorum. Yani işlerinde çok duyarlı hanımefendiler de vardı ama birçok hanımefendinin söylediği şu. Evet doğru, biz binamızı çok güçlü falan görmüyoruz, düşünmüyoruz. Riskli olduğunu da biliyoruz ama biz 1 yıl bir başka binaya gittiğimizde acaba benim perdem o yeni taşınacağım eve uyar mı? Efendim hocam?
Cümle başkanım, bitti süreniz.
Tamam,
Hanımlara girince el attım bu konuya.
Tamam. Hocam teşekkür ederim, evet. Çok teşekkürler. Diyor ki hanımefendi ve beyefendilerden de, yani benim çocuğum falan okulda burada öğretmenine alışmış, arkadaşlarına alışmış, bir başka semte gittiğimde kirasını siz de verecek olsanız orada öğretmenine nasıl alışacak, adapte olacak, nasıl efendim bu konuda arkadaşlarıyla yeni arkadaşlıklar kuracak. Yani çocuğunun hayatıyla alakalı, kendi ailesinin efendim hayatıyla alakalı önceliği değil, evde koltuğunu, perdesini düşüren bir anlayışta bu toplumsal dönüşümü, bireysel dönüşümü, bilinçlendirme dönüşümü falan sağlamak mümkün değil. Benim şahsi kanaatim, bir yönetici olarak efendim Kızılay kimliğimde şunu söylüyorum, Türkiye'de de ve birçok ülkede de, bir başka ülkeyi ben çok şey yapmam tabii, bu konuda bir yaptırım gücümüz falan olmaz. Temenniden öte geçiyoruz ama kendi ülkemde bunu yetkililere de ifade ediyoruz. Okullarda eğitime mutlaka mecburi ilk yardım dersi ve bilinçlendirme ve afete yönelik şuurlandırma dersinin ve bilinçlendirmesinin konulması lazım. İstanbul'un 16 milyon nüfusu var, ulaşılabilen insan ilk yardım eğitimi verdiğimiz sayı 4 milyon civarında. Daha %25'i. O da zorunlu olarak okuldan çocuklara milli eğitime yazmışız, gelin demişler, gelmişler. Ben sizin takdirlerinize bırakıyorum. Temennimiz dünyanın hiçbir yerinde afetlerin yaşanmaması, insanların bırakın ölmesi, burnunun dahi kanamaması arzusu içerisinde. Bu konuda Kızılay olarak, AFAD olarak ve diğer kurumlarımız olarak her şeyden öte hocalarımızın değerli fikirleriyle toplumun bilinçlendirmesi ve kamusal hazırlıklar noktasında iyi noktaya doğru gidiyoruz ama çok eksiğimiz var. Bu konuda hepimize sorumluluk düşüyor. Teşekkür ederim hepinize.
Teşekkürler. İsmail hocamıza, başkanımıza teşekkür ederiz. Ben de tebliğ sunumumda bahsetmiştim, biliyorsunuz, öğrenilmiş dersler konusunda. Onun için kendisinden mutlaka bir öğrenilmiş dersler dersi verebilmemiz için tecrübelerini bekliyoruz. Benim de sunumumda hatırlayacaksınız, belediyeler başta olmak üzere yerel yönetimlerin imar planları konusunda yetkili olduğunu söylemiştim. Onun için sıradan insanlar masum bir iyi niyetlilik içinde eteğinin danteliyle parke taşına bakabilir ama bunun nihai sorumluluğu kuşkusuz o yapıları kontrol edenlere aittir. Bu bakımdan idarenin benim de söylediğim gibi görev ve sorumluluklarını yerine getirmesi son derece önemli. Operasyon merkezlerini kural olarak biliyoruz ki içinde yaşayanların 4-5 ay kalabilecekleri, afetlerden etkilenmedikleri ve teknoloji avucunun içinde olduğu alanlar. Sizin örneğinizde göstermiş olmalarını ben taktiksel olarak biraz savunmaya bağlıyorum. Bizim yerimiz böyle, tabii binlerce ölü görmeniz son derece doğal diye. Çünkü hiçbir personel aslında defosunu göstermek istemez. Burada hemen şunu hatırlatmak istiyorum. Stratejik planlarda afetler de yer almalı. Mesela Lur geçen yıl da, hatta 2017'de başında Sen Nehri 6.6 metre yükseldi. 90'da 9.9 metre yükselmiş. Ben de o sırada Kültür ve Turizm Bakanlığı'na derse gitmiştim, hizmet içi eğitimi. Demiştim ki stratejik planlarınızda kültür varlıkları herhangi bir afete maruz kalırsa ne yapacaksınız? Örneğin sel gibi. Stratejik planınızda hiçbir maddeye rastlamadım. Yok dediler. Dolayısıyla öncelikle sizin de vurguladığınız gibi stratejik planlarında kurumların, bakanlıkların afet konusuna özel bir yer vermeleri son derece tabii ki yerinde olacaktır. Üçüncü konuşmacımız Gökhan Ergin. Buyurun efendim.
Çok değerli hocam, çok değerli bilim insanları, Kızılay'ımızın ve değişik sivil toplum kuruluşlarından gelen gönül verenler, hanımefendiler, beyefendiler, hepinizi saygıyla, sevgiyle selamlıyorum. Benim ismim Gökhan Ergin, İstanbul Valiliği İstanbul Proje Koordinasyon Biriminin 2006 yılından bu yana kurucu direktörlüğünü üstlenmekteyim. Mesleğe 98 yılında özel sektörde atıldım ve ilk görevimiz proje mühendisi olarak İstanbul ve İzmir devlet hastanelerinin güçlendirme veyahut yeniden yapım projelerini hazırlamaktı. Tabii o yıllarda bu işler çok bilinmiyordu. Bir şartnamesi de yoktu. İngiliz bir danışmanlık firması vardı ve Toplu Konut idaremizdi. Ve o gün İngiltere ve Amerikan şartnamelerini çevirerek o çalışmaları yapmıştık. 99 depremi olduğunda bizim işlerin kıymeti çok daha anlaşılır oldu ve yapılan çalışmaların bir kısmı da güçlendirme projelerinin uygulanma imkanı oldu. Daha sonra 2000 yılında ben Başbakanlık Proje Uygulama Birimine koordinatör olarak göreve başladım. Marmara depremi yeniden yapılandırma projesinde görev aldık ve çeşitli yerlerde, özellikle Marmara bölgesinde 15.000'in üzerinde konut inşaatı, altyapı, okul ve hastane inşaatı yaptık. Tabii bu arada İstanbul'un deprem riski de ortadaydı. Aslında İsmail Hakkı abimiz çok güzel damıttığı tecrübeleri bize aktardı. Aslında Zerrin hocam bir bilim insanı olarak ufkumuzu açtı ilk önce. Ve İsmail Hakkı abimiz de bize o damıttığı tecrübelerden istifade edelim diye anlattı sağ olsun. Hatta biz oturuma başlamadan önce Zerrin hocam İsmail Bey'in yaptığı özellikle çalışmaları kayıt altına almanın ve onları kitaplaştırmanın çok önemine değinmişti. Ben de o fikri çok beğendim aslında. İsmail abi onu bir şey yaparsak, kayda alırsak ve dökersek oradan çok tecrübeler çıkacaktır bizlere de. Şimdi İstanbul'un deprem riskine karşı neler yapılabilir? Bunlar özellikle çok konuşuldu o yıllar. Ve ben de İstanbul'un depreme hazırlık konusunda neler yapılması gerektiğine dair Başbakanlıkta çalışan ekipteydim. İstanbul'a çok sefer geldik, gittik ve bizim oturumumuzun adı Afetler ve Yerel Yönetimler. Biz Başbakanlıktan geldiğimiz zaman aslında yerel yönetim bu denli önemli olduğunu belki bilemiyor olabilirdik. Ama bizatihi şu an 11 yıllık tecrübemle ve bir yerel idarenin altında çalışırken bunun nedenli önemli olduğunu anladık. Çünkü şehirle hemhal olmak, şehri anlamak, sorunları neler, darboğazları neler, bir ulaşım sorunu bile İstanbul'da çok önemli bir sorun yeri geldiğinde. Ama biz bu projeyi mesela Başbakanlıktan veya bakanlık düzeyinden yönetseydik, işte yazışmalar olacaktı. Biz bir yazışma gönderecektik. İstanbul Valiliği veya belediye bize bir yazı gönderecekti. Biz onun neden olduğunu belki anlayamayacaktık. Çünkü bu şehirde yaşamıyorduk. İşte belki bir Eskişehir'e veya Kahramanmaraş'a nasıl bakıyorsak merkezi idareden İstanbul'a da öyle bakıyor olacaktık. Ama biz yerinde bir yönetim ve yönetişim yapınca, buranın sorunlarını da bilince ona göre özellikli ve öncelikli bir proje yürütebildik en nihayetinde. Tabii projeye başlamadan önce Biz Dünya Bankası'yla Hazine Müsteşarlığımızın bize verdiği yetkiyle çeşitli safhalarda görüşmelerimiz oldu. Ama en önemsediğim konu şu idi. Özellikle kamu binaları üzerine yoğunlaşmıştık. Okullar, hastaneler, yurtlar ve sosyal hizmet binaları olarak. Bunların hangileri sizler için öncelikli demişlerdi bize. Yani biz bir kredi tahsis edeceğiz buraya. İşte o ilk başladığımız bizim 310 milyon euroluk bir krediydi. Ama sizin ihtiyacınız belki 3 milyar, belki daha fazla veya daha az. O zaman hangi okuldan, hangi hastanenizden başlayacaksınız diye sormuşlardı. Biz o gün çok anlayamadık belki onu ama gereğini yaptık. Özellikle biz iyi bir yönetişim yaptığımızı düşünüyoruz. Yine 3 tane büyük üniversitemizden akademisyen, profesör hocalarımız geldiler. İlgili kurumların il müdürleri, vali yardımcılığımızın başkanlığında, ben de o komisyonun üyesiydim. Bir önceliklendirme çalışması yaptık. Önce kamu binalarını sektörlere ayırdık. Okullar, hastaneler, sosyal hizmet binaları, yurtlar ve idari binalar diye. Daha sonra her sektör altında da bir önceliklendirme kriteri belirledik. Fay hattına yakınlık, uzaklığı, okulda barındırdığı nüfus, işte 1000 kişi mi içinde var okulun, 3000 kişi mi var, 500 kişi mi var? Veya hakeza bir yurdun kapasitesi. İşte hastaneler için ulaşım çok önemliydi. Havadan ulaşım var mı yok mu? Karayoluyla nasıl ulaşılıyor? Öncelikli yollara yakın mı? İhtisas hastanesi mi? Vesaire vesaire. Biz projeye başlamadan önce 1. okulumuzda biliyorduk, 100. okulda. Bu bize ne sağladı? Biz okulları güçlendirme ve yeniden yapıma başladığımızda ilk 104 okulla başladık. Nisan 2007'de. Diğer okullardan hocalar da geldi, müdürlerimiz. Niye bizim okul değil de bu okullardan başlıyorsunuz diye. Biz onlara bu kriterleri, teknik kriterleri gösterince ha tamam bizim okulda seneye veya ondan sonra sene programlanmış diye baktılar. Ve biz daha gerçekçi ve daha sorun çıkmadan bir yönetim yapabildik. İstanbul Sismik Riskin Azaltılması ve Acil Durum Hazırlık Projesi şu an 2 milyar euroluk bütçeli bir proje. Dünya Bankası, Avrupa Yatırım Bankası, Avrupa Konseyi Kalkınma Bankası, İslam Kalkınma Bankası ve Alman Kalkınma Bankası'ndan Hazine Müsteşarlığı nezdinde alınan kredilerle biz işlerimizi yürütüyoruz. 3 tane ana bileşenimiz var. Birincisi AFAD'ın kurumsal kapasitesinin artırılması. Acil durum kapasitesinin artırılması kısmında araç gereç ekipman alımı. Yine İsmail abinin bahsettiği gibi bu özellikle komuta kontrol merkezleri çok önemli. 2 tane komuta kontrol merkezi yaptık biz İstanbul'da. Biri Hastal'da, diğeri de Akfırat'ta. Bunlar hem birbirlerini yedekler mahiyette hem de her türlü haberleşme ağıyla donatılmış ve deprem sonrasında kendine yetecek birimler ve yönetim merkezleri olarak tasarlandı. Hatta Tuzla Akfırat'ta Kızılay'ımızın lojistik merkezi de var. Marmara'da özellikle Marmara bölgesine hitap edecek, Doğu Marmara'ya bir lojistik merkez de oraya tasarlandı ve yapıldı. Ayrıca halkın eğitimi de çok önemliydi. Biz bugüne kadar İstanbul'da materyallerle kampanyalarımızla 3 milyon kişiye ulaştık. Yeterli mi? Hayır. Özellikle Kızılay Genel Başkanımız bu ara çok vurguluyor üstünde güvenli yaşam kültürü. Biz güvenli yaşam kültürünü geliştirmemiz gerekiyor arkadaşlar. Dolayısıyla güvenli yaşam kültürünü de ancak eğitimlerle, insanlarla hemhal olarak, onlarla bir bütün olarak ve afet öncesi, sırası ve sonrası doğru yaklaşım onları anlatarak güvenli yaşam kültürünü aktarabiliriz, anlatabiliriz. İşte o zaman o İstanbul'daki Fatih'teki kadınlar da ya biz ne zaman yapabiliriz, hadi bunu bir an önce yapalım diyecekler aslında. Bunları anlatmamız lazım halka diye düşünüyoruz ve biz önümüzdeki süreçte de AFAD'la bu güvenli yaşam kültürüne dair eğitimlerimize devam edeceğiz. Aslında burada Kızılay'da bir paydaş olarak mutlaka düşünüyoruz. Beraber yapacağız diye umuyorum. Ayrıca en büyük bileşenimiz kamu binalarının güçlendirilmesi ve yeniden yapımı. Şu ana kadar İstanbul'da biz 1320 tane kamu binasını güçlendirdik. Eğer güçlendirme maliyeti yıkıp yeniden maliyetin %40'ını aşıyorsa yıkıp yeniden yapıyoruz. Okullarda 1083 tane okulu güçlendirdik veya yeniden yaptık. Bunlar 99 öncesi yapılan binalardır. Çünkü 99'dan sonra bizim 98'de yeni bir inşaat yönetmeliğimiz çıktı. Ve nispeten 99 sonrası yapılan yapılar daha sağlam ve daha dayanıklı. Çünkü perde duvarlar ve kolon boyutları büyüdü. Dolayısıyla biz 99 öncesi binalara fokuslandık ve onların da okullar bazında %85'ini İstanbul'da bitirmiş vaziyetteyiz. Yurtların %90-95'ini yine bitirdik. Özellikle en büyük yurdu İstanbul'un Atatürk Öğrenci Yurdu'nu yıkıp yeniden yaptık. Şu an 3555 kız öğrencisi orada okumakta. Ayrıca yine proje kapsamında kültürel tarihi mirasla ilgili yaptığımız çalışmalar vardı. 26 kompleks 176 binada envanter çıkardık. Çoklu afet riskine karşı bunların risk durumları neler? Az riskli mi, çok riskli mi, orta riskli mi diye. Üçü içinde güçlendirme ve restorasyon projeleri bütünleşik olarak yapılmıştı. Bunlar Aya İrini, Arkeoloji Müzesi ve Mecidiye Köşkü. Ama biz gördük ki bunun bir standardı, bir mevzuatı yok Türkiye'de. Ve biz 2012 yılından 2013 yılından beri Kültür Bakanlığı ve Vakıflar Genel Müdürlüğü ile beraber bunun mevzuatına dair ne yapabiliriz diye çalışmalar yaptık. Daha geçen hafta tarihi miraslarda nasıl bir yaklaşım yapılabilir onunla ilgili bir kılavuz çalışmamız vardı. Ve kılavuz çalışmamızı İtalyan uzmanlarla beraber tamamladık ve şu an Türkiye genelinde dağıtımına başlıyoruz. Bu kılavuz çalışması yaşayan bir doküman olacak. Elde edilen çıktılar, yapılan uygulamalar ve tecrübelerle birlikte bunun çeşitli versiyonları olacaktır diye umuyoruz. Kültür Bakanlığı ve Vakıflar Genel Müdürlüğü de Anıtlar Kurulu'yla beraber bu dokümanı, kılavuzu inşallah yürürlüğe koyacaklar diye umuyorum. Çok önemli bir çalışma Türkiye için. Ayrıca pilot belediyelerde yine imar mevzuatını etkin uygulamak açısından neler yapılabilir diye ortaya çıktık ve Bağcılar ve Pendik pilot belediyelerinde bütün arşiv sistemini dijital hale getirdik. Orada kurulan yine call center yani çağrı merkezleriyle beraber halkın da daha etkileşiminin yoğun olduğu ve birebir kontrolünün olduğu raporlanabilir şeffaf süreçler yaptık. Eskiden belki inşaat ruhsat süreci 80-90 iş kalemiyle çıkıyordu. Bunlar biz baktık ki bazılar birbirini tekrarlayan süreçler. Süreç analizi yaptık ve 54 sürece indirdik. Yine biz belediye başkanına veya başkan yardımcımıza sorduğumuzda ne kadar sürede inşaat ruhsatı verebiliyorsunuz diye işte 6 ay da olabiliyor, 3 ay da olabiliyor dedikleri süreci de 10 günün altına çektik. Ve bu da diğer belediyelere de örnek oldu bu yapılan çalışmalar ve diğer belediyeler için de güzel bir örnek ve uygulama olduğunu düşünüyoruz. Ayrıca inşaat mühendislerinin 2007'de deprem şartnamesine güçlendirme yönetmeliği kısmı eklenmişti. 3500 civarında inşaat mühendislerine Türkiye çapında da eğitim verildi. Yani şu an gelinen noktada İstanbul Vali Proje Koordinasyon Birimi tarafından uygulanan İSMEP projesi dünyada da çok bilinen, hatta İsmail abiyle de konuştuk, geçen Bangladeş'e de gitmiş. Bizim projenin aynısı, benzeri demeyeceğim ama hemen hemen aynısı Bangladeş'te de yürürlüğe kondu ve çeşitli ülkelerden çok sayıda ziyaretçi alıyoruz. İşte bu hafta yine İslam Kalkınma Bankası'ndan, Dünya Bankası'ndan gelecek ziyaretçilerimiz var. 2 hafta önce Filipinler'den çok üst düzey müsteşar ve bakan yardımcısı düzeyinde ziyaretçilerimiz vardı. Aynı zamanda 34 ülkede 75 tane biz konferansa veya panelist veya konuşmacı olarak katıldık. Yani bizim tecrübelerimizi de dünyaya aktarıyoruz. Biz Birleşmiş Milletler'in yine güvenli okullar alanında en başarılı uygulama örneği olarak seçildik ve Dünya Bankası'nın da ülkemizde highly satisfactory denilen en yüksek derecedeki başarı notunu almış bulunuyoruz. Ve biz şunu gördük, aslında yerel idarede belli bir bütçe ve belli bir ehliyetli ve liyakatli ekip bu işe ayrıldığı zaman aslında bu işler olabiliyor. Yeter ki afet öncesi zarar azaltmaya tamamen fokuslanılsın veya bu konuda neler yapılabilir iyice ortaya koyulsun ki Zerrin Hocam'ın İzmir'le ilgili çok önemli çalışmaları var. Aslında bu model mesela çok rahat İzmir'e de yayılabilir ve orada da tatbik edilebilir. Ben özellikle beni dinlediğiniz için, ilginiz için çok teşekkür eder, saygılarımı sunarım efendim. Sağ olun.
Değerli bürokratımız Kazım Gökhan Elgin Bey'e teşekkür ederiz. Bana bir şey hatırlattı. Sakarya depreminde doktora sınavı vesilesiyle deprem sonrasında şehre gittik. Arkadaşım o sırada kamu yönetim bölüm başkanıydı. Görevden almışlar. Niye? şurada burada çatlak var, bu çatlakları ne yapacağız dediği için biz gittiğimizde badanalanmıştı. Görmedik. Yani deprem sonrası badanalandığından bahsediyorum. Hakikaten ne yapalım diye bir komisyon kuracak yerde niye ilgileniyor diye bölüm başkanını görevden alan ve maalesef bir akademik dünyadan bahsediyoruz. Yani kendimize de hani bir eleştiri olsun diye. Tabii hukuki düzenlemeler çok önemli. Siz konuşurken baktım, hata yapmayayım, siz daha iyi bilirsiniz. Kamu binaları denetim yönetmeliğinde 2001'de çıktığında yoktu denetimi. Halbuki en fazla kamu binaları biraz önce söylendiği gibi etkilenmişti. Çok sonra geldi kamunun denetimi. 2012-13'lerde. Ondan sonra da pek bir çalışma yapılmadı. Onun için sizin bu çalışmanız gerçekten bir katkı verecek. Bu da gerçekten çok önemli. Sevgili arkadaşlar, sevgili dostlar, bizim oturumumuz ve sizlere aktarabildiğimiz bu dönem içerisindeki konuşma süresi içerisinde ancak bu kadar. Ama sizin soracağınız birkaç soruyu alabiliriz varsa ve o şekilde teşekkür edip kapatacağız. Sorusu olan arkadaşımız var mı acaba? O zaman şu sözü söylemeden geçemeyeceğim. Çok etkilenmiştim açıkçası. Bu mukavemetli toplum çok önemli. Sabah da anlatıldı, her şey olabilir ama insan faktörü çok önemli. Benim gözümden gitmiyor baltaları eline alıp ağaçlara saldıran bir şehrin halkından bir iki kişi bile olsa. Bu ne hiddet, bu ne şiddet. Dolayısıyla yerel yönetimlerin sadece yol, su değil, bunlar çok önemli. Aynı zamanda kültürel karşılıklılık prensibi diye bir prensip var. Yani aynı duygular, hedefler içinde toplum olmalı. Hani tarihi geçmişin olmayan yeni gruplar da gelebilir. O açıdan yerel yönetimlerin, aramızda yerel yöneticiler var. Mutlaka kent konseyleri ve diğer organları veya organ olmayan danışma mekanizmalarını kullanarak mutlaka bulundukları idari sınırlar içerisinde kültürel ortaklaşmayı sağlayacak hizmet içi eğitimler dışında halka yönelik de eğitimleri yapması son derece gerekli. Çoluk çocuğa süt vermeyi saygıyla karşılıyoruz ama bakanlarımız da söyledi, gelenlerin %50'sinin eğitimi yok, yapılamıyor. Bu da kayıp nesil anlamına gelir. Bu ayrı bir problematik konudur. O nedenle yerel yönetimlerden başlamak üzere birçok belediye, bunun içinde büyük şehirler de var, diğerleri de var. Çok ilgilenenler de var, hiç ilgilenmeyen, nasılsa gidecek diyenler de var. Siz daha yakından görmüşsünüzdür. Mutlaka kültürel oydaşmaların sağlanacağı, kültürel faaliyetlerin yapılmasına katkı vermeleri ve strateji planlarına mutlaka göçle gelenleri almaları çok önemli. Bunu yapmıyorlar. Bu bizim tespitimiz. Bununla sözlerimi bitirmek istiyorum. Teşekkür ediyorum hepinize. Söylenmedi, siz biliyorsunuz herhalde. Onun için ben de bir şey söyleyemeyeceğim. Takan kimse yok değil mi? Dear distinguished, you're welcome to the second section dememe gerek yok ama hadi demiş oldum nezaketen. Şimdi arkadaşlarım bu ikinci günün ikinci oturumunda afetler ve yerel yönetimler diye çok önemli bir başlığımız var. Çok önemli, ben de dahil, ben önemli miyim bilemiyorum ama 2 tane önemli konuşmacımız var. Tabii bütün deneyimleri ve bilgileriyle bize burada büyük bir katkı verecekler. Hatta kayıt bile alabilirsiniz demek isterim. Çünkü bunları bir daha bulamayabiliriz bu bilgileri. Ben hemen vakit geçirmeden toplantıyı açmak istiyorum izninizle. İlk konuşmacı da benim. Sizleri Allah kahretsin deyip sıkıntıya sokmayacak bir profesyonellikte yürütmek istiyorum. Çünkü hem yönetici hem sunucu olmanın avantajları olduğu gibi dezavantajları da var. Yani bu profesyonelliğimi göstermeye çalışıyorum. Ekranda görmüyorum kendimi. Yönetiliyordu ama nereden geliyor şey? PowerPoint'i yollamıştık. Ben bilemedim. Lütfen yardımcı olur musunuz? Oturacağım. Ya oraya gideceğim. Ha, tamam. Teşekkür ederim. Hocam siz 15'te öksürün. Tamam mı?
15'te tamam.
Kamu yönetimi bölümünde eğitim almış bir öğretim üyesiyim. Profesörüm 96'dan beri ve girişimci kadınım. Girişimciliğimle bağlantılı olarak bu konuyla ne alakası var? 9 Eylül Üniversitesi'nde afet yönetimi yüksek lisans ve doktora programını kurduk. Hatta öğrencilerimin çoğu burada. Bugün burada ders yapıyoruz. Aslında İzmir'de olsaydık sabah dersimiz vardı. Ama buraya geldiler. Hem sizlerle tanışmak için hem de dersimizi burada yapacağız. Aynı zamanda kamu yönetimi bölüm başkanıyım. Dağlık alanların sürdürülebilirliği ve yönetişimi diye de bir dernek kurdum. Tabii ki iklim değişiklikleriyle bağlantılı olarak Türkiye'nin %80'i dağken, böyle yerel yönetimlerinde birçoğu dağlık alan belediyesi iken ve hala inşallah içimizde belediyeden arkadaşlarımız vardır. Bir dağlık alan belediyeler birliği diye bir birlik kurulması ihtiyacı ortadayken ve kurulmamışken bugün bir geniş bakış açısı içerisinde ben yerel yönetimlerden anlayan, işte 40 yıldır bu dersleri veren biri olarak, neredeyse 40 yıl, sizlerle bazı konuları paylaşmak istiyorum. Görülen o ki afet bizim rutin hayatımızı etkilemekte ve dolayısıyla kayıplar ortaya çıkmakta. O zaman aslında bu kayıpların büyük bir kısmı toplumun bizzat kendisinden kaynaklanmakta. Ama kamu yönetiminin hatalarından doğan sorunlar büyük bir kısmı. Dolayısıyla sabahleyin bir mukavemetten bahsedildi. Ben bekledim mukavemetli toplum densin diye, Resilient Society diye. Evet, burada önemli olan aynı zamanda bu anlatıldığı gibi sabah kırılmadan tekrar eski haline gelen toplumu biz nasıl kuracağız? Burada tabii ki sağlıklı ve dengeli çevrede yaşamasını sağlama noktasında idarenin merkezi yönetimi ve yerel yönetimlerin önemli sorumlulukları var. Geçenlerde Kayseri'de tsunami zerrin toprak deyince geliyor. Ben bu bilgiyi aktarmıştım. O zaman henüz tsunami olmamıştı. Birleşmiş Milletler Afet Riskleri Azaltılması Dairesi'nin çalışmalarına göre Türkiye'de deprem, çatışma, tsunami %30, sel, kuraklık riski var dedim. Hoca dediler uçtu galiba ama oldu. Esasen 1688'de İzmir'de de oldu. Haritadan silinen yer sarsıntısıyla 7.3 ve üstünde ve İzmir'de şu anda yok, Yenikale mevkiinde kale sulara gömülmüş. 19. yüzyılda İzmir'de doğal afetler diye bir kitapta bunu görüyoruz. Bunu ben görünce, bilim zaten biriktirilmiş bilgi demek. Depremde gösterdiler kıpkırmızı bir Türkiye. Fay hattı oradaysa, su şuradaysa, deprem varsa tsunami de olabilir dedik. Yani bunu niye söylüyoruz? Biz birçok afet tipiyle karşı karşıyayız. Ve bununla ilgili de toplumun, yerel toplulukların mukavemetini arttırmak durumundayız. Tabii ki teknoloji elimizde var ve bilgiyle beraber askeri güç, profesyonellik ve diğer kurumsal destekle beraber bazı kaynakları kullanmak durumundayız. Bunun içerisinde endüstrileşme ve rekabetçi kapitalizm bizim çalışma alanımızı zorlaştırıyor afet açısından, bazen de kolaylaştırıyor. Onun için buna fazla girmeyeceğim ama bunların her biri biraz önce söylendi, güvenlikle ilgili. Örneğin yoksulluğu çalışıyorsun, kentlerde yoksulluk. Bu afetle ilgili, ekonomik güvenlik. Gıdayla ilgili bir şeyler çalışıyorsun, gıda güvenliği. Bunların içinde bu Birleşmiş Milletler raporuna olan bir tablo. Yıldızları ben ekledim, terör var. Yani laboratuvarda oluşturulmuş da olabilir sağlıkla ilgili konular. Ve içimizde herhangi biri de, yani kamu yönetimi, o kaotik ortamda vatandaşın ya da yerleşik halkın, vatandaş olur olmaz, yabancı da olabilir, ıstırap çekmemesini sağlayacak hamleler yaparken artık bir realite var. Konuşmalarda da gördünüz, terör de ister yurt içinden gelsin, ister yurt dışından gelsin, hatta orada da olsun. Birçok Avrupa'da da görüyoruz. Virüs gibi o ülkeden bu ülkeye sıçrıyor ve kendi vatandaşı. Dolayısıyla biz artık idareciler olarak bunu da düşünmek zorundayız. Çevresel bozulmanın sağladığı doğal afetler, yoksa bizzat çevre kirliliği doğal afet değil biliyorsunuz ama afet kirliliği dehşetli bir kirliliğe yol açabilir. Bu arada fiziki şiddet, suç, aile içi şiddet, mutsuz toplum, kişi güvenliği açısından sorun alanı ve kaotik ortamda sorun olabilir. Toplum güvenliği açısından etnik farklılıklar, dini farklılıklar, kimlik tabanlı gerginlikler ve terörizm bunun içinde sorun alanı olabilir. Politik güvenlik, insan hakları ihlalleri sorun olabilir. Bizde şöyle bir ifade var kamu yönetiminde. O da nedir? Hizmetlerde etkinlik ve demokratik katılımın birlikte sağlanması. Şimdi ben bozulma olduğunu biliyoruz. Bunu tekrarlamak gerekmiyor ama kurumsal sürdürülebilir başarının yönetiminde biraz önce söylediğim inançlar, değerler, kişisel özellikler, çevresel faktörler, kurumsal özellikler, devlet boyutuna çıkan özellikler ve mevzuat düzenlemeleri, kurumsal stratejiler, amaçlanan çıktılar, kalıcı etkileri, kurumsal sadakat, kurumsal imaj, devletin imajı, vatandaşın sadakati gibi kurallar bütünü içinde yönetim hareket ediyor. Yönetim dediğinde planlamadan kontrole kadar olan süreç. Bunun içinde planlama, personel alma, raporlama, ki burada çok eksiğimiz var raporlamada, bütçeleme, denetim, bütün bu konular kamu yönetiminin klasik temel konuları. Ve yine bunun içerisinde personelin verimliliği, merkeziyetçi yaklaşım, hiyerarşik denetim veya geniş tabanlı denetim, yürütmenin denetimi, siyasetle ve yönetimin ayrılması gibi kamu yönetiminin klasik duruşları var. Ben bu sunumumda şunu demeye çalışıyorum. Kamu yönetiminin planlamadan kontrole kadar olan süreci içerisindeki tüm aşamalarında biz katılımı istiyoruz. Ama klasik yönetim afet yönetiminin temelinde yer alıyor. Çünkü nihai olarak idari ve siyasi ve cezai sorumluluğu olan birine dönüp bakıyoruz. Çünkü biraz önce saydığım çok farklı güvenlik konuları var, ihtisaslaşmış konular ve bunlar kamu yönetiminin üzerine gitmesi gereken özellikli konular. Dolayısıyla danışma mekanizmaları, evet, planlama sırasında, afet öncesi, sonrasında sivil örgütlerin destekleri gibi konular son derece önemli ama bunların her birinin tekrar sıkı bir güvenlik kontrolü içerisinde yapılması gerekiyor. Yansıdaki süreç tablosu bana ait. Afet Yönetimi Anabilim Dalı sayfasında var. Kitaplarımız da var orada, 2 tane indirebilirsiniz rahatlıkla. Ve burada bütünleşik afet yönetiminde riskin ve krizin birlikte artık düzenlendiğini görüyoruz. Dolayısıyla yerel yönetimlerin mevzuat düzenlemelerine baktığımızda hem öncesi planlama, arazi planlaması açısından baktığınızda hem de sonrasının başlangıçta riskin olasılığını saptama hareketlerini risk analizlerinde görüyoruz krizin. Dolayısıyla krizle ilgili olarak da şu kavun içi de gördüğümüz alan yine Türkçe literatürde benim ilk defa vurguladığım hızlı chat kavramı var. Yani chat atlatmak ustası olan bir ülkenin chatleri atlata afet riskleriyle karşılaşacağını söylüyorum. Bunun için iyi bir chat planlaması veya stratejik çevresel değerlendirme afet yönetimi açısından hazırlık çalışmalarının iyi yapılması anlamına gelir. Dolayısıyla chat ve hızlı chat uygulamalarını yine internetten adımla bulabilirsiniz. Şimdi vaktim kısıtlı fakat bu basılacak. Sadece şunu demeye çalışıyorum. Evet, kamu yönetiminde biz demokrasi, yönetişim, katılım, ben yerel gündem 21 stratejisyeniyim. Onun için Allah kahretsin yönetişim diyen öğretim üyelerinden ayrılıyorum. Yönetişim çok önemli. Kamu, özel, sivil, ortaklı, katılım ama afet yönetimi için klasik yönetim süreçleri devrededir. Biraz önce söylediğim gibi kimse danışıldığı için cezai sorumluluk üstlenmek istemeyecektir. Nihai karar alıcı kimdir bu? AFAD İl Müdürü, yürütme organı, merkezde, il bütününde vali ve merkezi düzeyde de AFAD Başkanı ve Başbakan'a giden oklar şimdi nedir? Nokta iken direkt çizgi olarak yani doğrudan sorumlu olarak Cumhurbaşkanı'na doğru yönelmiş oldu sorumluluk itibarıyla. Dolayısıyla kamu yönetiminin nihai karar alıcıları rolünde olan kişilerin bu izleme, değerlendirme, denetleme konularında diğer faktörler biraz önce yansıda görüldüğü gibi kurumsal sadakat, liyakat ilkesi vesaire olmak üzere dikkate almaları gerekiyor. Bunun için de uluslararası modeller de önemli. Şunu söylemeden geçemeyeceğim. Geçen yılda AFAD bir toplantı yaptı Ankara'da ve o konuşuldu. Bütün bakanlıkların strateji planlama çalışmasında yer alması gerekiyor. Hala değişiklik olmadı. Olması gereken diğer bakanlıklar kadar önemli olan Bilim Teknoloji Bakanlığı, Çalışma Bakanlığı ve Gençlik ve ilgili bakanlık. Gençlik, spor, top, ot değil. Gençlik ondan istifade edeceğimiz insan kaynağı. Bilim de öyle. Çalışma Bakanlığı açısından da öyle. Dolayısıyla bu sistemin bütün bakanlıkları içine alacak şekilde planlanması gerekiyor. İster il genel idaresi kanununa bakalım. Bucaklar kalkmış olmakla beraber kanunda duruyor. Her günde yeni bir idari düzenleme olabilir. Anayasa korumuyor çünkü idari yapıları. İlla bu yapı olacak demiyor. İl diyor, belediye veya köy diyor. Onun için bütün yapılar anayasaya göre çok korumalı değil. Belediye kanununda görüyorsunuz yansıda da acil durum planlarının hazırlanmasıyla ilgili il ölçeğinde işbirliğine yönelik öncesi ile ilgili önemli düzenlemeler var. Belediye zabıtasının, itfaiye acil durum planlamasının çok önemli görevleri var. Hazırlıkla ilgili plan yapar, ekip donanımı hazırlar diye. Mahalle yönetiminde mahalle çok önemli. Mahalle belediye yönetimlerinde vardır. Dolayısıyla belde sakinlerinin herkesin yani mahalle müşterek nitelikteki ihtiyaçlarını karşılamak üzere kurulan bu modelde halkın yerel mahalledeki herkesin yabancı olabilir, vatandaş olabilir, herkesin burada katkı sağlanabilecek hukuki düzenleme var. Büyükşehir şu anda büyük şehirlerimiz 30 tane ama giderek artacağı düşünülmekte ve büyükşehir belediyelerinin de gördüğünüz gibi gayri müesseselerle ilgili konutlarla ilgili belediyelerin de öyle 5393 veya 5216 çerçevesinde gerçekten öncesi yardımların dağıtılması vesairesinde sonrasında valinin de afet sırasında kontrolü altında çok geniş bir görev ağı var. Peki o zaman AFAD İl Müdürü ve Vali bu görevlerini ne kadar yerine getiriyor? Şunu demeye çalışıyorum. Yani biraz önce söylemiştik, hazırlık çalışmalarına ilişkin olarak belediyelerin sahip olduğu bu görev ve sorumlulukları çerçevesinde AFAD sisteminin hem il hem merkezi düzeyde bir de GAMER kuruldu biliyorsunuz 2017. Şu anda ne kadar faaliyetleri var işlevsel bilmiyoruz ama yönetişim formatında kurulan ve son derece önemli güvenlik odaklı bir sistem içerisinde yer alan bir birim. Şunu demeye çalışıyorum, belediyelerimizin görevlerini, kanunda yazılan görevlerini ne kadar afetle bağlantılı yerine getirip getirmediği bugüne kadar sorgulanmış değildir. Sorgulanmasının zamanı gelmiştir, geçiyor bile. Dolayısıyla merkezi yönetimin taşra teşkilatının başındaki valinin çok yönlü görevleri içerisinde afet ve acil durum görevleri de var. Hizmette aksama ile ilgili de görevleri var. Dolayısıyla bir an evvel görevlerin yerine getirilip getirilmediği ve düzeyleriyle ilgili sorgulama formlarının oluşturulması gerekiyor. Benim belediyelerde öğrencim var. Diyorum ki öğrettiğimiz bilgileri ne kadar uyguluyorsunuz? Bize hiçbir şey sorulmuyor diyor. Tabii ki idare kendine ait bir takım görevleri idare ederken yerel yönetimleri kastediyorum. Yapıyor ama teyidi gerekiyor. Dolayısıyla bunu bir eksiklik olarak ortaya koymuş oluyorum. Dolayısıyla bir bu boyutu var. Diğer bir boyutu da kalifiye personel olma. AFAD İl Müdürü kalifiye, vali öyle kurallar gereğince ama AFAD Başkanı'nın kariyerle ilgili konulardaki yasal olmazsa olmazları kaldırılmıştır hukuki düzenlemeden. Bunu bir eksiklik olması açısından büyük bir biraz önce söyledik, güvenlik açığı olarak görüyorum. O nedenle özellikle güvenlikle, yani adı güvenlik, afet dediğin güvenlik. Güvenlikle ilgili birimlerin kariyerden gelen tecrübeli, bilgili kişiler olduğunu biliyoruz. Onu yönetenlerin de öyle olması gerektiğinin mevzuatta görünür olması son derece önemli bir konu. O kadar çok yapılacak iş var ki kamu yönetimi açısından haberleşme ağları, can kaybının en aza indirilmesi, ölülerin, yaralıların yakıntı altından çıkarılması, tıbbi yardımlar ki bu toplantının konusu. Dolayısıyla her yapılan iş yönetimin bir parçasıdır. Bunu kabul etmek gerekir. Her yapılan iş, bu sırada elde edilen tecrübe yönetimin bir parçasıdır. Bu nedenle bu sistemlerin doğru kullanılması, tehditlerin saptanması açısından bizim öğrenilmiş derslerimizin yazılı hale getirildiği dokümanlar oluşturmamız gerekiyor. Burada olmamalı. Sen orada olmayabilirsin. Bazen hizmet içi eğitimlere gidiyoruz. Diyor ki memurlar, personel, müdürlerin işi vardı, ben geldim. İyi yaptınız diyoruz biz de. Çünkü müdür belki o sırada orada olmayabilir ama sen orada olacaksın. Bununla ne demek istiyorum? Yani yönetim ağları içerisinde herkese, ister yönetici olsun, ister müdür veya yönetimin çeşitli aşamalarındaki personel, dolayısıyla bunların her birinin, sizin her birinizin öğrendiği konular ve bunları aktarmanız son derece önemli. Afetlerde erken uyarıdan bahsedildi, son derece önemli ama tabiat bazen aldatıyor ve biz beklentilerimizin karşılığını alamıyoruz. Yağmurun geleceğini bilsek de fırtına ile geldiğinde şiddeti değişiyor ve zayıflıyor veya artıyor. Dolayısıyla şundan vazgeçelim. Bir klasik öğretimimize sıkı sıkı sarılmaktan vazgeçip yeniliklere açık olarak bilgimizi afet yönetimi itibarıyla nasıl güncelleyebiliriz ve her disiplinde bunu nasıl yapabiliriz? Bunu gerçekten son derece önemli. Bir de bilgilerimizin raf ömrüne bakmak gerekiyor. Öğrendiklerimizin de uygulandığını görmek gerekiyor. İlk konuşmada yansıda vardı. Mezarlıkları gösterdiler. Toplantı mekanları, afet sonrası toplanma mekanları diye. Birçoğumuz bilmiyoruz toplantı mekanlarını. Çoğu da bir şekilde kamu yönetiminin bizzat eliyle değiştirilmiş olduğu için gerçekten bizim işimizi doğru yapma gerektiğinde, işte klasik yönetimin öğretisinde bu var. Öyle değil böyle diyebilme gücünü kendimizde görmemiz son derece önemli. Biz eskiden öğrencimize bürokrasiyi anlatırken büroların egemenliği, olumsuz yanlarını anlatıyorduk. Şimdi keşke büro olsa, kresi olsa egemenlik ve bürokratlar direnebilse diyoruz. Onun için kamu yönetiminde bilimin desteklediği, tecrübenin istemediği konuların mutlaka kurumsal sadakat anayasada da vardır, her yerde vardır, devlet memurları kanununda da vardır. Dolayısıyla misyonumuza ve vizyonumuza uygun şekilde güvenliğin bütün boyutlarında hızla kendimizi yenilememiz ve belli bir ekip çalışması içerisinde olabilmemiz, zihnimizi buna hazırlamamız ve teknolojinin bütün imkanlarından istifade etmemiz son derece önemli. Nihai olarak bu bizim Yerel Gündem 21 sloganımız. Yani 21. yüzyılın gündemi, bir tanesi de maalesef afetler. Yeni bir bilinç, kentine sahip çıkma, yeni bir anlayış, çözümde ortaklık, yeni bir davranış, aktif katılım hepimizin takip etmesi gereken temel prensipler diye düşünüyorum. Madem ki klasik yönetimde yönetici çok önemli, onun için yöneticinin bilgili ve kariyer sahibi olması, etrafındaki uzmanların da yine gerçekten uzman nitelikli kişiler olması, çok yönlü olması ve uzman sendromuna da bir taraftan kapılmaması gerektiğini, çok tehlikeli olduğunu söyleyerek sözlerimi tamamlıyorum. Tabii ki sorularınızı açayım. İlginize teşekkür ederim. Olarak hazırlanmıştır. Uygulamada bir kadın ve bir erkek el sıkışıyor, yoktur. Bunu biz hazırladık. Böyle olması gerekir. Toplum kadını ve erkeğiyle bir bütündür. Dolayısıyla sevgili arkadaşlar, ben yerel yönetim mevzuatı ve bağlantıları üzerinde bu kısa zamanda söylemeye çalıştım ama yazılı olarak da erişebilirsiniz. Kitapçık basılacak. İkinci konuşmacımız İsmail Hakkı Turunç Bey. Kendisi özelliklerini nasıl istiyorsa ve konuşmasını kendi takdim etsin. En iyi takdim eden kendisidir diye. Buyurun efendim.
Kıymetli konuklar, öncelikle hepinize saygılar sunuyorum. Bu organizasyona katıldığınız için de ayrıca teşekkür ediyorum duyarlılığınızdan dolayı. Hocama çok teşekkür ediyorum. Zaten gerek hocamın, gerek Gökhan Bey'in ve şahsımın anlatacağı, paylaşacağı hususlar hep ortak hususlar olacaktır. Dolayısıyla hocamın çok güzel hazırlamış olduğu ve sunmuş olduğu ve bilimsel bir tabana da tutturduğu, her birimize ışık tutacak bu değerlendirmesi ve sunum için de kendisine teşekkür ediyorum. Ben Kızılay Genel Başkan Vekili olarak hem Kızılaycı kimliğimle hem de İstanbul Büyükşehir Belediye Başkan Danışmanı kimliğimle sizlere takribi 20 yıla yakındır afetlere yönelik operasyonun bizzat içinde olan birisi olarak sizinle bilgilerimi ve tecrübelerimi ve temennilerimi paylaşmak istiyorum. İstanbul özeliyle alakalı Gökhan Bey gerçekten bizim çok değerli bir arkadaşımız. Kendisini her zaman zevkle dinliyoruz. İstanbul'a yönelik yaptığı çalışmaları yakinen biliyorum. İstanbul özelindeki rakamlarla alakalı eminim kendisi yapılan çalışmalarla alakalı çok özel bilgiler bize sunacak. Ben biraz dünya ölçeğinden bahsetmek istiyorum. Yaşanan sıkıntılardan bahsetmek istiyorum. Ya dünyanın hangi ülkesidir bilmiyorum. Yani Japonya'ya gitmişim bundan 5 sene kadar önce Sydney'de bir tsunami sonrası oluşan bir riskten sonra yardımcı olmaya gittik. Belki Japonya'nın ihtiyacı var mıydı yok muydu o tartışılır ama Japonlar biliyorsunuz Türkiye'nin her zaman afetlerde ve diğer konularda da bir gönül bağımız ve duygusal bağımız olduğumuz bir devlet ve ülke. Biz de tabii insani noktada sıkıntılarında yanında olmamız gerekirdir diye hem Kızılay kimliğimle hem İstanbul Büyükşehir Belediye Başkan Danışmanı kimliğiyle oraya gitmiştik. Gittiğimizde gördüğümüz manzara gerçekten bir hazırlık içerisindeler ama ne kadar gelişmiş ülke olursanız olun hesabınızı bir yere göre yapıyorsunuz. Belli bir standardı var. Hatta standardın yani riskin en doruk noktası, en tepe noktası neyse ona göre altyapınızı yapıyorsunuz. Ona göre tsunami'ye yönelik önlemler alıyorsunuz. Hatırlayabildiğim kadarıyla siz de yakından takip etmiştirseniz yani sahilde bir nükleer santralın Sadna denilen bir şehirdeydi. 6 metrelik tsunami dalga kırıcı yapmalarına rağmen 7-7,5 metrelik dalgalar geldi. Yine o nükleer santralı tsunami bastı ve çok ciddi manada ülkede bir risk oluştu. Tecrübeleriyle, bilgileriyle çözdüler ama yaşadılar sıkıntı. Şimdi bir tarafta çok gelişmiş ülkeler, hazırlıklı ülkeler, depremin her türlüsünü afet, yanardağ patlaması, aşırı yağışlar, heyelanlar gibi nükleer santrallerle riskler gibi her noktada hazırlığını yapan ülke de olsanız yine hesabınızın üzerinde farklı bir tabloyla karşılaştığınızda fırtınalar gibi ABD işte görüyorsunuz son birkaç aydır hatta birkaç yıldır yaşadığı sıkıntılarla birçok manada aşamıyor sıkıntısını ve problemini. Belki de eksikliği kimse görülmesin diye uluslararası yardım çağrısı falan da açmıyor. Yani biz oraya da yardıma giderdik. Gerek Kızılay olarak gerek Türkiye'deki kurumlarımız olarak ama uluslararası yardım çağrısı açmıyor. Gerçekten hakikaten doğal afetlerin boyutu sizin hesabınızın üzerinde gelişiyorsa bunu aşmanız mümkün değil. Burada aslında ülke yöneticilerini falan da yani bir nevi eğer hazırlığı yoksa çok iyi niyetli olursunuz, hazırlık yaparsınız ama sizin hesap ettiğiniz yani günde saatte metrekareye 80 kilometre düşecek diye hesabınızı yaparsınız ama 180 kilometre düştüğünüzde buna ne yapacaksınız? Yani sizi de aşan, yönetimsel olarak sizi de aşan, hazırlıklarınızı aşan bir tabloyla karşı karşıya kaldığınızda aman şu şehirde neden bu noktada, şu ülkede bu noktada demek çok biraz insafsızlık olur diye düşünüyorum. Dolayısıyla iki gruba bölüyorum ben ülkeleri. Sizden de takdiriniz bu doğrultudadır diye düşünüyorum. Bir hakikaten istikrarlı bir ülke, ülkesinin gelişmişliğiyle, kalkınmasıyla alakalı ve her türlü risklere yönelik hazırlıklarını yapmış, bireysel olarak insanları afetin her şekline hazırlamış, ilk yardım eğitimlerini vermiş, bütün hazırlıklarını yapmış, kendi altyapısını oluşturmuş, müdahale ekiplerini oluşturmuş, çok bilinçli bir şekilde bir ülke düşünün. Ama diğer bazı ülkeler var ki kaç tane ülke sayabilirsiniz dünyada bu noktada hazırlığını yapmış olan. Her zaman risk yaşamış olmasına rağmen genellikle kıyı ülkeleri ve ada ülkeleri tsunami'den, aşırı yağışlardan veya çok şiddetli depremlerden etkileniyorlar. Kaç tane ülke bu noktada hazırlık yapmıştır? Ben dün 12 itibariyle Bengaldeş'ten döndüm. Arakan'dan 800 bine yakın göç eden insanların bulunduğu kamp da değil aslında. Yani ormana sığınmış, çok ilkel bir vaziyette yani insanların da çok zor yaşayacağı ortamlarda 800 bin insanın yaşadığı bir bölgeye geçtim. Bengaldeş'in zaten bu konuda çok ciddi sıkıntısı var. O sıkıntının üzerine bir de 800 bin kişi gelmiş ve bilgi ve tecrübeleri çok fazla ileri. Ben bir ülkeyi suçlamak, devleti, yöneticiyi suçlamak adına değil de realiteyi paylaşmak adına ifade ediyorum. Dolayısıyla 800 bin insan da yük gelmiş. Kendi ülkeleriyle alakalı zaten her yıl onlarca kez yaşadıkları muson yağmurlarından dolayı çok ciddi sıkıntılar ve altyapısını oluşturmayan bir ülke ve ekonomik olarak da çok iyi noktada değiller. Sanırım ülkenin iç siyasi meselesini sormadım, bilmiyorum. Siyasi istikrar var mı yok mu onu da bilmiyorum ama gördüğüm tablo gerçekten vahim. Biz Kızılay olarak ve dünyadaki sivil toplum kuruluşları olarak ülkelerin, ülke yöneticilerinin, devlet yöneticilerinin, kamu yöneticilerinin biraz önce hocamın ifade ettiği gibi müdürü çağırıyoruz bir toplantıya, müdür yardımcısı, şef gelmiş, bilmem kim gelmiş. Ben küçümseme kastıyla söylemiyorum. Hiyerarşik yapı içerisinde devlet kurumlarına, kamu yönetimine saygı duyuyorum ama müdürün bilmesi gereken bir konu, bir daire başkanının bilmesi gereken, bir genel müdürün, bir genel sekreterin bilmesi ve ehemmiyet göstermesi gereken bir konuda efendim müdür gelmedi, şef geldi, şef gelmedi, ustabaşı geldiyle falan olmaz. Böyle bir mantık olmaz. Ne Türkiye'de bu noktada çok ciddi var. Ben de yöneticiyim. Burada varsa benim de payım. Yani ben kamudan, toplumdan özür diliyorum ama bu bir realite, bu bir gerçek. En üst noktada ilgilenmek zorundayız. En üst noktada takip etmek zorundayız. Böyle takip etmediğiniz takdirde duyarlı efendim anlatıyorsunuz şefe, şef gidecek müdürüne anlatacak. Müdür bilmem daire başkanına anlatacak, tedbiri alacak. Bunun için bütçe ayarlayacak. Bunun için herhangi bir efendim yasal mevzuat hazırlayacak falan. Kusura bakmayın olmaz. Ya ne biz Kızılay olarak bundan gocunmuyoruz. Dünyanın en büyük sivil toplum kuruluşlarından birisi. Bunu siz de takdir ediyorsunuz. Ama biz insanlar öldükten sonra, insanların başına büyük musibetler, afetler geldikten sonra ki öyle bir şeyimiz yok. Yakın zamana kadar vardı. İlk kurtarma ekibimiz vardı. Daha çok barınma ve beslenmeye yönelik AFAD'ın yanında efendim bir rol üstleniyoruz. Ama biz yani insanlar işte ölmüş, geride kalanlara yemek veren, geride kalanlara barınmasını sağlayan bir fonksiyon üstlenmek istemiyoruz. Bu konuda Türkiye olarak biz ne tedbir alacaksak devlet olarak